Good morning, Dr. Rod. This is Rucha.
Oh, good morning, Richard.
Hi.
Early start.
Yes, actually, can we just wait for about 5 minutes and then we can start? Not an issue.
Sure. Yeah,
Dr.
that's okay.
Ramanna has not yet joined. I think he is going to be there for the first session, right?
Yes, so he's got things to say, as do I. Thanks.
Yes. Also, I just got a message. You mentioned that Dr. Ken's talk.
Yeah, he's got two. The one that he's got on the program, and then in the final session, after the introductions, he's going to speak for about 4 or 5 minutes about Gore, and then we'll go on and do the other pre-recorded talks.
Just a second, sir. Just a second.
Yeah, just at the last sessions, I will just share my screen for about 5 minutes, just for a few slides of code. I'll keep it short and simple.
Okay, so it's a different presentation that you are going to be showing.
It's a different presentation.
Okay,
So
it
I
does
haven't
not
sent it
collide
to
with
you.
your session, the other session, right? This is a different one altogether.
No, the other session I sent you already.
Yeah.
So it's recorded, you should have it. And I'm just going to sort of plug in 5 minutes. Originally, they want 20 minutes, which is probably too long, I think.
Yeah, no problem. That should not be a problem. I was just thinking, in case I have to shift your previous talk here or no, just wanted to get a clarity on that. But you have a separate slides to show. That's completely fine.
I have separate slide. Maybe if I send it to you now, maybe you can play it as well. But I'll just speak live on it. So I haven't have it recorded yet. Maybe do you want me to record it now in between time and send it to you?
That's fine. You can just share screen and share the slides. That should not be an issue.
Okay, thank you.
Harsha's going to introduce Gore and you, and then you can speak, and then we'll go on to do Dr. Karatas's pre-recorded talks and all the others.
Yep, no, thank you. Thanks. I'll be out for dinner as well. So just after that, yeah.
Romana.
Hi.
Hi.
Good morning.
Good morning.
Are we good to go?
Yeah, I think we're good to go. Rush, are you happy? Okay. Can I share my
Yes.
screen?
We
would you like
probably
to
have
put it on?
8 more minutes left, I think.
Yeah. We might sort of get started in a second.
Todd has only one M to his name.
Okay.
Hello, everybody.
Hey, good morning.
Good morning.
Good.
New acquisition.
Hey, it's been there for a while. Everyone was surprised because I had a mask on most of the time, and then I took it off.
That's
It was like Wolfman Paulie over here. He's probably been hiding that behind a mask.
Yeah, I just stopped taking care of COVID patients that I can have any kind of beard that I want. I don't need to wear N95s anymore. It's great.
Oh, really?
I got a call this week about putting a feeding tube in some COVID patient, and I was like, am I gonna have to shave? Because if I do, they don't really need a feeding tube that badly. And the guy refused and went home without one. So I was like, okay, cool. I can keep my beard.
And of course, we've got a beautiful new strain of COVID coming out of Africa.
Right. Rucha, are we actually live? Is the program
Yes,
on?
we are live.
Oh,
Yes,
we are
we
live.
are.
On the so,
Yeah.
Rod,
Well,
please.
let's get started then. Good afternoon from the east coast of Australia. Good morning
We
to
really
India,
hear you, Rod.
in the rest of the world. So we have a great lineup today, and hopefully we'll cover the things that we don't often get to talk about the complications, and then hopefully we'll talk about how you can predict those, and then what sort of things you can do to perhaps stop getting complications, and finally how you might be able to treat them if you do get them. So we've got speakers from Australia and in India, the United States and Europe. And I'd like to welcome my co-host, Dr. Romana B, to say a couple of quick words before we get into the program.
Thanks, Rod. Yeah, actually, the first two Anzawr meetings have been so well received that we thought that next one should be on something very impactful. And we've got a host of speakers with deep insight into the subject. So I can't wait to start. So let's go.
Just to remind the people when they join to keep their phones on or their microphones on mute. If you have any questions, you can type them and we'll put them to the speakers at the end of the session. And finally, if you can go to the sponsors, because without them we can't do these talks. The sponsor of this session is Baxter. Baxter, of course, make a lot of products that our colleagues, the anaesthetists, use, that which we can't operate. And then the ones that we use surgically, hopefully we don't need to use flow seal too often, but many of us use TCL as a tissue glue. So the first speaker is Keith Tansey. He's a burns, trauma and hernia surgeon from Queensland. He has a pre-recorded talk. Take it away.
Rod, you'll have to do something about your sound quality. It's terrible.
Can we start with the first talk?
My understanding was it's being run by the host.
Yeah, it should come on, Keith, but you got to unmute yourself.
Can someone confirm, am I operating it from my end, or is it being driven by the events host?
No, it'll come on, Keith. Just wait.
Right.
Smile and wave.
Can Wama take care of this? Dr. Tausey's talk isn't coming in. Does he have the rights to share his screen? Okay, so they're starting in 2 minutes. That's what they said. Yeah, all right, good.
Good afternoon, everybody. Keith Towns is my name. I'm one of the surgeons here in Brisbane, Australia. I'm, for those who don't know me, I'm a trauma and burn surgeon with an interest in complex abdominal wall reconstruction. I have a practice based both at the Royal Brisbane Hospital and I'm also the chair of surgery at St Andrew's War Memorial Hospital. I'd like to thank Rob Jacobs for asking me to speak this afternoon, and I have the honour of being the first speaker today, and hopefully will not steal the thunder of too many of our subsequent presenters this afternoon. But my presentation today is just covering off on some of the more common complications following open ventral hernia repair. So ventral hernias represent quite a significant disease burden within most communities. Just under half of ventral hernias are considered to be incisional in origin, and incisional hernias form within 25 to 39% of patients undergoing laparotomy. The open repair of ventral hernias carries not insignificant morbidity, particularly with concerns around mesh infections, recurrent wound complications, including both superficial infection and fascial dehiscence, the development of seromas, enterotomy, compartment syndrome, and chronic pain. And these complications we'll look at a little bit this afternoon. There are several presenters later on in the day who are going to look at some of these in more detail, but we'll cover off on some of the basics now. Wound infection is the leading complication for ventral hernia repair, affecting about 15 to 30% of patients. And we've all had patients who have developed some form of wound infection after surgery. It's classified as, by the CDC as an infection within 30 days of surgery. And the risk factors for developing a wound infection include obesity, diabetes, smoking, prolonged operative time, gut violations, these are both planned and unplanned violations of the gastrointestinal tract, patients who are concurrently taking steroids, and chronic renal failure. Wound infection is an implicated risk factor for the development of recurrence, both associated with deep and superficial infections, and mesh infection is associated with deep space infections. Antibiotics, beyond that which is used for prophylaxis, has not been shown to reduce the incidence of wound infections, even when antibiotics are carried on beyond the initial prophylactic dose at the time of induction. The management of wound infection really depends on how severe the infection is and where it's located, whether it's superficial or deep. So for superficial infections such as cellulitis, which would be the majority of our patients, these can generally be managed by broad spectrum oral antibiotics. If we have swab results, we can use these to tailor the antibiotic regime to suit appropriate sensitivities. And generally these patients will have their infection resolved within 7 to 10 days. For deep space infected collections such as postoperative seromas or hematomas, we typically need to increase the amount of intervention to resolve these problems, and this often involves hospitalisation, the commencement of intravenous antibiotics, and drainage of any collections need to be considered. This is photos of a patient of mine who developed a large infected seroma after his abdominal wall reconstruction, and this was successfully managed by a percutaneous drain with complete resolution of his sepsis. Other patients, however, may require open drainage, and if there's any necrotic tissue involved, this may in turn need to be debrided and managed with a vac dressing. Mesh infections is one of those things that we all fear, and is one of the leading concerns about the use of implants for the management of hernias, particularly incisional hernias. And these patients will typically present with pain, fever, a draining sinus, or erythema involving their wound, and can be classified as either early or late presenters. The majority do not present early. The median time to presentation is approximately 27 months, with a median of 3.5 months to time to presentation. Of these, about half will be more than 90 days after their index operation, 40% after 6 months, and a third after a year. Early presenters will typically have some other adverse event which needs early intervention, such as a missed enterotomy, a leak, or a fistula. The management really depends on the timing of the patient post-op and the severity of their sepsis. Early presentations or very septic patients will often require urgent surgical management, typically through the drainage of abscesses or debridement of wounds, as we've mentioned previously, explantation of permanent mesh, the use of broad-spectrum antibiotics, and the management of any underlying cause, such as the missed enterotomy or fistula. For patients who have a delayed presentation, they may be amenable to a more conservative approach, and this will typically involve the use of percutaneous drainage of any collections and the use of prolonged antibiotics. The thing to remember though, if you have frank pass on drainage, it's very unlikely going to be able to salvage a mesh in this circumstance, and often will proceed to surgical management. The use of prolonged antibiotics is key. However, there's no evidence really for how long we should be using these antibiotics. If you look at the studies, depending on which paper you read, it's anywhere between 4 weeks to 6 months. And in my personal experience, we generally require around about 3 months worth of antibiotics until we see a normalisation of the patient's C-reactive protein. Once this is settled, we generally find that the patients remain well. However, some patients will require permanent long-term suppressive antibiotics to maintain their sepsis suppression, and the use of antibiotics to achieve this is really guided by the use of cultures and antibiotic sensitivities. Looking at the outcomes or the success of non-operative management, and I'd have to thank Todd Henneford, you'll see him referenced a few times during this presentation, but Todd's team over at the Carolinas Medical Center looked at this particular question in 2015, and of the patients in their study, they found that the average time to infection from time of surgery was approximately 31 months. Initially, all patients on their study were managed non-operatively, but of these, 86% of patients subsequently failed non-operative care, which is give you an indication of the poor success rate with non-operative management of mesh infections. 16% of these patients subsequently were proven to have fistulas, and of those who fail, the majority, or if you were a smoker, you failed non-operative care. If you had a polyester mesh, you failed non-operative care. However, if you had polypropylene mesh, this was salvageable in 29% of cases, and this 29% also includes patients who remained on permanent long-term suppressive antibiotics. When we break that down into types of polypropylene, those with lightweight polypropylene meshes had a relatively good success rate, about 39% of salvage. However, if you've had a heavyweight mesh, your chance of salvaging that situation was less than 2%. Likewise, patients with PDFE, though we don't see many of them these days, again, the success rate was less than 8%. So if our patient fails non-operative management, clearly we now need to look at an operative solution to the problem. And the primary thing to think about is, why has this patient got persisting infection? Is it biofilm that's got onto the mesh at the index operation, or is there the presence of a bowel fistula or a mesh erosion which is driving the sepsis? And operative management really needs to revolve around excluding the presence of mesh erosions, and then to planning an operation where we aim to explant the entirety of their mesh. Ideally, you want to try and avoid partial debridement of meshes. Typically, that mesh which is left behind, though it looks well incorporated and healthy at the time of surgery, will often contain a biofilm which is not detected at that operation and leads to ongoing sepsis, even if the patient makes initially a good recovery. We need to think about how we're going to control the defect once we remove the mesh. Is there a plan to redo a reconstruction with a bioabsorbable or a biological mesh, or is there a plan to primarily close it or leave it as laparostomy with a plan for a later definitive reconstruction once the sepsis is resolved? Prevention is often better than cure in these circumstances, and a large part of it has to do with good preoperative optimization. Again, this topic will be covered in more detail, but briefly, we need to make sure that patients will lose weight. They need to stop smoking, control their diabetes, and have good nutrition. And certainly in my practice, we exclude all patients with a BMI of 40 or over, active smokers, or uncontrolled diabetes from elective reconstruction. Operative planning, again, is key, and Todd will talk about this further shortly, but we need to think about what is the correct selection of mesh based on the patient's risk profile and hernia stage. Can we stage this procedure if we're involving the gastrointestinal tract during the time of the operation? Is it suitable for a concurrent repair? If so, what type of mesh will we use? Versus a staged or two-step approach where the gut is corrected first, followed by a hernia repair at a later date. Certainly, again, there's some good evidence from Todd's group that would suggest a concurrent repair with a bioabsorbable mesh will often give better long-term results and less morbidity compared to a staged approach. However, each time, each patient needs to be tailored to their particular needs. Prophylactic antibiotics is mandated in most of these operations, and ideally we want to base the use of the prophylactic antibiotics on the cultures from previous infections if there's been any. The operative technique needs to be appropriately selected, ideally avoiding enterotomy, minimising seromas and hematomas, and there may or may not be a role for drains. Moving on, talking about drains is seromas. And seromas, as we've mentioned previously, are associated both with mesh infections and with superficial infections, and they affect up to a third of patients undergoing open hernia repair. The good news is that 8% will resolve within 3 months of surgery without requiring intervention. A further 15% will resolve with aspiration, and less than 5% will have ongoing collections which require ongoing drainage and subsequent infection. Seromas are much more common after larger open component separations because of the raising of large skin flaps to do these techniques, and there is some mixed data that suggests that seromas are much more common with biological meshes than other types. So clearly, trying to minimise seroma through a good operative technique and mesh selection is key. Aside from this, prevention with the use of drains, unfortunately, is not really supported by evidence. I certainly do use drains after transverse abdominis releases and open component separations, but I don't use them for retrorectus repairs. The Cochrane database from 2013 failed to find any evidence to support or deny the use of drains. Again, Todd's group a couple of years ago looked at the use of talc sprayed intraoperatively to reduce seroma rates, and they had some success. And again, the use of Tisseal, there's been some conflicting evidence, predominantly around the use of to seal to prevent seromas after abdominoplasty with plastics. However, its role for elective ventral hernia repair remains controversial. Enterotomy is, again, one of the challenges associated particularly with redo hernia surgery, and we find that the rates are likely underreported. Anywhere between 2 to 2.5% of patients undergoing ventral hernia repair will sustain an enterotomy. Majority of these involve the small bowel, but about 9% involve the large bowel. More worryingly, though, the injury was missed at the time of surgery in about 20% of cases. Clearly, enterotomy is associated with both a rise in mortality rate, particularly if the injury was missed, and its impact on surgical site occurrences is variable again, thanks to Todd and his group, which demonstrated 28-fold increased risk of synthetic mesh infections, a 5-fold increased risk of wound infections, and a 16-fold increased risk of recurrence. As a consequence, the Ventral Hernia Working Group recommends the placement of biologics or bioabsorbable meshes in these cases. There's been some advocates for doing a staged operation where you correct the enterotomy, wait a couple of days before doing the definitive hernia repair with permanent mesh, where there's not a lot of data to support this particular approach. Dehiscence, again, can be quite a challenge, is often underreported, and we need to differentiate between superficial and deep. Superficial dehiscence is relatively common. Thankfully, deep dehiscence is not. And the risk factors are the usual suspects of obesity, smoking, and diabetes, particularly made worse if patients taking steroids, if they already have an affected hernia, chronic renal disease. And if you're doing a large open component separation, the raising of those skin flaps and division of skin perforators often leads to flap necrosis and subsequent wound dehiscence. Thankfully, most patients only require local wound care. However, a small group, particularly those who develop a subsequent mesh infection, facial disruption, or flap necrosis, will often need to return to theatre for definitive care. Abdominal compartment syndrome, again, is a relatively uncommon problem. However, we do see it in about 20% of patients undergoing abdominal wall reconstruction. We divide them into intra-abdominal hypertension and true ACS. Intra-abdominal hypertension is broadly defined as blood pressures between 12 to 20 millimeters of mercury, and fortunately, the majority of these patients, their pressures are self-limiting and resolve spontaneously. For those with high expiratory airway pressures or pressures are greater than 20 millimeters of mercury in the bladder, management is typically intubation and ventilation, and usually resolves over a few days. Patients who are morbidly obese, the BMI is over 40 and prolonged operative time are at high risk. Abdominal compartment syndrome is intra-abdominal hypertension plus organ dysfunction and develops in about 11% of patients with intra-abdominal hypertension. It carries quite a high mortality rate of about 68%, and this is largely due to rapid end organ ischemia and necrosis. In the early stages, it's managed by intubation and ventilation with a low threshold for decompressive laparostomy if it's progressing. And again, the risk factors remain as patients with a BMI greater than 43 or operative time more than 280 minutes. Chronic pain, again, is quite a common and disheartening complication associated with open repairs with a high variation between studies. Anywhere between 6 to 30% of patients will experience pain after abdominal wall reconstruction, and the risk factors are usually associated with patients who've had pain preceding their operation, particularly if they're using narcotics pre-surgery. You can expect them to have a stormy course afterwards. Pain which persists after a month or repairs which have significant mesh eventration or fixation are often associated with the development of chronic pain. And a large part of the prevention of this complication involves minimising the need for fixation and closing the defect. So in conclusion, reconstruction of open ventral hernias can be challenging, and the open repairs in particular are associated with a variety of complications, particularly around the wounds themselves. Prevention and early recognition of complications are key to improving long-term operative outcomes. Accurate risk stratification of patients will allow us to appropriately optimise patients preoperatively, select the right procedure, and hopefully use the right mesh to minimise these complications. Are there any questions? Thank you.
Keith, thank you very much. I think we'll keep the questions until the end. We've got some time for discussion. So without much further ado, I'll get them to start running Hugh McGregor's talk. Hugh is another surgeon from Queensland, who has vast experience in laparoscopic ventral hernia. Thank you.
Thank you, ladies and gentlemen. Thank you, the organising committee, for giving me the pleasure of speaking again, and congratulations on a fantastic program. I've been asked today to talk on complications in laparoscopic ventral hernia repair. I've been doing laparoscopic ventral hernia repair for about 15 years, and I certainly have had lots of complications. So I'm going to discuss those with you today and share them, and hopefully we can learn to minimise and prevent these sometimes very serious complications. Complications essentially occur in 4 phases. The first is choosing the wrong patient. I'll come back to that later. Primarily, there's 3 issues. Complications on entering the abdomen, during the actual dissection, and after the procedure. On entering the abdomen, minimally invasively with trocars, of visceral and vascular injuries. This is no surprise. It's certainly not unique to ventral hernia repair. I think it is higher risk, however, given the fact that in laparoscopic ventral hernia repair, we need to optimise port position for the actual hernia repair, and often these hernias are incisional with a potentially a higher prevalence of adhesions than de novo surgery. I think another issue that makes laparoscopic ventral hernia repair specifically higher risk for trocar injuries is the fact that most hernias are midline, and most of our standard entry techniques for entering the abdominal cavity are also midline. So this necessitates lateral port placement, and consequently, I think there's a higher increased risk of injury to bowel vessels, other viscera. It should come no surprise to anybody here that gynecologists have the highest rate of trocar injuries. However, this is closely followed by hernia repair and cholecystectomy, interestingly. And it should also not be a surprise to anybody that intestinal injury is the most prevalent anatomical structure to be injured by a trocar, followed closely by bladder, kidneys, vascular, etc. Interestingly, someone there is putting trocars into the lung and heart, which doesn't sound very pleasant. This study from the American College of Surgeons journal from 20 years ago looked at about 630 trocar injuries. I think that's a gross underrepresentation of the probable number. But interestingly, of the deaths following trocar injuries, 20% arose from bowel injury. What they did find is that direct view trocars resulted in less trocar vascular injury, or visceral injury. With trocar injury, there's a 10% delayed enterotomy rate, and of those people, 20% or 21% with delayed enterotomies actually died. And they make that conclusion that bowel injuries often went unrecognised, in which case they are highly lethal. So it's something that we really need to manage a bit better. How I try and prevent complications during entry, I've hit most things with ports. I think, obviously, if you haven't hit stuff with ports, you haven't done enough surgery. But there are ways to minimise that, and hitting viscera and vessels and other things with ports is very unpleasant, especially if it's not recognised. I understand that in many countries, including India, it's necessary to use reusable ports. And not every country has the wealth or the luxury of using disposable ports. However, there are ports that make it much easier to get in the abdomen. And I particularly like this FIAS first entry port by Applied. It has a hole for insufflation and a very good view. Ideally, it would be good to avoid sharp ports. I think we have some other tools which are not always present, but if present, can be very helpful, such as a CT to assess presence of bowel adhesions and omentum to make planning optical entry into the abdomen easy. I now use selective use of Verres needle in a modified Hassan sort of position over here, where we exteriorize the umbilical stalk and get in with a stab incision just in the base of the cicatrix and popping in a Verres needle just a short distance and insufflating the abdomen to 15 centimetres pressure before placing the other ports in. I find that very useful. I've always been taught Verres needle is a dirty word, but it's actually a useful tool. I think with wisdom and age and experience, it's also worthwhile considering, not selecting patients with battle-scarred abdomens. This can be very dangerous. These people can have very substantial adhesions, and often one more scar is not going to make any difference to them. What I also do is I often use the upper rectus on the right as my optical port placement. I think it's very predictable anatomy with skin fat, anterior sheath, muscle, posterior sheath, extraperitoneal fat, peritoneum. And the structures lying below that are generally omentum, but potentially liver. And I think there's less chance of a significant injury, although I have hit the pancreas in that position. So, nothing's foolproof. Intraoperative complications, the most significant and severe complication in laparoscopic ventral hernia repair and or any minimally invasive abdominal surgery involving adhesions is small bowel injury. And it's obviously generally related to how extensive the division of adhesions are. As general surgeons, we're all very experienced at taking down adhesions, but obviously we know that not all adhesions are the same. And where I would spend several hours when I was a young man taking down adhesions only to find that I'd caused a bowel injury, I will abandon that very promptly now with age and wisdom, because the risk of a missed bowel injury and the consequences of that are too severe. And we know that the mortality from a missed small bowel injury is approaching or exceeding 20%. And these patients don't become unwell on day one. They become, small bowel content is pH balanced. It doesn't cause a significant inflammatory response until the second day. And often these people are at home. And early recognition of these injuries is very vital before systemic inflammatory response comes on. The most common vascular injury in laparoscopic ventral hernia repair is inferior epigastric artery injury, while the most common source of delayed bleeding is omental. As a colleague of mine said, the omentum looks like fat and bleeds like liver, and can be a very disappointing little bit of fat. Early identification of the inferior epigastrics is very important, obviously, before port placement and also putting tacks. But it does happen, and anyone who does these has hit the inferior epigastrics. Anyone who does minimally invasive surgery has hit the inferior epigastrics. And a little trick I use, if I haven't needed it for quite some time, but is to use a suture passer to ligate above and below the bleeder. Obviously, in the setting of a major vascular injury, a colleague hit the inferior vena cava with an optical port. Gynecologists have been present after they've hit the aorta. Obviously, conversion to laparotomy and appropriate management of that is important. Post-operative, early and late complications, laparoscopic ventral hernia repair hurts, and it hurts a lot. I often see people talking about their day surgery patients with lap ventral hernia repair. I keep these people overnight. They have patient-controlled analgesia. I often put subfascial local anaesthetic in, which I think works quite well. Some people have minimal pain. Some people, as you know, have a lot of pain. Tap block, some people use them, I generally don't, but certainly slow release analgesia if they've had significant discomfort. And it's important to remember that patients, even having minimally invasive hernia repair, can have ileus regardless of the approach, and often due to analgesia, pain, pneumoperitoneum, presence of blood, etc. So I start these patients on the first night on clear fluids and feed them the following day if they're proceeding well. Late complications after this procedure relate to mesh infection, seroma formation, pain and recurrence. Mesh infection, in my experience, is usually related to missed bowel injury. There are no salvage options. It has to be removed. I've luckily never had an infected mesh. I've been dragging mesh through the abdominal wall as per Nick O'Rourke's paper from 10 years ago for many years and haven't had any infections. So a seroma formation is an inevitability. It's basically the size of the seroma. Obviously, you can minimise the seroma by incorporating the sac into the closure suture to close the defect intracorporeally. They're often inevitable. Large seromas I wouldn't touch unless they were causing problems, because we don't want secondary mesh infection. Pain, I think, long-term is more related to permanent fixation. I try and avoid metallic fixation, and sometimes it's unavoidable. I think I have seen quite a few patients from colleagues who have anterior cutaneous nerve entrapment or scarring related to high velocity dissolving fixation. And I think that's something to consider as well. And also, of course, poor mesh fixation or mobile mesh causes pain. Recurrence, we're all going to get recurrences, we all have. It's important to select the correct patient, correct mesh and correct fixation. It's important to give equal distribution of fixation. It's important to remember that transfascial fixation can cause hernias by cheese wiring through the fascia, and you can, of course, get port side hernias. Coming back to choosing the correct patient, I think it's important to choose the correct patient for this surgery. Patients with minimal previous surgery, fatter in fact is better. Laparoscopic ventral hernia repair is very useful for very obese patients with small problematic hernias. And I think defects up to 5 to 6 centimetres. Previously have done defects up to 10 to 12 centimetres. I think there are better options. Obviously, it's very useful for multiple Swiss cheese defects. But I have learned over the years, the bigger the patient, the bigger the mesh and the more permanent the fixation. You can't do everything with one technique, though. It's important as hernia surgeons to have multiple things up, multiple techniques in your armamentarium. And I think it's important not to throw the baby out with the bathwater. It is a viable technique. It's very useful, and I don't think it's necessary to hop on the bandwagon of let's keep the mesh out of the abdomen. I just did this little diagram here about fixation. I think this is a big cause of recurrence because it's obviously very easy to tack your mesh with dissolving or permanent fixation on the opposite side to your ports, and I think it's important that that people balance up their fixation. And we know that from a recent work from colleagues in Germany, such as Andreas Koch, who've clearly shown that. Thank you.
Well, that was an interesting talk, as expected, because laparoscopic ventral hernia repair is such a common procedure of interest to all surgeons. It's my pleasure now to introduce a young star from India, Ahem Arora. He's teaching faculty in Mumbai's Grant Medical College, and he's going to talk on extraperitoneal approaches and their complications. Ahem.
Good morning, everyone. Let me start by saying that the adoption of MIS AWR procedures is quite unlike anything we've seen for a while. The combination of a benign pathology with the novelty of a fancy technique has promoted the rapid development and adoption of several procedures all across the world. And while all procedures have complications which are often discussed to death, sometimes at meetings like this, here are a few reasons why we need to pay closer attention to all of these surgeries and their eventual outcomes. While there is some overlap, several complications following AWR procedures are distinct from the prevalent MIS ventral hernia repair at this time, which is the lap IPOM. Now, this is particularly important for someone who's doing IPOMs right now, but is looking to transition to one of these newer procedures. MIS repairs aim to recreate the open surgical counterparts. The structures divided, spaces combined, and even the mesh is placed, they are all the same. But the steps to get there are often very different. So even though the complications I discussed here are essentially the same as in open repairs, we are creating them in brand new ways. If you think about a complication as a destination, we are taking different routes. However, MIS repairs may yet have a greater probability of iatrogenic injury than in open surgery. So we are definitely raising the stakes. I am M. Arora, and I come to you from Grand Medical College and Sir JJ Group of Hospitals in Mumbai. Let's begin. For the sake of brevity, I'm going to restrict the discussion primarily to MIS retromuscular or sublate repairs, because these are the most popular at present. And their open counterparts, the Reeve-Stropa and open TAR, already have a well-established track record, which is going to help us perform a comparison little later on. Now, complications after these procedures are not uncommon, but as I mentioned earlier, some can be quite unique. Linea alba injury appears to be a pretty common one at that. In an open procedure, one first dissects the two retrorectus spaces and then connects them. You can see each space has a right-angled retractor put within it. So the surgeon has identified both the post-rectus sheets, permitting their safe division cranially as well as caudally. In ETEP, however, the crossover to connect the spaces is unidirectional, meaning that the contralateral post-rectus sheet division is somewhat blind. Even though there are a few visual cues, it's quite easy to see how the step can sometimes produce linea alba division, which is quite high up in the abdomen and may not have mesh cover. You can see the contralateral rectus is just coming into view. In this next case, the surgeon, while performing the crossover, missed an injury in the linea alba before he actually hit the contralateral rectus muscle. You can see a lot of subcutaneous fat is actually peeking through at the top left of your screen. Unfortunately, in this particular case, this injury was not repaired and the mesh did not reach that high up to cover this. So that's a new hernia that's waiting to be repaired somewhere down the line. Similar injuries can also be seen in transabdominal approaches like TARM. In this clip, there's a distinct linea alba disruption proximal to the hernia defect that's on your screen right about now. But the surgeon here realized the error and actually landed up closing the anterior sheath in its entirety with a barbed suture and then covering it with a mesh. You can see the needle is actually going across the iatrogenic injury right now. Another notable complication that's specific to sublay injuries is damage to the neurovascular bundles, producing denervation and atrophy of the rectus muscle. This is one of my old patients who had an ETEP with a unilateral TAR for recurrent M2W2 hernia. He came back just over a year later with some vague discomfort that we couldn't put a finger on. So we decided to scan him. And the scan showed a segmental denervation of the right rectus muscle. Now, I'm not sure how much of this discomfort can be ascribed to this, but I can't quantify any functional defect that's resulting from this complication as well. So unless I find any other reason for it, I have to think that it's a rectus atrophy that's causing the problem. Another unique complication is interparietal hernias. An inability to safeguard peritoneum or closing the posterior fascia under tension may produce postoperative dehiscence, producing an interparietal hernia where the viscera comes into direct contact with an uncoated mesh. You can actually see the post-rectus sheets on your screen just lift down like a mesh. Now, this may not be a true recurrence, but it definitely predisposes the patient to all the possible complications of one. There's pain, bowel obstruction, possible strangulation, and erosions as a result of interaction with an uncoated mesh. Now, what is alarming is that this posterior disruption is not diagnosed clinically. You need a pretty high index of suspicion and radio imaging, as you see on screen, to such the diagnosis. Once again, this is a known complication of the open Reeve-Stropa as well, but its incidence is much higher in MIS repairs. Here's a case with a very complex recurrence after dehiscence of both the anterior and posterior fascias after TARM. These two defects in the fascias are also a little offset, which produces an oblique passage of viscera across the abdominal wall. This patient, we went back in open, and Dr. Ramesh Punjani from Bombay and I, we landed up performing a bilateral TAR. And this is the patient's post-operative CT a year later, you can actually appreciate the new mesh that we've placed having this little waviness that is deeper to the rectus abdominis and the TA slightly more laterally. But by far the most disabling and challenging iatrogenic injury to repair is from a semilunar line disruption. Now, this young lady had a 4-centimeter primary umbilical hernia, which was repaired using a bilateral laparoscopic TAR, as per the operative notes. Not only did she have a retrorectus abscess around the mesh, but she also has bilateral semilunar line injuries, possibly because the operating surgeon got disoriented and landed up going far too lateral with his division. This patient has 2 large hernias, an abscess that needs some sort of management. We landed up performing an open mesh explant and will hopefully perform a definitive repair for the hernia soon. Unfortunately, this is not uncommon. Social media is full of similar images of semilunar line injuries, which can be a real challenge to fix. Now that I've discussed the weird and most dreaded complications of these surgeries, let's see what literature has to say. Most of the published series come from high volume centers with truly masterful surgeons. They report very reasonable and sometimes enviable complication rates. But these good outcomes can't always be replicated in a real world scenario by a different surgical team, often in a different part of the world altogether. Let's start with a comparison of open and robo TARs. These are the studies I'm going to be referencing, and you'll notice some familiar and pretty big names in there. So by and large, the operative times are longer in RoboTAR, but the greater investment of time and effort pays dividends in the form of reduced length of stay. There's no difference in SSI risk, but seromas are definitely more common in the robotic approach, possibly because the ab wall and the hernia sac aren't debrided in open cases, as is the norm in open repairs. This has prompted some to explore the impact of hybrid procedures involving the robo and comparing them with purely open repairs. These researchers found that the operative times are still shorter for open TAR, which makes me wonder if maybe we could invent a robot that can dock the robot faster than a human. Jokes aside, the length of stay for open repairs remains long. The real challenge in hybrid repairs, or the real change, is actually the drop in SSOs. In one of the studies, their incidence was the same as in open repairs, while in Abdu's paper, it was actually much lower, possibly because they landed up excising the excess hernia sac in the open part of their hybrid surgery. This is one paper that I particularly like. It's a more expansive look at the long-term outcomes after open and robotic retromuscular repairs. These researchers found that the quality of life scores improved similarly from pre-op levels between the two groups. There was no difference. Wound morbidity and recurrence risk were also similar. The two groups differed primarily in their length of hospital stay, which makes me feel like eventually the choice between procedures is going to come down to patient pathology characteristics as well as cost effectiveness. Let's take a step back and take a look at SSIs and SSOs. These definitions are pretty broad and very inclusive, which makes it difficult to interpret the numbers. How were any of these events diagnosed? Were the seromas picked up clinically or on imaging? Did they have standard protocols for imaging in the post-operative period? Did the patient even complain about the seroma? What fraction of the seromas and infections actually had an impact on the patient? We don't really know because the prevalent definitions are rather sterile. Excuse the pun. They are great for reporting incidents, but they don't divulge much information about clinical relevance. For example, the image to your left, here's a patient with a small palpable seroma from a lateral hernia that's not causing discomfort, but it's definitely palpable. Here's another seroma in the retrorectus space following an ETEP TAR, which is incidentally seen on a follow-up scan. The patient doesn't have any issues. This, on the other hand, is a large infected seroma with overlying bone cellulitis that definitely warrants attention. But there's no good way at present to convey all of the relevant information. Let's also take a look at the comparative studies that I mentioned earlier. Almost all of them universally mention SSIs, SSOs, and SSOPI rates, along with recurrence, which is a norm when reporting hernia outcomes. These numbers are low, in line with other ventral hernia repairs. But the complications specific to these AWR surgeries find really scarce mention in these papers. In stark contrast, social media platforms are flush with surgeons discussing their own complications or seeking help to manage someone else's. Here is another set of large series of cases from all over the world, including my part of the world, where the reporting patterns kind of repeat themselves. It looks like complications are often underreported, and there exists a clear publication bias where favorable outcomes are reported more often than the real world adverse events. And truly, it seems like the high volume centers are publishing way more than the low to mid tier centers. At this point, I won't go so far as to say that the data is inaccurate. Rather, sometimes it just appears incomplete. Now, I don't want to be a mindless wet blanket and smother the adoption of good surgery, but maybe, just maybe, we need to curb our collective enthusiasm. Each conference has at least one speaker show the Dunning-Kruger curve, and I'm quite happy to be the first one to do so today because it's still early in the schedule. The Dunning-Kruger curve shows that we start off with a lot of enthusiasm and confidence, and we feel like we know everything, but as we notch up the numbers, we realize there's a lot more that we don't completely understand, and true mastery is achieved as a function of time and effort. Where do you think we are as a surgical community with regards to these new procedures on the curve that you see on screen? In my mind, there's two ways this story plays out. One would be similar to that of lap and robotic Whipples, where initially centers all over the world adopted the procedure, had some really encouraging reports, and people started performing minimally invasive Whipples more and more. But not all centers could replicate the great outcomes. This then prompted the development of guidelines for who should be performing these surgeries. It was based on annual volumes and the breadth of their advanced laparoscopic as well as open surgical experience. The other possibility, and one that I am personally more optimistic about, is that this plays out like lap cholecystectomy, where we had quite a few iatrogenic injuries soon after the surgery was developed, but thankfully they've now significantly trailed off.
It's frozen.
Yes, sir. Yes, sir. Just a moment.
I'll leave you with one thought. The combination.
Sir, the video has been ended.
Okay.
Yes, sir. So
All right.
next session will be live, sir, from Haniford, sir.
Okay. So thank you for an exceptionally good talk, Ahem. We will move on to the last speaker, pair of speakers, actually, it turns out. Introducing Todd Haniford, one of the most influential and legendary figures in modern hernia surgery. So please, Todd, stage is yours.
1 second, guys. I'm trying to share my screen. Thank you very much for allowing me to participate with you guys. 1 second here. Very good. Can you guys see this now?
Yeah.
Yeah, fantastic. So thank you very much, Rod and Ram, of course, and it's great to be in a session with friends. You know, Keith and Hugh I've known for a very, very long time, and look forward to getting to know Dr. Aurora. That's a terrific lecture talking about one of the hottest topics in surgery, not just in hernia repair. But we're going to talk about tonight. We're going to talk about use of CAT scan and then AI, looking at risk stratification and also predicting complications. And in lecturing with me will be Sully Ayuso. Sully has been in our lab for a year and now is back out in his residency. He's one of our remarkable surgical residents. He just published a paper in JAMA Surgery. And actually has 3 other papers that will be coming out looking at AI and predicting wound-related complications. These are my disclosures. why a CT scan? Of course, it's available. It's highly reproducible from one institution to another. It's fairly standard, and essentially most of the patients that come in to see me already have one. The expense, it's relatively inexpensive, and I actually considered an extension of the physical exam. And we could give an entire talk just on CAT scan and what to look at in a CAT scan, and how to use a CAT scan to help drive your care and truly improve your ability to prepare for the operation, prepare your patient for the operation, and then also after surgery, what to look for after surgery. But of course, can it actually predict complications in our patients, and also stratify risk? Of course, all of these types of patients will have had a CAT scan, typically before I actually even see them. Patients like this, with a fistula, easy to see on a CAT scan, but how to get into the abdomen, how to, what intersection of the bowels involved, et cetera, that's pretty easy. Patients like this, whose CAT scan doesn't actually match their operative note, fairly complex operation, supposedly has an intraperitoneal mesh, has a failed external oblique release on the patient's right side, as you can see here. But then as you look down over here, if you can see my arrow down the right lower side, she has tacks outside of her abdominal wall. So again, preparing for this patient, we know that we don't have the full story, and the CAT scan helps put that together. And then also in patients like this, of course, this is a bilateral failed external oblique release with a blowout through the external oblique. And of course, the semilunaris has been lacerated here. One of the things that's important here, as you can see in the CAT scan, the midline is actually still together. And you can see on the operative side over here that the midline is together. But one of the things that does help me with in this patient is talk to the patient about rectus muscle function and abdominal wall function after the operation. So this operation is not going to make the rectus muscles work again. They will never work, but it does help me prepare for the surgery, but also help me prepare the patient for what they'll have left. Other things that you can find from preoperative CAT scans, like the assessment of pain, and then other patient assessments, such as patients with concomitant disease, liver disease, ascites, and even sarcopenia. What have we done to try and use CAT scans to predict outcomes? And this was done by Katie Slosser and Sean Maloney. These are two residents that work in our lab. And Katie is actually going to be working with Will Cobb in Alpha Carbon next year in a fellowship in abdominal reconstruction. She published this in the Surgical Endoscopy about 15 months ago. But what we looked at was looking at subcutaneous volume, total visceral volume, and hernia volume, and looking at could we predict outcomes. Of course, the need for component separation, hernia volume and intra-abdominal volume played a role. The subcutaneous fat did not. But if you look at fascial closure and operative time, hernia volume played a role in all of these, as did the extra-abdominal volume. But when you look at the complications, hernia volume, the volume of the amount of the intestine and omentum, et cetera, outside the abdomen played a key role in predicting wound complications, readmissions, reoperations, recurrence, and even length of stay. And intra-abdominal volume played some role in that. You can see the p-value is not nearly as strong. We had almost 1,200 patients in this study, but the extra-abdominal volume, again, subcutaneous fat, obesity played a role in wound complications, readmission, and the need for percutaneous drain. How about pulmonary failure? Of course, looking at CAT scans to try and predict pulmonary failure. Our rate of pulmonary failure in these big open abdominal reconstructions is just shy of 7%. And pulmonary failure in our hands is not necessarily intubation, but high flow oxygen, especially those requiring admission to the ICU. Body mass index played a role. Age, I had no idea that diabetes would be so important in patients developing pulmonary failure. And then, of course, pre-existing lung disease. But again, looking at the CAT scan, the defect area, as the area got larger, 250 square centimeters, when we broke these down into very low risk, medium risk, and higher risk patients, large defects, look at the hernia volume of over 2 liters. And if you skip down to the hernia volume abdominal wall ratio of greater than 50%, these patients reach high risk for pulmonary failure. And how about weight change? Can you predict weight change? And if I can get a patient like this guy to actually lose weight, putting him back together again, removing the 3 meshes that he had in his abdomen, it actually becomes quite a nice operation and much easier. Just weight loss of 5 kilograms makes a huge difference. 11 pounds, you can see the intra-abdominal volume, total visceral volume, and subcutaneous volume. And with all of this, it helps us get the abdomen closed. But if you think back to the slides I just showed, that if you can decrease these volumes, you can decrease complications. Unfortunately for women, women tend to carry their weight all over. So if you divide this between men and women, men lose a lot more fat involving their abdomen than women do. Women do lose weight and do lose volume in their abdomen, but not nearly as effective as men. One of the things that we also learned from this in predicting patients who will actually be more difficult to repair, if you wait to operate on patients, and I'm now, not in favor of watchful waiting for ventral hernias, especially the patients who have long midline hernias. Now, this is part of that paper published in Surgery that Katie had done. If you look at this, is the same patient 14 months later, no change in weight. But if you look at the defect size is substantially larger, and the hernia volume is substantially more. And essentially, this patient is now much more difficult to fix, and you would suppose would carry a higher complication rate. And if you look at the mean change in defect size, just pick 18 months for a midline laparotomy, increase in defect size by 85 square centimeters, and the hernia volume by 550 cubic centimeters, making these actually just a really different animal in trying to repair them. We've tried to try and predict component separations in the past, and this was done by one of our former fellows, Laurel Blair and Sam Ross, who's now one of my partners. It was a rudimentary attempt at this several years ago. Of course, others have tried to look at this. We actually look at the angle from the aorta. Of course, when you see this and you do this mathematically, it does not take the hernia volume into account at all. Here's one by Will Cobb and Alfie Carbonell, where they actually looked at just the width of the rectus muscles and whether someone would need a component separation, a components release or not. But again, it did not include the subcutaneous hernia volume at all in these patients. Could we do better? And so Charbel El-Haj, working with Sully in our lab, started looking at artificial intelligence and deep learning. And of course, the consideration of artificial intelligence and deep learning, can this actually replace some of the what we do as physicians? And this is not a new idea. This was actually first published, in all of these quotes actually came from 1970 in the New England Journal of Medicine. And so, has this been used before? It has. It's artificial intelligence looking at scans for cancer, and also, even more importantly, for pathological slides, like an evaluation for breast cancer in biopsy specimens that actually has been used. And what we wanted to do was looking at our previous data, because our previous data actually was just looking at objective data, looking at CAT scan data. In these patients, because our previous data was pretty successful, could we actually use AI and look at just CAT scans and then predict outcomes? And so what these guys did, and Sully will talk about it in a few minutes, but what they did was they took over 350 patients' CAT scans. They took 80% of them and allowed the computer to review these images and gave the answers to the computer. So the computer knew whether the patient was going to have a component separation or not, knew whether the patient was going to develop wound-related complications, and knew whether the patient was going to have pulmonary failure. And then it went through these over and over and over again until it got each test 100% correct. So it looked at 300 CAT scans, and then it did it over 12,000 times until, like looking at component separation, until it looked at every single CAT scan and got it correct every time. And so it took over 12,000 times for the computer to be able to do that. But what is the computer looking at? We actually don't know. You really don't know if it's looking at intestinal volume, hernia volume, subcutaneous volume, looking at the pulmonary cuts. We just really don't know. And so they published this in JAMA Surgery this summer, and it's gotten a lot of acclaim. But again, 369 patients, 80% of the CAT scans were for training, and then the 20% for the test. And then what we found is that in looking at whether the patient will need a component separation or not, the area under the curve of almost 0.75, which was excellent, really quite good. So then what we did was we actually compared it to surgeons. Surgeons took the same test group and looked at the same test group that the computer did, and master surgeons, 6 master surgeons who perform abdominal wall reconstruction and complex abdominal wall repair, Actually, the computer did substantially better. You can see the area under the curve for the surgeons was 0.64 or 0.65 versus 0.75 for the computer. And can they predict wound complications? And this is the data predicting wound complications in these same patients, these 360 patients, and then predicting pulmonary failure. And I love it when our fellows actually have such substantial wins, when you can see that they actually predicted wound infection in nearly 90% of the patients looking at CAT scan, once you train the computer to look at these CAT scans. But they called this a fail. If the area under the curve was only 0.55, 55% of the time, it effectively predicted patients who would develop pulmonary failure. I consider that a huge win. Of course, these guys, being perfectionists that they are, continue to work on this. And so for me, looking at where we were to where we are, even if you just look at pulmonary failure, it's substantially improved. And so I'm going to stop here, and Sully's going to take us into the next part of this. And Sully, I will stop, and if you can share your screen now.
Sounds good. Thank you, Dr. Hannaford. So I'm going to pick off where Dr. Hannaford left off. As he said, predicting wound complication or component separation with an area under the curve of over 0.75 is truly remarkable. But what we wanted to do is improve the ability to predict rare outcomes. An ROC of 0.5 essentially is slightly better than a flip of the coin in being able to discriminate a positive versus a negative outcome. So few things came to mind as we were developing these models is, could we increase the number of images in our data set for our models to train and accurately predict outcomes? And then secondly, just intuitively, when there are more instances of an outcome, the deep learning models that we develop are better able to train because they have more representations of the data. And then the third thing that we thought of after the first project was, how can we integrate the data that we have at Carolinas Medical Center, which is quite robust, to supplement model performance? And so the aim of our kind of second project of many that we're currently working on is to try to improve the deep learning model performance specifically on outcomes that occur less frequently. So we already had one outcome that we could kind of tamper with, which is the pulmonary failure model. And as Dr. Hannaford said, and overall in our data set, it occurs in approximately 7% of patients. Mesh infection occurs in much less than that. And so I think given the fact that that is one of the most devastating outcomes in abdominal wall reconstruction, that was another outcome that we would like to target in terms of outcome prediction. So here's our conventional deep learning model. So the input is a CT scan, so 5mm slices that encompass the entire hernia defect. The model essentially discriminates based on data that is unknown to the user, then extracts features and either puts a patient or a CT scan in a positive or a negative outcome prediction based on the model training and then validation in a separate 20% of the data set. So we reviewed the data science literature, and I think one of the things that was important here is a multidisciplinary collaboration with people that do this much more frequently than we do. And so we partnered with a data scientist to kind of go through the literature and see what was working out there to predict outcomes in other fields for outcomes that occurred, less frequently. Wound complications occur in 20 to 30% of patients that undergo abdominal wall reconstruction. Component separation in our data set, Carolinas Medical Center, is quite common as well. So what we came across is two things. One is image augmentation, so artificially creating images that are based on representative kind of CT scans in this case. And the second one is anomaly detection. So training a data set based solely on the positive outcomes. So that would be things like mesh infection and pulmonary failure. And then in the validation set, where we're testing the model, looking and seeing how well that we can discriminate based on features that aren't characteristic of that positive data group. And so here we have data from approximately 500 patients. That is about a 40% increase from our initial paper. And you see here the number of images that we used was approximately 10,000. Mesh infection occurred in 3.7% of this population. That is almost double of the mesh infection rate in our overall group, but this is a representative sample of 500 patients out of nearly 3,000. And then pulmonary failure you see here occurred approximately 5% of the time. But these are just representative CT scan cuts on the left that we use to input into the model. And so when we looked at the outcome prediction of our conventional model that we published in JAMA Surgery for both pulmonary and mesh infection, the model performed okay, is what I think I would say and what most data scientists would say, with an AUC of about 0.6. Generally, we view 0.7 to 0.8 as good, 0.8 to 0.9 as excellent, and then 0.9 and above is kind of out of this world. And so we wanted to compare how our novel model that incorporated both image augmentation and anomaly detection performed in comparison to the initial model for these more rare outcomes. And what you see here is for pulmonary failure and mesh infection, the area under the curve increased by more than 0.1, which is quite remarkable, and being able to just distinguish positive from negative outcomes. And so when we look at the accuracy, sensitivity, and specificity, you see that the conventional deep learning model that we have already published on was very accurate in predicting a specific outcome. So the overall number of guesses that the model was making in terms of it was very accurate in being able to distinguish that, but it could not pick up very in a sensitive manner on all of the instances of mesh infection that occurred. And so what you see in the pulmonary failure is the same thing. So our kind of novel model that we developed with image augmentation anomaly detection overall was much stronger because it wasn't compromised by decreased model sensitivity. So what was kind of the deciding factor in terms of strengthening model characteristics? So when we looked at image augmentation alone, so this is generating new instances of an image, but training again on the negative and the positive outcomes, we see that this isn't much better than the original model for pulmonary failure. And that was the exact same when we looked at mesh infection, suggesting that anomaly detection, where you train a data set based on just the positive instances of that specific outcome, and then recognizing images that do not kind of look like those was kind of the driving point for our novel model development being very strong. And so kind of conclusions from this data set, image augmentation anomaly detection, which we term GAN anomaly, which is the term that we're going to use in the paper coming out, was effective in improving model performance for rare outcomes. And that was driven predominantly by anomaly detection rather than image augmentation. Conventional deep learning models were compromised by decreased sensitivity. They could not pick up on these outcomes rarely. And I think, something that Dr. Hannaford and I talk about frequently is that we train these models based on our data alone. And we feel very confident about our data set being, up to date and prospectively maintained. So we're training models that we feel we're very confident that they're predicting accurately outcomes, which I think kind of is in part the reason that why we've been able to do this so successfully. And so future direction, here is a paper that was published from a group at Massachusetts General Hospital recently in the Journal of Surgical Research. And I really like this quote, and I feel like this is very applicable when we talk about the use of AI in medicine. It is certainly coming, and it is already here. As much as I think we like to run from things that we don't understand, we're not going to be able to in the long term. And so the application of deep learning is not a revolutionary process, but an evolutionary one. And I think all of these incrementations of what we are kind of putting together at Carolinas Medical Center are going to be important in being able to deliver outcome prediction and risk stratify patients at the bedside. So the next step, or one of the next steps for our group in abdominal wall reconstruction, is saying, hey, do these models that we develop work on CT scans from other institutions? So we know that, we are a large tertiary care referral center. We're getting CT scans from all over the state and all over the country. And so these CT scans, are coming from different scanners, et cetera. But The one thing that I think we have going is that we perform repairs in a very consistent manner. We predominantly use pre-peritoneal approach to repair. We predominantly use large mesh overlap, and seeing if these specific outcomes will be applicable when we get CT scans from other institutions and use the outcomes that were recorded by their data sets. So I think another thing to keep in mind and is very important is what we're doing better than what exists. Dr. Henneford had mentioned things that we had done at Carolinas Medical Center in the past. Dr. Carbonell and their group, were predicting the ability to close fascia based on the the rectus muscle versus the width of the defect, and they did that pretty successfully. But are things that we're putting together better than general linear regression? Are they better than things that we put together at our own institution, like the CEDAR app, which predicts wound complications for patients undergoing open abdominal wall reconstruction or NSQIP, et cetera? And so keeping ourselves honest, I think, is going to be the most important part of this process going forward. And then how can we integrate large scale data? So we have data from approximately 3,000 patients who underwent open abdominal wall reconstruction, being able to tie in factors that we know impact outcomes, such as smoking, diabetes, and predicting wound complications, et cetera. That is kind of what's going forward. We have unfortunately not been able to augment our outcomes much with that to this point, but I think that's in large part given the fact that we hold smokers and diabetics to a strict standard before they get operations. So, at our institution, it is mandatory that patients quit smoking 4 weeks before their operation and have an A1C goal of below 7.2. But being able to integrate data points that we might not know impact outcomes yet is something that is certainly on the horizon for our group. And, this is a field that we're lucky enough to have a bunch of large databases that we can draw on and hopefully collaborate with other partners and other institutions to make models that are going to be quite applicable and beneficial for patient care. And so this is kind of, I think the way I see artificial intelligence and deep learning going is being individualized. This is a figure from a paper that was published in JACS not too long ago, essentially predicting outcomes for patients undergoing emergency general surgery. And I think, being able to go through things algorithmic and having, image-based deep learning model predictions as a part of this, where you say, this is the type of procedure that the patient is having, these are their medications, and then kind of go through an individualized checklist for patients, and then be able to have a risk stratified outcome based on many different factors rather than, just one or two things is going to be ultimately very strong in terms of influencing what we do for patients. And so I think, just to reiterate, each and every one of these projects is going to be important going forward, and being open-minded, but also being honest with yourself about, what these models mean in terms of their ability to predict outcomes, and how well, we trust the data that we're training these off is very important going forward. Thank you guys for allowing me to present. Thanks to Dr. Henneford for always being open-minded to new ideas. So.
Thank you. Well, I want to congratulate all the speakers who have given us food for thought. Whilst we're waiting for some questions from the audience, I'm going to throw one firstly to Eham, and the others can jump in as well. So you alluded to the fact that perhaps the data is not as robust as it might be. So I've always wondered whether we get an underreporting of complications or perhaps an overreporting of complications when we get them from centres of excellence, because they're people doing the work all the time, and therefore you might expect their complication rates to be a bit lower. Or are they more fastidious and finicky, and they pick up all the tiny complications that might not otherwise really be an important thing? I'm wondering what others have to think about that, and whether or not we really know what the complications are.
That's a great question. Regarding the smaller complications that are relatively infrequent, I think it's difficult to convey all of that information within a paper. You want it to be concise and dense, and you want to get some points across, but discussing individual patients with an odd complication a little too much may be a bit distracting. I honestly do feel that the centers of excellence are not having these complications as often as, say, lone or small surgical teams out there in the world. But also, it also comes down to the definitions. So a lot of these patients who are coming back with bulges and hernias, they're going to be labeled as a recurrence. But somebody has to look at the operative videos a little closely and figure out, was this recurrence just a function of the mesh not having great overlap, or was it actually because of iatrogenic facial injury? Because these complications you don't see in the other forms of hernia repairs. These are relatively constrained to the new AWR procedures that we're seeing right now. So I think we need to be more honest as to what's happening in the OR and not be quick to dismiss these recurrences as just routine parts of the surgery.
Okay. So I think Romana's got one, but I'm going to ask Todd quickly. So should we stop waiting and just operate if the hernia is going to get bigger, or should we get their weight down? What do you think is more important, getting the 5 kilograms off or getting in and stopping the hernia doubling in its size?
Well, I mean, I think that there's little question if you operate on smokers, and unless you're going to do this laparoscopically, you're going to be like Hugh and do them laparoscopically or do these robotically, or patients who have obesity or uncontrolled diabetes, you're going to have problems. And so complications in these patients increase our recurrence rate by more than 3 times, between 3 and 5-fold when we're doing them open. And so I press on the patients that it's, instead of saying, go get your life right and then come back, I press on the patients to actually, we need to do this. We need to move this along. And then instead of sending them out and maybe seeing them back in 6 months, now see them back in 45 days, and then recheck with them. And so I'm much more on top of them. I'm also much more likely to send them to. So I'm getting a lot of echo back. Send them to for formal bariatrician consultation, or even bariatric surgery more rapidly than I would have in the past. But I hold them to a standard. I'm not going to operate on if you're smoking. Hemoglobin A1C of 7.2. You need to lose enough weight that I can get your abdomen closed, and every point of BMI decreases morbidity. And so I hold that kind of seesaw back and forth between that and letting the hernia get larger, and converting these people to a much more difficult operation.
Okay. Romana, I think you had a question.
You need to unmute yourself.
Romana, you need to unmute yourself. Ah, there we go.
Hello. Sorry, the question.
Rama, you got the website open as well. That's the problem. Close the website and just go to Zoom.
Okay, I'm sorry about that. I had 2 on because of internet fluctuations. So my question is for Todd. Are you able to hear me?
Surely.
Yes.
Yes.
Todd, all this Unreal computer and artificial intelligence interpretations of images and the data that you feed in, how far are these away from being practically usable for the real world? When do we see another app, and when do we start using these on our own patients? And are there any hurdles along the way?
Well, I think Sully did a good job delineating one of the key factors. One of the key factors in this is surgeons performing the operations differently, and then different subsets of patients. One of the things I think of the advantages that we have here that you mentioned is, the people that I work with, essentially trained them, and we've worked together for a long time. We all do preperitoneal mesh choice is very equal. We hold patients to a standard. So, within our microcosm, I think they work well. But before we can release these, and before Sully can have his first app, which is the plan is that we'll do this, we have to do a multi-institutional trial. And so the CEDAR app works because smoking is bad, and obesity is bad, and enterotomy is bad, and all those things are bad. And but the consideration of whether a preoperative CAT scan will yield postoperative outcomes, I think we have to put it through a multi-institutional trial, and that's what we're currently doing. We've signed contracts with folks. I mean, trying to get this through legal is just amazing, to share information, and it should be difficult, let's just say. But once that happens, then the answer is yes. We will. When you're being able to take a CT scan and put it into this app, and then seeing what these possible complications are, I think will change an awful lot of the way we talk to patients, even in the consent process. If you know you're going to have, let's say you work in a small hospital and this patient has a 60% chance of developing pulmonary failure, perhaps that ought to be done in a tertiary center. Or that they're increasing the wound-related complications, you talk to the patient and perhaps the patient decides not to have surgery. The consent process will change as well. Resource utilization, where the patients actually have their operations in the consent process.
Thanks.
I think Dr. Hensman has something he'd like to ask. Chris?
Yeah, Todd, thanks for your presentation and as usual, great insights. My question to you is, in Australia, we are just in the final stages of launching a registry with all of the nuts and bolts of a learning healthcare system that has the power to analyze some of these data points and use artificial intelligence then to predict the kind of things that you're doing. And I wonder whether you could make a comment for that, about that, because I think this is the next step, the nested registry data that can be used to drive options, risk mitigation, and prediction for patients with regard to hernia care.
Maybe I'll pass that to Sully. So Sully has certainly talked about that an awful lot.
Yeah, no, I think that's the goal. Just to kind of reiterate, a couple of things is one, that we trust in our own data at Carolinas Medical Center. The outcomes that we have reported for the studies that I alluded to are completely independent of the surgeons that were performing the procedure. So we have a data collection team that really has no stake in the outcomes that we have for our patients. And then we have a team of researchers who kind of work hard to kind of make sense of the data. And so I think that, when you're talking about more large scale data collection, it has to be standardized in how it's actually collected, and that data is pure enough that if you're doing anything that's algorithmic, that you're, kind of feel okay about, the predictions that are being had. Because if you create a data that is actually predicting outcomes that are incorrect, then that's doing a tremendous amount of harm, potentially for, triaging patients to specific centers, et cetera. I think that, the kind of nuts and bolts of, artificial intelligence and stuff, what we're doing is that you also have to kind of read between the lines a lot of times in the models that are being developed here, because unfortunately, a lot of folks are kind of new to this as we are as well. And you want to make sure that the models that have been developed are, kind of among a certain criteria. The data that we reported both in the paper and then what I just, kind of reported is, averaged out over, thousands of iterations. So this is not just kind of a one-off and being able to detect something. So I would say, to kind of answer that question simply, again, just make sure that the data is being reported accurately and consistently.
It's all about Chris, it's all about the accuracy of the data. It's interesting to hear Hugh talk about, like, I put it in the pancreas and I put a trocar in the liver. And I mean, just like when you become a mature surgeon, you're unafraid to say, here are my complications and here's what I've learned from them. When I was young, I tried to hide everything. I didn't want anybody to know about my complications, and it would hurt my feelings. And so, but, being, accurate data, and you can do some amazing things with accurate data.
So look, we might finish there. Look, I want to thank all the speakers. We've had a great first session that's set the tone for the next two sessions, where we're going to hopefully learn how to mitigate those risks and then finally treat the ones that we can't avoid or happen anyway. I want to thank all the speakers, and I'll hand over to the two next chairs, Chris Hensman and Pramod Shind, and they can take it away for the next session. Thank you all.
Thank you.
Thank you, guys.
Thank you. Great talk, Doug. Thanks.
Thanks, Rod. And the next session is entirely dedicated to risk mitigation. I'm chairing the session with Pramod Shind. Now, if you don't know who Pramod Shind is, I recommend you go and jump on YouTube and have a look. There was recently an award ceremony where his work over his lifetime was recognized, and he was given an award, and it makes for a fascinating listen. Have a look at that. That's worth a couple of minutes. In terms of the next session, we've got a collection of top line surgeons, all experts at the craft. Before I start the session with our first speaker, I wanted to just recognize the contribution that Medtronic has made to make this meeting successful. It takes two things, support and a great team, and Rod and his team have put together a great program. And I want to thank Medtronic for their support, and they've been ongoing supporters of the ANZ AWR meetings over the last several years. Without much ado, I'm going to introduce our first speaker, Dr. Nicolian. He's from the Oregon's hospital and university, and also expert in abdominal wall reconstruction. He has written extensively on the subject and will be talking on the preoperative strategies. I think a better prepared patient's often going to give us the better outcomes. So over to you, Dr. Nicolian.
Thank you very much. My name is Vahag Nicolian. I'm presenting on behalf of my institution, Oregon Health and Science University in Portland, Oregon. And today it really is an honor to present at the ANZ AWR conference, focused on discussing one of my passions, preoperative risk mitigation and optimization in advance of abdominal wall reconstruction. I currently serve as a consultant for Care Syntax, Medtronic, and Intuitive, though these are not relevant to today's conversation and presentation. So why do we optimize? And the answer is simple. We want to maximize the potential for a patient to have a long-term and durable repair. This data that was published nearly 2 decades ago demonstrates that the patient's best opportunity at a long-term and durable repair for hernia is the subsequent operation. With every recurrence, the chance of achieving a long-term durable repair in the future goes down. And so it's important that we maximize the potential for patients to do well after ventral hernia repair. The burden of ventral hernia is significant. We have up to 40% of all patients who undergo laparotomies developing an incisional hernia. This accounts for 350 to 450,000 ventral hernia repairs performed annually. Unfortunately, in spite of being such a commonly performed procedure, the outcomes for these operations are not all that great, with recurrence rates upwards of 40%. Complication burdens of between 10 and 60%, and readmissions for as many as 13% of patients. This accounts for billions of dollars spent annually in the United States to manage patients who have poor outcomes following ventral hernia repair. Ventral hernia repair results in what many consider a vicious cycle, and a patient undergoes an operation, which is unfortunately complicated, and then they develop a recurrence, which prompts another surgeon to perform a hernia repair, which unfortunately results in a complication. And this vicious cycle seems to repeat itself until patients no longer have many options available to them. So it's important that we optimize outcomes. And the best way to do so is to try and identify the right patient, the right timing, and the right operation. In general, in hernia surgery, there are many right answers and a few wrong ones. So today what we're going to focus on is identifying some right answers and also recognizing what are potentially some wrong answers to avoid for the future. Preoperative optimization can be broken down to a variety of concepts. I think many of us think about the big three highlighted in this pyramid as diabetes control, smoking cessation, and weight loss, but there's clearly other opportunities as well, including infection control, improving patient exercise tolerance, optimizing pain, alcohol cessation, as well as obstructive sleep apnea optimization in advance of an operation. What I like to think about is this concept of optimizing optimization. In an ideal world, every patient presenting for a ventral hernia repair would be optimized. But clearly, this isn't an opportunity that's going to become anything real in our lifetimes. What's more important is to be able to identify those that are high risk and do our best to make their risk profile less. So those patients who are actively smoking, who have infections, who have loss of domain, who have multiply recurrent hernias, or who are malnourished, may qualify for some adjunctive measures to reduce their potential risks associated with an abdominal wall reconstruction. I also include any patient that requires an open procedure because clearly the wound morbidity is going to be higher for them. I think it's important to be objective. My patients respond really well to objective measures of risk, objective measures of complications, and objective measures of a realistic goal for them. And so I use the CEDAR app developed by Dr. Henneford and his colleagues at the Carolinas Medical Center. I think it's one of the best apps. It gives patients a very objective view of what may happen to them should we proceed with an operation. More importantly, I'm able to modulate some of those risk factors and then demonstrate to them what happens to their risk profile as they improve in their optimization goals. Also included is the anticipated costs in the hospital setting and follow-up charges that change when the risk obviously goes up. Though these aren't necessarily important at the individual level, it's important to recognize just the consequences this can have for our medical systems that are oftentimes limited in resources. Other risk calculators exist, though I don't believe they're as good as the CEDAR app when discussing ventral incisional hernia repair. Smoking cessation is one of the things that many people highlight as an opportunity for improving outcomes for patients. There are tons of data out there that highlight the reduction in surgical site infection, hernia recurrence, as well as readmissions for patients who are successful in smoking cessation. In an ideal world, we target 4 weeks of abstinence from smoking. And now with the advent of nicotine and metabolite testing, we're even able to test patients who are on nicotine replacement. So I no longer have to tell a patient, you have to go cold turkey, you have to completely stop smoking and using any nicotine products so that we may test you with Cotin test. Nicotine and metabolite testing lets us differentiate who is using nicotine replacement and who is still actively smoking. Smoking cessation has become somewhat controversial. A recent paper out of the American Hernia Society Quality Collaborative, also known as the ACHQC, showed that among thousands of patients undergoing elective open ventral hernia repair, there is an insignificant difference in wound morbidity when looking at smokers versus non-smokers, though these outcomes were only at 30 and 90 days. Long-term outcome is lacking, though there are current trials evaluating whether or not there will be a difference in outcome. Management of obesity is yet another opportunity for improved outcomes. We try to make sure that patients who are obese have a thorough discussion about the risks of obesity on their hernia outcomes. Clearly, with supramorbidly obese patients, there is a higher rate of SSI, pulmonary complications, blood clots, as well as readmissions. I will highlight that we don't have a consensus on the ideal cutoff, though our institution uses 35. Clearly, not every patient can get to this number. I think for any patient coming in with a BMI greater than 35, working on at least some basic opportunities for reduction in their BMI is worthwhile. I don't necessarily set 35 as the absolute number, but rather as a goal, and we want to see a trajectory towards the goal. So if someone comes in with a BMI of 42, our goal is get closer to 35. If they get to 36, 37, at that point, I feel like the abdominal wall laxity is likely going to improve. The intra-abdominal lipodystrophy may improve, and our ability to manipulate and close their abdomen is higher. So usually we're able to proceed. In that same vein, it's important to recognize if a patient presents with a BMI of 32 and at the time of operation has gone up to a BMI of 36, you may have differences in terms of your compliance of the abdominal wall and your ability to perform the operation you intended. Diabetes control, clearly an opportunity yet again for improvements in outcomes. Patients who have poorly controlled diabetes have increased rates of wound complications and perioperative complications. In an ideal world, hemoglobin A1C is targeted at 6.5 or less. I look at this as a surrogate for the patient's relationship with their PCP. If a patient has a hemoglobin A1C of 8, at the time of our initial evaluation, I ask them about what their PCP thinks about that number. If they tell me that their PCP has stated that the number's pretty good and that they're doing well with their diabetes control, I use this as a reason to refer the patient to an endocrinologist for more close observation and optimization of diabetes. If the patient states that they don't have a good relationship with their PCP or that their PCP is not satisfied with their diabetes control and is recommending for further management strategies, I advocate for the patient to actually follow through with these goals so that they can qualify for a hernia repair. Prehabilitation. Something that's become very much in vogue over the course of the last decade, is a really important concept to discuss. We work closely with multiple team members to prehabilitate patients in advance of abdominal wall reconstruction. Our goal is to offset the effects of the surgical insults, specifically the catabolic effects, the tissue trauma that we induce, the semi-starvation period that the patient has to sort of withstand, as well as the general inactivity in the post-operative period. Our major goals for prehabilitation include enhancing patient physical conditioning, reversing the deconditioning of an operation, and increasing the functional reserve. So how do we achieve this? And so there's multiple adjuncts in the prehab setting, specifically physical exercise, nutritional optimization, and psychological support. So we'll review these now. Physical exercise and strengthening really can be great. We work closely with physiotherapists who are able to give us a good baseline assessment of the patient's baseline function. And then we work to improve their endurance and cardiovascular health in advance of surgery. Strengthening exercises can also be performed, but really what we're trying to highlight to these patients are effective, simple strategies for cardiovascular optimization in advance of surgery. Physical exercise and strengthening can be done in a variety of ways. I don't believe that you necessarily need to spend a lot of money to accomplish this. So here are some simple strategies that we use. One, we set a 4 to 8 week period for prehabilitation for any patient that we feel would benefit. We try to be cost conscious about our recommendations, recommending low cost, if not free options such as walking and canned food weights. My senior partner, Dr. Martindale, really advocates for very basic exercises with canned foods that can be done by essentially anyone. We use the ACHQC mobile app, which provides some nice recommendations about some basic maneuvers that can be performed at home to improve core health. So prehab, tons of data exists. Over the last 10 years, we've seen a rapid increase in people's appreciation for prehabilitation because we've seen that it improves functional capacity. It increases the rate at which patients return to their preoperative setting and hopefully even beyond. It decreases complications, length of stay, and it improves postoperative function. Another important concept is this idea of immunonutrition, especially in GI surgery. We've seen that it decreases rates of SSIs, infections, sepsis, and mortality. Our institution recommends Impact AR, advanced recovery, for our patients, though it has become more and more challenging to obtain this for patients, especially getting insurance approval. A pack of Impact AR and advanced surgery can cost sometimes upwards of hundreds of dollars, so it can be cost prohibitive for certain patient populations. Psychological support is yet another opportunity to help patients. We use psychological support to educate patients, reduce anxiety, and hopefully result in improved compliance in understanding their disease process. We collaborate regularly with psychiatric and psychological services, especially when we're referring patients for bariatric support. So we've talked about the goals, but it's really important to recognize some of the realities. And the reality is that all of these things require a ton of resources. But what I want to highlight to people here is that poor outcomes also are very resource intensive. So being proactive about this, setting and putting aside significant time to help patients, developing good relationships with personnel around your institution, and recognizing that things can be done in cost-effective manners can help our patients in the post-op setting. So in conclusion, pre-op optimization is critical for post-operative outcomes. It takes a multidisciplinary effort for prehabilitation to work. So it's important to do so that we can reduce complication burden. And proactive preparation can mitigate retrospective regrets. With that, I want to thank everyone here at the conference and welcome you all to Portland one day whenever it's easier to travel. Thank you again.
Thanks, Vahan. That's an excellent talk and really quite systematic and thorough. Thank you for that excellent presentation. We'll move on. Pramod?
Thank you, Chris. Thanks for your kind words. And Chris, I know that you're also an accomplished surgeon, bariatric, and leading the hernia movement in Australia. And it's indeed my honor and pleasure to be here to chair this session and introduce Dr. Eric Polai, who in fact does not need so much of an introduction because he's very popular for his CT scan readings. A name, he has also his own repair, the Polai repair. And we've seen his skills for open hernia surgery and the abdominal wall reconstruction, especially the so-called TAR, in our own IHC 2018 and on social media. So he's going to talk about mitigating the risk, especially the intraoperative strategies in open surgery. Over to Eric Polai.
In Australia and New Zealand. My name is Eric Polai. I'm a professor of surgery at Penn State Hershey Medical Center, and I really appreciate the opportunity to spend a few minutes talking with you about mitigating the risk of open surgery by talking about intraoperative strategies, and we'll spend the next few minutes on this topic. I do have some disclosures, none of which have any relevance in what we're going to be talking about in this presentation. So morbidity after open ventral hernia repair remains exceptionally common. There are estimates that 25 to 50% of component separation patients, for example, can be expected to have at least one postoperative occurrence. We most commonly think about those as surgical site infections, wound complications, and seromas. As you can see, different rates in this slide, but we know that that includes all other problems, including pulmonary problems, bleeding and clotting problems, urinary tract infections, and respiratory issues. And I think that what we're seeing in the US is that reimbursement for hernia surgery is being increasingly tied to outcomes. And as a consequence of that, optimization, typically in a pre and post-operative period, has received great attention. But obviously there are things that happen in the middle of the operation that we as surgeons can do to help mitigate the risk. And we're going to therefore spend the next few minutes talking about an evidence-based and maybe a little bit not evidence-based review and recommendations about how to mitigate risk. I'm going to focus, as was mentioned earlier, on open ventral hernia repair. And as a person who primarily does posterior component separation and transversus abdominis release, that's really where I'm going to focus most of my attention today. I'm going to walk through this in a step-by-step fashion, kind of a skin-to-skin approach from the beginning of the operation to the end. So the first recommendation from my perspective, which is really, I think, the only non-evidence-based recommendation in this talk, is to review the available imaging studies. I believe, and when I speak about imaging, I talk about this, that careful review of preoperative scans can help you identify high-risk and low-risk places for abdominal access, for example. On this particular CT scan, we've got a patient here who's got a hernia beginning in the upper midline. This is actually a piece of mesh with EPTFE that's pretty heavily stuck to the colon. And you can imagine that making an incision in this area, encountering mesh, and then colon stuck directly beneath it is a very bad place to start this operation. Whereas if you go down just a few more slices, you can actually see some omental fat in a hernia sac. That's a safer place to get in. Or even much farther down where you've got abdominal wall, mesh, and then just intra-abdominal fat and no colon densely adherent. So I think you can pick a safe place to get in by review of imaging studies. But I'll also point out that intraoperative review can help you correlate the findings that you're seeing in the middle of surgery. And what I typically use this for is the concept of, maybe I should slow down the operation a little bit in this particular area. So here's a good example of that. We're lysing some adhesions. We're behind. This is the right rectus abdominis muscle. We're lysing some adhesions in this loop of bowel here. And I said, man, this is really stuck. Let's take a look at what we're working on here. And what we're working on here, here's the rectus, is this loop of bowel right here, which is the duodenum being pulled out of the retroperitoneum. And right next to it is the gallbladder. And obviously, making a hole in either of these things is going to really change the nature of the operation to a pretty great degree. So again, maybe we should slow down at that location. Second recommendation is to remove all previously placed mesh. And this is a study from Lillian Coe from Annals of Surgery 2020, where they looked at a propensity match study from the AHSQC. And they matched patients for a variety of comorbid conditions. They eventually identified 1,904 patients who underwent mesh excision. And what they found were that complications in the postoperative period were significantly higher, 35% versus 29%, if patients received partial mesh excision. And that included surgical site infections, surgical site occurrences requiring a procedural intervention, and all reoperations. Now, that effect was more magnified in clean, contaminated cases. For example, the risk of a surgical site infection requiring a procedural intervention in that wound class was 24 versus 9%. When they looked at heavily infected or fistula cases, that effect was even more magnified. The SSOPI rate was 46 versus 29%, and the risk of a reoperation was 21% versus 6%. And obviously, these are very significant problems if you have to go back and reoperate. And so their recommendation was, obviously, remove all mesh. But I think there's a few things that we can critique about this. And one of the things is that the amount of mesh left behind is not really well classified in the AHSQC. You can simply say complete removal or incomplete removal. And so the question becomes something like this. This is a patient of mine in whom we were going for complete mesh removal, and we caused an enterotomy. And so I've upclassed the wound, obviously. I've got to fix an enterotomy. And, the question is, what if I left a small patch of mesh on the bowel? Is that incomplete mesh removal worse than increasing the wound class by having an enterotomy? And the answer is nobody knows the answer. So what I aim to do in my patients is complete mesh removal with a few caveats and exceptions about the risk of making enterotomies. Third recommendation, if you're concerned about adhesions, consider going open or robotic, but basically not lap. And the reason I say that is we know that the rates of bowel injuries when comparing open ventral hernia repair with component separation and robotic are the same. And here you see us laparoscopically creating an enterotomy during some adhesiolysis. The rates are the same for both full thickness and partial thickness injuries, and also recognized versus missed injuries. But the rate of bowel injury, it clearly favors robotic repair versus lap. All right, and so if you have access to the robot, then certainly robotic adhesiolysis is as safe as open. But if you're concerned primarily about adhesiolysis as part of the case, and you're doing a retromuscular repair, either do it robotically or do it open, but probably not traditionally laparoscopically. Recommendation 4, if you're a person who does tap blocks postoperatively for pain, consider doing it yourself. This is a study that one of my lab residents put together a few years ago, where we retrospectively looked at all of our patients in the AHSQC database who were getting open ventral hernia repairs that were either retrorectus or TAR. And we compared patients who got an ultrasound-guided tap block versus patients who got a direct vision, meaning surgeon-performed tap block in the operating room. And in this study, all of our patients received liposomal bupivacaine. Our ultrasound tap blocks were performed by our acute pain team. They're a very good pain team and did a wonderful job. Our direct vision tap blocks were performed exactly as you see here, with direct injection of the dilute Exparel directly into the intermuscular plane. And it's very easy to do. You can see here the cut edge of the transversus in panel A. You can see us injecting, and you get this nice bleb when you inject into the retromuscular pocket. And what we found was that patients had very similar pain scores after surgery. In fact, only on postoperative day 0, later in the recovery phase, out of the PACU, did patients have differences in their pain scores. So the scores were the same. But in order to achieve similar pain scores, the patients who received the ultrasound-guided tap blocks required significantly more milliequivalent conversion of oral morphine. And if you look at all of the oral morphine equivalency that they needed during the hospital stay, the ultrasound group required significantly more than direct visualization group. Now, this has less to do with the fact that surgeons are much better at tap blocks than the fact that we very heavily diluted that Exparel. We could inject under direct visualization over a very broad plane. And because we diluted it so much, I think that the agent really dissects that plane very nicely. And so probably more a difference in the technique than the technical expertise of the people performing the procedure. But again, I would consider doing it myself if I was going to do a tap block, which is what I still do. Recommendation 5, if you're going to irrigate, consider irrigating your retromuscular pocket with antibiotic irrigation solution. This is some work from Alfie Carbonell, Jeremy Warren, and Cobb. This is their initial paper from 2018 in which they retrospectively reviewed their open ventral hernia patients. And they broke them down into groups. Group 1, 260 patients who got their operation with no antibiotic irrigation. Group 2 was 263 patients who had gentamicin in their irrigant. And then group 3, 299 patients who had gent and clindamycin in their irrigation solution. And what they found was that the incidence of surgical site infection was significantly lower in the group that had gent and clinda, but not in the group that had gentamicin alone. And if you look at the difference in the infection rates between the groups, group 1, 16%, group 2, 15%, group 3, that 2 antibiotic group, 5.4%, and that was statistically significant compared to other groups. Importantly, the use of the gent and clinda was an independent predictor of a decreased surgical site infection rate with an odds ratio of 0.33. And so with this information in mind, the same group of investigators went on and it has just finished collecting the data on a multi-center trial, which we were part of, called the RINSE trial, Reducing Infection at the Surgical Site with Antibiotic Irrigation During Ventral Hernia Repair. This is a phase 3 randomized multi-center trial, wound class 1 through 3, which was basically a 3-minute irrigation. After the mesh went in and was fixated, we either poured saline or saline with gent and clinda into the pocket and left it for 3 minutes. And we enrolled 250 patients, and the data will be forthcoming. I will point out, if you go to clinicaltrials.gov, we did not irrigate with gemcitabine as clinicaltrials.gov says. It was gentamicin and clinda, I promise. Recommendation 6, consider a reduced weight macroporous monofilament mesh. Obviously, mesh choice is very important for hernia repair. Contaminated fields continue to represent a very challenging circumstance, but there's an emerging body of evidence that suggests that macroporous monofilament mesh may be safe in the sublay space, but obviously nobody wants to see pussed out mesh in the postoperative period. This is some work from Arnab Manjumder, which included patients of mine, Yuri Novitsky and Igor Belyansky, and we compared 126 patients in class 2 and 3 wounds. There were roughly 70 patients who had acellular porcine dermal matrix and 57 patients who had macroporous intermediate weight polypropylene mesh. These were all sublay patients, all retrorectus and TAR patients. And what we found was that the use of a synthetic mesh over a biologic mesh resulted in a 46% relative reduction in surgical site occurrences, mostly driven by a 61% relative reduction in surgical site infections. There was a 75% reduction in deep surgical site infections and a 66% relative reduction in hernia recurrence. And obviously, this study really changed a lot about the way that I think about using permanent synthetic meshes and biologic meshes, and has heavily driven me to primarily consider the use of these macroporous, reduced weight polypropylene meshes, even in very challenging wound classes. My 7th recommendation is to place drains to avoid seroma formation. This is data from Alfie Carbonell's group again, in which they looked at AHSQC data and did a propensity match study as I described earlier. Now, the primary goal of this study was to look at the length of stay comparing essentially open versus robotic TAR. But there are some additional data points that you can glean from this. They ultimately had 111 robotic TARs, and they matched those to 222, 2-to-1 ratio open TARs. Ignoring their primary outcome of length of stay, open operations used drains about 70% of the time, robotically only 21% of the time. So there were statistically significant differences in how these patients were drained. What they found was that the risk of surgical site occurrences in the open group was only 14%, but it was 32% in the robot case, and that difference was driven primarily by this finding, which is retromuscular seromas. But I want to point out that between these two groups, there was no difference in surgical site occurrences requiring procedural interventions. And so while there were more seromas in the group that did not have drains, in this case, the robotic group, they did not mandate a procedure or a surgery or an intervention. And so if you're concerned about SSOPIs, you may not need to leave drains. If you're just concerned about the absolute rate of surgical site occurrences, then yes, drains can reduce the risk of seroma formation. My final recommendation is to use airway pressures to determine the need for intubation post-op. And this is an older study done by my really good friend Jeff Blatnick when he was a fellow at Case Western working with Dr. Rosen and Novitsky. And they looked at a retrospective analysis of 2 years of open complex reconstruction patients, and they identified 60 patients and a 20% rate of pulmonary complications. And the primary stuff they were looking at was the need for upgrade in care for pulmonary complications or the need for intubation. What they found was that patients who developed respiratory complications had a greater change in their plateau airway pressures, 5.8 versus 2.3 centimeters of water, during their index operation. And what they ultimately determined was the following. If the change in the plateau pressures was greater than 6 centimeters of water, the odds ratio of a pulmonary complication was 8.67. If that change was greater than 9, that odds ratio jumped to 11.5. And what this led to is the algorithm that many people follow, myself included, which is that if the plateau pressure goes up by greater than 6, the patient stays intubated overnight in the ICU. If the plateau pressure goes up by more than 9, I typically leave that patient intubated and chemically paralyzed overnight, and then the next day my anesthesia team in the ICU can begin to wean the sedation and the paralysis. So I'll conclude by saying open ventral hernia repair operations have a very high rate of postoperative morbidity, but that risk mitigation, although it begins preoperatively with optimization, there are a wide array of intraoperative steps that you can take to help reduce the chance of postoperative complications. I want to thank you once again for the opportunity to speak to you all. I'm sorry that we can't be there in person. Hopefully I get to Australia and New Zealand at some point in my career. I look forward to answering your questions, and if it's not answered during the question and answer session, please feel free to reach out to me via email, or you can send me a direct message on Twitter. Well, good afternoon to all my friends in Australia and New Zealand.
Thank you, Eric, for a very lucid talk full of recommendations and a very useful talk to all the surgeons across the world. I hand over the next introduction to my co-chair, Dr. Chris.
Thank you, Eric, and thank you to all the speakers for keeping on time, if not shorter than their allotted time. That really helps to run the program. The next speaker needs very little introduction. David, I think, is not just a rising star, he's actually a risen star. He's a young gun surgeon interested in robotic abdominal wall reconstruction. And I guess as surgeons, we are so focused on technique that he's going to tell us how we can do it better. So he's going to talk, his topic for presentation today is mitigating the risk, intraoperative strategies. This is focused to the MIS approach. So David, take it away. Thank you.
Thanks, Chris. I'm just going to share my PowerPoint. I'm running it live, but I promise I'll run to time. I'll have a timer next to me. So yeah, a lot of great talks today, and there might be a bit of overlap, but I'm going to talk about strategies to reduce risk in minimally invasive surgery. So I do some proctoring for the robot distributor, Da Vinci and Medtronic, and also I should disclose that I've started doing lap ETEP pretty early on after Igor and et al. First reported it. So the minimally invasive hernia repair is evolving. There's been the addition of robotics. There's a lot of new acronyms we've heard already today. IPOM with defect closure, IPOM plus, TAP, ETEP and its cousin Milos, TAR, SCOLA, which is a laparoscopic onlay. And with all these new techniques, there are a unique set of complications. So with IPOM, the most traditional, we are worried always about the pain and nerve entrapment and issues with penetrating fixation, the risk of long-term visceral adhesions, potential for devastating bowel erosions and fistulas. Without defect closure, you can have eventration of the mesh. Moving on to TAP, but pre-peritoneal repairs, there can be a difficult dissection, possibly needing the robot rather than just normal laparoscopy. If you don't make a nice enough peritoneal flap, it can be difficult to cover the mesh. May need to bail out to an IPOM, and there is a risk when you have a extra peritoneal space for mesh that bowel may slip in there, cause bowel obstruction, which is also an issue for ETEP repairs. And they're also more complicated dissection. You can get lost navigating through the retrorectus space. If you're not used to viewing the retrorectus space from that approach, you may get lost and damage normal anatomy. And it's in ETEP where particularly issues like linear alba, linea semilunaris injuries have become an issue. There's also a sort of a nebulous issue, which is I've been aware of, is that some patients get some persisting bulging afterwards, or even new bulging, particularly in the upper abdomen, and be dissatisfied, which is something to consider. Minimally invasive TAR is a difficult operation. The robot makes it easier, but they're long operations, difficult procedures, and there's the potential to get into the wrong plane and cause devastating issues to the linea semilunaris. You can also have bowel obstructions if you get holes in the peritoneal closure. And in these retromuscular repairs, bleeding can be an issue because they're more vascular compared to IPOM repairs. SCOLA is the newest kit on the block, laparoscopic onlay. The main issue with that is seromas and large areas of skin numbness, but also to consider that you need to pick your patients, and if they're more appropriate for a peniculectomy, they may not be happy after the procedure. So the more complex the technique, the more complex the complications. The wise surgeon once said. And in general terms, I'd say when you're learning these new techniques, if you're getting onto the robot, to respect the learning curve. That's a quote from Conrad Ballasser. And also to, choose appropriate techniques for appropriate hernias. So primary ventral hernias like this, don't rush into ETEP, which I may have been guilty of early on in my ETEP experience. This incisional hernias are probably, I think, a better fit for ETEP repairs. And, you can get good results with the robot and a TAR for a complex defect like this. But then choosing ETEP versus, a transabdominal robotic approach like this with dense bowel adhesions to the midline from multiple previous operations. With an ETEP approach, you may run into the bowel and cause bowel injuries. So, and now I'm just going to go over the particular issue with the retromuscular repairs is damage to the abdominal wall. And it seems to be more common or become more of an issue with these new minimally invasive retrorectus repairs. So just to show, this is an ETEP approach, and ETEP repair involves entering the retrorectus space and crossing over safely to the other side. And if you get lost during the crossover and you cause major injury to the linear alba, and devastating sort of issues like this can arise. This is in the theme of complications, this is a video of a robotic ETEP just showing getting lost. And you can see here that rather than dissecting down here, we've gone, or the surgeon has gone above and has taken down the entire linear alba, and this is all subcutaneous fat. And you can see the rectus muscles are separating. And so this, you need to suture these rectus sheaths back together and reinforce with mesh. But this is not a traditional way of doing an ETEP. Other ways of causing injury to the linear alba is once you've, so this is a lap ETEP, we've crossed over initially well, but then going to the other side. This certainly is an issue early on in the learning curve, trying to work out where the opposite rectus muscle is. And then when you see yellow fat there, that should be a clue that you're too medial. And as you can see in a little moment, there's quite a significant defect created before we were able to, you can see a large defect there. So, a patient with a wide diastasis, a tricky crossover, and then you can see there we're getting out more lateral, and that's the opposite retrorectus space. So you need to reinforce that injury to the linear alba and cover with mesh, or you'll end up with an early recurrence. So that the other major problem with these repairs is the injury to the linea semilunaris, which is usually if you're trying to perform a TAR, and that leads to these lateral hernias, but also you damage the nerves and cause denervation of the rectus. So as you can see, the TAR is a good procedure for abdominal wall recon, but you need to make sure that you divide the TA muscle medial to these linea semilunaris, and then get out preperitoneal. I'll just show a video of this is a robotic TAR. So the retrorectus dissection has been done, and you can see the surgeon starting to cut way too high up on the, directly on the linea semilunaris there. And in a moment, there's, see this is a neurovascular bundle that's about to be divided. So this is, an issue with maybe not being familiar with the robotic approach, maybe not being familiar with the technique. The one issue is the camera is looking up, and I think that can predispose you to be dissecting up and onto the abdominal wall, rather than if you flip 30 down, you should dissect down through the posterior sheath to get into the correct plane. So these are, there's a lot of reports on social media, and in the literature of wrong plane TAR, and this is sort of showing how it can happen. I'll just move on. This is showing another case of a robotic TAR. Again, a common theme, I think, is the camera still in 30-degree up mode, and it's a bit blurry, but you can see the posterior sheaths in the foreground here. We should be cutting down through the posterior sheath, but the surgeon is avoiding the nerves here, but is damaging the linea semilinaris out, lateral there. So the dissection should be medial here. So this is just showing how what it should look like. We've got the camera pointed 30-degree down. This is a bottom-up TAR, and what you need to do is develop a cave underneath the posterior sheath, under the, and make sure you've got you're in the preperitoneal space out here, and then you take the peritoneum down off the posterior layer, and then make sure when you do your TA release that you're medial, and you shouldn't be seeing muscle down here like in that previous case. You should just be, there's no, the TA is just a poneurotic down low in the abdomen. So, the keys are to know the anatomy, learn the anatomy, and also, the learning curve of learning open. I think it's important to know the principles of open retrorectus and TAR repairs before trying them on the robot. You need to make sure you always identify the key structures, the linea and the nerves, and then perform your TAR medial, cutting downwards medially to those structures. Think about flipping the camera 30 degrees down. The other issue is issues with posterior closure in these ETEP and TAR repairs. So if you have a failure of the closure, you can get early small bowel obstruction. And it's important to do CT scans if you have any concerns. And this is just showing a case that ended up with a dehiscence. This is an ETEP restoper. Suturing the posterior sheaths together. It doesn't look like there's a lot of tension, but there probably is some tension there. And this is one of the difficulties with these new repairs that we've been appreciating, that if there is too much tension, you can get, or the patient coughs and violently, you can get tearing of that layer, small bowel sneaking in. And so, it's important to be careful about the tension when you're closing. Consider, preserving peritoneum, doing a TAR, but that's, maybe just a partial TAR to help with closure. On the flip side of that, and this is what troubles me a little bit, is that talking to Igor Belyansky recently, he's been finding that patients who get the plication of diastasis with an ETEP and not as satisfied with the cosmetic outcome. With an anterior plication, you roll the rectus in and you get a nice flat surface compared to the ETEP repair. And there are a significant number of patients who do get some bulging of the upper abdomen. And he postulates that it may be related to not closing the posterior sheaths. And this is what we started doing when we were doing ETEP, is leaving the bridging peritoneum there. This is a patient of mine who, she had a recurrent epigastric and umbilical hernia with some diastasis. We did an ETEP. You can see the rectus flattens out and elongates. And it was it looked good on the CT, but she felt that her whole abdomen was just bulging forwards, and wasn't satisfied with that. And so I'd say just to be cautious about using ETEP for patients with primary ventrals and diastasis, maybe other repairs like scolar or just a TAP or IPOM repair. Consider closing the posterior layer, but you need to be careful not to end up. You need to this is a patient that recently I did with a robotic ETEP, and I did drop the pressure and I closed the posterior sheaths together with very closely spaced bites. That's something Eagle's also started doing recently, is now moving back towards closing the posterior sheaths, but I think the jury is still out about this issue. So in conclusion, there's an expanding range of minimally invasive options for ventral hernia repairs. There's new and sometimes complex complications, and you need to understand the complication profile for your choice of operation, mastering the anatomy. There's some good papers out there. I'll put a plug in for EHAM, who gave a good talk earlier, and Romana for landmarks in ETEP, and also a good paper by Conrad Balliser on the critical view for robotic TAR. Thank you. Any questions?
Thanks, David. We might hold the questions just in the interest of time and move on. Thanks very much, David, and you really placed robotic repairs on the map, and thanks for the work that you continue to do. So we might move on. Pramod, do you want to introduce our next speaker?
Yeah, it will be my honor to introduce Lars Jorgensen, who's from Denmark, a very highly accomplished surgeon with lots of publications known for endoscopic component separation. And he will be talking to us on mitigating the risk, what's the evidence, and what's the guideline suggests. So over to Lars Jorgensen. He may not be able to join us live, but we have his talk with us.
Hello, my name is Lars Nannester Jørgensen. It's an honor to be able to present for you here from a cold November evening in Copenhagen. It's a difficult subject. I've been told to present all the evidence and guidelines concerning mitigating the risk in ventral hernia surgery. And first of all, there are many guidelines out there, and I have looked around and taken the most recent ones. And the evidence that I will present now are from the guidelines you see here. Time does not allow to go through all the details and all the evidence there is there, so I'll focus on the major reports from each guideline concerning the level of evidence and strength of recommendation. High level evidence are from RCTs. Moderate level evidence are from upgraded observational studies or downgraded RCTs, whereas low level evidence is mainly from observational studies, and all other kinds of evidence is considered very low evidence. Here's one of the more recent reviews on different aspects of endoscopic surgery. And I have only picked some of the chapters from these guidelines due to time. Considering ventral or incisional hernia repair, it's not surprising that the use of mesh comes out very, very much in favor when you consider recurrent hernias. This has been known for many years now, meaning that in defects more than 1 centimeter size in ventral hernia repair, a mesh is certainly recommended. It might even be recommended, but we still don't have enough evidence for defects less than 1 centimeter if you only consider the risk of hernia recurrence. And this is also supported by a very recent guideline by Nadja Henriksen and co-workers on epigastric and umbilical hernias, that in elective hernia repair, one should use a mesh. Very, very strong evidence, very, very high recommendation. Now, we switch to peristomal hernia repair, and now it gets much more difficult, but because there are so few publications on this. But even though the level of evidence was only moderate, it is very strongly recommended that one does not only use a suture repair in repairing a peristomal hernia. What about obese patients? We know obesity is associated with a high risk of surgical site occurrences. And for such patients in elective hernia repair, laparoscopic repair is definitely worth to consider in patients more than 30, BMI or more than 30. And the risk is higher for recurrence, which also is the reason why certain technical issues are recommended when dealing with obese patients. What about closure of the defect? The recent years have learned us that much fewer adverse hernia site outcomes are seen in patients where the defect is closed, especially seroma, but probably also hernia recurrence. So in laparoscopic IPOM, for surgeons who still use this technique, it's recommended to close the defect. This was also supported in the new recommendation by Reinhard Bittner and colleagues that the defect was closed following laparoscopic IPOM. Now we turn into the question of overlap. We were all taught when we learned how to do laparoscopic IPOM that at least 5 centimeters overlap was required. But actually it seems like this is not enough for bigger hernias, because what has to be considered is the area to defect ratio, which should be above 16:1. This means that the side of the mesh should be at least 4 times the length or transverse measure of the hernia defect in order to reach that ratio. What about bowel injury during laparoscopic hernia repair? Well, it is recommended, not with very high evidence, only low-level evidence, that following repair and antibiotic cover, one can actually consider still using a synthetic mesh if a gross spillage is not encountered. I now turn into some of the recommendations from these recent guidelines on umbilical and epigastric hernia repair. Are these patients, do they benefit from preoperative optimization? Well, very, very weak recommendation, very, very low level of evidence, but still extrapolating from other surgical specialties, it's recommended to avoid smoking 4 to 6 weeks preoperatively, and to try to achieve a BMI below 35. Antibiotic cover, well, is still recommended, although very, very low level of evidence. And this was the reason why it was only given a weak strength of recommendation. Now turning into some of the other guidelines, suddenly when you look at the same issue, the level of evidence was considered moderate, and the recommendation was considered weak. Whereas when we turn to the SAGES guidelines for laparoscopic ventral hernia repair, the quality of the evidence was considered moderate, now given a strong recommendation. And this really demonstrates how much these guidelines differ between them. So this is quite interesting, I think. definitely, and this goes across all the guidelines, that surgical site infections are definitely reduced with minimal invasive endoscopic surgery compared to open surgery, not surprising. What about the use of plastic adhesive drapes, some of them being impregnated with antibiotics? No benefit from this in terms of reducing surgical site infections, and the recommendation behind this is weak, based on low quality evidence. There are some recommendations concerning fixation to the bony structures close to the pelvis in order to reduce hernia recurrence. If the hernia location are close to these bony structures, care should be taken, fixing mesh in the lateral and lower parts of the abdominal wall due to the risk of especially nerve location. The cephalad fixation must be very, very cautious because of the risk of cardiac or pleural injuries. What's the optimal surgical approach for an acute strangulated or incarcerated umbilical or epigastric hernia? Well, it's considered that mesh can still be used in these occasions, given that there is no gross spillage of bowel content. So this really means that you can actually also perform bowel resection under controlled conditions and still use mesh, given that there is intraoperative antibiotic cover. What's the preferred type of mesh in these cases for umbilical or epigastric hernia repair? The authors recommended the use of a flat permanent mesh placed in the preperitoneal plane in these patients. And they gave this diagram for an algorithm for repair depending on the size of the umbilical or epigastric defect. If it was more than 4 centimeters, you should actually consider the hernia as an incisional hernia. Defects between 1 and 4 centimeters always use mesh. As I just mentioned, in the preperitoneal plane, the authors recommended either using laparoscopic technique, especially in patients with a high risk of surgical site morbidity, diabetics, obese patients, whereas open retromuscular or preperitoneal mesh placement is an opportunity in other patients. The debate still goes on whether one should use a mesh or not in patients with defects below 1 centimeter. But as I pointed out before, there is now evidence suggesting that there is also a benefit in terms of reducing recurrence in these kind of patients, but more studies are needed. A few studies on emergency surgery. If it's a clean field, even though it's an emergency situation, mesh repair is advocated with high-level evidence. If it is patients with a CDC wound class 2 potentially contaminated, this includes bowel strangulation or even concomitant need of bowel resection. As I mentioned, the mesh can be used in these situations if there's not a large enteric spillage during the procedure. The situation gets more difficult in contaminated or dirty conditions where a suture repair is recommended if the defect is less than 3 centimeters. And the authors say that one could consider biologic mesh for defects bigger than that. But this is very much being discussed because the rate of recurrence is very, very high, even though a biologic mesh is used for the repair. I think, and interesting recommendation is this one. If fascial closure cannot be achieved even after mesh traction or other techniques during VAC treatment, it's definitely to be recommended to close the skin and come back at another time after the wound have healed for the definitive hernia repair. Now the problem is that most of the guidelines have only reported very weak recommendation. So there is so much still to be done, and definitely more RCTs and registry data are warranted to give us better evidence for the future, because there are so many unanswered questions there. I thank you very much for the opportunity to present for you. I hope that there will still be a great meeting. Thank you very much. Goodbye.
Thank you, Dr. Lars.
Hello, my name is Lars Nannester Jørgensen.
Thank you, Dr. Lars. That was a very detailed presentation on all the evidence for mitigating risk strategies. Chris, would you like to take over and...
Yeah, thanks. We are ahead on time, which is great because we can really have a robust discussion about these topics. I think the next topic is increasingly an interesting topic as we see this cohort of patients who are, the morbidly obese. So we're encountering them at every corner, and the controversy rages about how at what point are they safe, understanding the implications of obesity and its impact on all body systems. And then you have a hernia. So now we've heard today that perhaps waiting is not the right thing because the hernial defect will increase in size. So we're going to hear from Ken Loy. Now, Ken needs very little introduction. And if you're ever in Sydney and you want to visit the best place for the single malt whiskey or a restaurant, be notified today that just contact Ken. And not only will he take you to the best, he probably know the operators of the restaurant as well. So Ken, take it away. Thank you.
Thanks. Can you start my talk? Thank you, Chris. Have you got my talk, or do you want me to?
Yes, sir. Yes, sir. We have your talk. Yes, sir.
Yeah.
We are just sharing it.
Looks a bit stuck. Can't hear it.
Sir, give me a moment, sir.
Ken, do you want to actually run it live?
Happy to do that.
Vama, which would be easier? The Vama team? Can run it live by
Yes, sir. Yes, sir. Yes, sir.
Yeah, why don't you do that? Do that, Ken. Go ahead.
I have to share screen. That's the next talk that I'm getting. I will attempt to share my screen now. Can you see my screen?
Yeah, go ahead. Yeah, go ahead. That's fantastic. Go ahead.
For asking me to present on this topic regarding of obesity and hernia surgery. My name is Ken Loy. I'm a consultant upper GI surgeon in St. George Hospital, and I'm currently the executive treasurer and president-elect of IFSO APC. I guess I have some disclosure to make. I do talks and consultancy for different operations, but this talk is not sponsored by anyone except by the invitations of the ANZ AWR Hernia Committee. So I guess before the lockdown, I have to say that my practice is consistent of mixtures of bariatric and hernia operations. So I guess I got a good and a bad on the both end. And being Asian, I think, when you add those two together, I always say that this is the yin and yang for surgery. Is the yin and yang means that there's always nothing is black and white. Supposedly is black and white, but everything in this, when you mix the two type of surgery together, it's not that black and white, because I think as a surgeons, we always have different thoughts and priorities in our life. And I have to say that the yang is probably bariatric and the yin is actually hernia. In a sense that I think bariatric surgery, I probably more play in terms of what BMI of the persons, and I learned from the surgery that to assess people's body shape, and in terms of also assessing their comorbidity relating to the surgery as well. And we're quite clear on what type of operation we're going to perform, and we have pretty good consent on the patients. And I guess with the yang on the hernia surgery is regarding of this more complex, because sometimes hernia operations really depending on the size, and you have to choose what measures you're going to use. You're going to worry about infections, and you've got to balance about risk of recurrences, etc. In terms of American data, I think they even say that 60% of any patients undergoing any ventral hernia over there has BMI already greater than 35. So really speaking, you really need to understand about the goal of the treatment when you see the patients, whether the patient's primary goal is for you to help them to lose weight, or whether they want you just to fix the hernia. And when they present to you, whether the hernia is just an incidental finding, or whether they're actually symptomatic from it. And I guess you have to assess and play around with the risk of incarcerations, and you also got to understand about the risk of recurrences if you fix the hernia when they're obese as well. I think Americans Hernia Society already have some sort of agreement or guideline or suggestion regarding of what we should do with it. You can go with that, but again, any guideline is merely there for you to utilize it. You might not be taking it as dogmatic. It's really case by case basis, and that's why this topic is hernia quite difficult. So I try to break it down to look at it from different way. So if you try, there are camps or people that really suggesting that hernia should be done before bariatric surgery, then you've got to be aware that the potential post-operative complications such as surgical site infections and the fact that patient hasn't been losing weight, then you've got to counsel against them the higher risk of hernia recurrences. And also, if you decided to do open hernia for big component separation, it may actually, in fact, affect the potential future laparoscopic surgery for bariatric patients as well. And I guess we're dealing with a patient with huge abdominal wall, huge inter-abdominal pressures, and the abdominal wall compliances might not be great. So you've got to consider other way to help your surgery. And at the end, as I say before, is about which one come first, and what specialty you are, and what sort of specialty support you have in your country and your hospital in terms of access for hernia and bariatric surgery. And if you think that there's a group of people also suggesting that maybe we should do bariatric surgery first before hernia repair, in some countries, it's a bit of a luxury because sometimes public bariatric patients in Australia is not that accessible. But whereas in American, I think it's quite a clear guideline on what patient will be qualified for surgery. And there are studies that saying that we should, in fact, generally speaking, in my practice, in fact, not only just more than BMI 35, I think 50, BMI more than 40, I would start considering if the patient should have bariatric surgery first to lose weight, to actually reduce the complications. And I think also people saying that if you, in fact, is quite safe to actually watch the hernia, you should make them lose weight first, and the risk of emergency strangulation of hernia is quite low. It's only 3% in Kokotovic study. But I guess you have to keep a close eye on them, and if they get pain presentations after the bariatric surgery, you should operate on them. And a lot of patients that, if they are found to have asymptomatic patients, you probably should try to look at that carefully during the operations, but not to reduce the hernia, since there'll be chances that you can actually have bowel trap there, and that will ruin your beautiful gastric bypass or sleeve gastrectomy repair. And also the patients sometimes are amenable to have their hernia repair, because a lot of them, after they successfully lose weight, they will or may undergo abdominoplasty, which we can then fix the hernia at the same time. What about if you try to fix the hernia at the same time of the bariatric operations? The consensus guideline really draw on the line that depending on the size of the defect, either is incidental or prepares, or the surgery is prepared to fix the hernia, or that there's a planned hernia surgery at the same time. I really would advise that based on my experience. I think it's really depending on patients in terms of the risk factors. I think male patients, sizable intra-abdominal pressures, body shape problems, narrow costal margins, all these things are playing mind, and of course the size and the defect. There are studies actually looking at analysis from UK's bariatric database, and they kind of draw the line around defining the type of hernia on 5 centimeters or 5 to 10 centimeter or greater than 10 centimeter, and essentially say that surgery probably in fact is quite safe in most of the cases to actually leave alone. But the bigger the size of it, then the chances of recurrence is higher comparingly, because also patients will have comorbidity as well. And George Eade and their group very early in the state already told us that, I think, when they try to repair hernia, it doesn't matter what sort of meshes they use. In fact, it's quite safe to actually use mesh rather than suture repair, because if you're simply using suture to bring fascia together in defect size, doesn't matter what size it is, the repair rate usually is higher. And if you defer the repair by just simply reducing the hernia, your incidence of bowel obstruction will be quite high afterwards. And they follow up with actually another paper afterwards, saying that if you got patient with adhesiolysis at the same time, you should fix it, and you should actually fix the hernia together with bariatric surgery. And some of the other study also say that a lot of the large size ventral hernia, in fact, should not be reduced if it doesn't interfere with the operations. I think Spain, my friend Ramon Villalonga tried to attempt to draw some conclusion in terms of what patients should go for what operations. You can go down the pathway of either bariatric surgery with hernia repair or ventral hernia repair, then bariatric surgery, or at the same time. Essentially, the algorithm is there, but it really then listed out the potential risk of bowel obstruction afterwards for people to consider and quote to the patients. And the Italian group, which based on the European hernia study guideline, I think the defect size they draw on is 4 centimeters. And once we get past this threshold, really depending on symptomatic or asymptomatic surgery. And I think another group that's saying that the roles of the size defect is also important as well. I guess my suggestion in summary is that you need to assess the primary goal and what you want to achieve for the patients. And in our experience, we really find that 2 to 4 weeks of OptiFast, if the patients can wait, will improve, doesn't matter what type of operation you do, even cancer surgery sometimes, or gallbladder surgery, because it will create more abdominal space and less abdominal tensions. And increasingly, if it is affordable, then chemical component separations can be considered to be utilized for some of the hernia repair if you just purely want to tackle the hernia based when the patient doesn't really need or want or have access for bariatric surgery and doesn't want to wait as well. And if you have an incidental finding on hernia during bariatric surgery, unless they are symptomatic, better not touch it. If you touch it, you fix it. I think that's the rule, either by method, and it's quite safe, relatively speaking, to use mesh as well. And if your patients have either hernia surgery who are obese or that have operations, or if patients who have bariatric surgery and waiting for hernia repair, we need to keep a close eye on these patients to interfere at the correct and right timing. So these are the references. And I guess if I'm running out of time, I think there are a lot of case study, but I'm telling you, if these 3 people need to have surgery, I reckon Mr. Kim's surgery will be the most difficult operations based on the fact of amount of intra-abdominal fat. So hopefully you enjoy the talk, and I look forward to hear from other speakers and learn from them. Thank you very much.
Yeah, thank you, Ken. That was a good talk. We've got a few minutes now to open up for questions. I have Eric Pauli still alive. Eric, thank you for staying up. It must be fairly late for you in your part of the world, so thank you. I know that you've been a fairly strong advocate for bariatric surgery first. Can you tell us your thinking about that? Because I've seen your publications and they unequivocally state that you should just do the bariatric surgery first, get the patient better overall, fix the hernia later.
Yeah, so I mean, I guess what I'll say is in that group of patients, these were people who required complex abdominal wall surgeries. They weren't smaller defects that were potentially repairable with other methods. And so we knew that weight loss was sort of going to be part of the algorithm. Second, all of our surgeries were done by a team of experts, bariatric surgeons at an ASMBS Center of Excellence with capable hernia surgeons available in the event of a hernia-related emergency, and also with advanced endoluminal capabilities. My other career is an endoscopic surgeon. And so while we worry about sleeve leaks, we don't worry about them the way we used to because we can manage a lot of them endoscopically. And so what that means is that patients can get surgeries by qualified experts, can have their hernias monitored, as Ken was just saying, and followed up in both the short and the long term. And we really don't have to reoperate on these folks for bariatric related complications to the degree that we maybe had to 10 years ago. And I think when you put all that together, it heavily favors doing the bariatric surgery up front. And we have a myriad of patients who have gone through our program, including the ones in the publication that you referenced, who have had a very successful outcome. We had one patient fail, and that patient was having bowel obstructive symptoms while going through the bariatric program. And by the time he showed up for his weight loss operation, his BMI was actually less than 35. He was no longer a candidate for weight loss surgery. He was immediately referred back to me. He got a hernia surgery, management of his bowel obstructive issues, and a complex reconstruction. So on some level, he succeeded even though he failed and didn't get a bariatric operation.
Thank you, Eric. Any other questions? I have maybe Vahan, if you can take a minute. What's your practice? You're seeing these patients increasingly frequently now. They're presenting with hernia, but they have this comorbidity of obesity. How do you manage? What's your practical approach?
Very similar to Dr. Pauli's approach. We have a wonderful group of bariatric surgeons. We oftentimes will integrate the patients into the bariatric program, even if they're not necessarily going to go through with surgery. And they have such a wonderful multidisciplinary team with physiotherapists, endocrinologists, and all these other things that get the patients optimized, get the patient's weight trajectory in the sort of way that we want it, and then we're able to have a more successful outcome with regard to our optimization strategies. And so again, it's all about trajectory. For many of our patients, we're seeing much more success when we integrate this multidisciplinary approach for optimization, and our bariatric programs oftentimes already have those things in place. So we're sort of riding their coattails to success.
Thank you so much. Any other questions on any of the topics that we've discussed? David, I've got a question for you. In terms of the newer techniques, we've seen a swing, if you like. Initially, when robotic retrorectus came in, everyone was doing it for every hernia, and then it swung back the other way to where it was really now open to a limited group of patients. Are you clear about what that group is increasingly?
I guess, definitely if you mean robotic ETEP, definitely that's become more selective. I guess it's really, there's lots of options, and I think I'm getting it more clear in my mind, but I think IPOM and TAP for the simpler hernias. I prefer TAP with the robot, but laparoscopically, that's a bit more difficult. But ETAP I'm reserving more for incisional hernias, or if there's a hernia within a large diastasis and you want to do a proper retrorectus. The indications are kind of sharpening up rather than being all comers for ETAP, which I don't think is the right approach.
Thanks, David. Any other questions? We still have about 5 minutes.
I think Chris, one of our senior faculty, Dr. Ramesh Punjani had a question for Eric regarding the irrigation fluid that he recommended. So Eric, we really wanted to know what is the composition of the irrigation fluid, especially the dosages that you use. You've recommended clindamycin with gentamicin. I mean, that was the recommendation which was found to be most effective. So
yeah, both of the total concentrations are in that study by Warren. I want to say, gosh, maybe Charlotte remembers.
Yeah, I do, because I also use it all the time. It's 600 milligrams of clindamycin, 240 of genta, and 500 of saline. And you just pour it in, leave it for 5 minutes, and then suck it out.
Thank you.
Yeah, it's about the most unexciting part of the operation. Like I used, before we did the rinse trial, I was using a pulse lavage, and it's like active and like it's really exciting. The residents get to do something, but with the rinse trial irrigation, like you pour it in and you set a watch for 3 to 5 minutes and you just wait. I mean, nothing happens. It's pretty boring.
Yeah. Ken, you have a question? Ken Loy, you got a question?
Yeah, I think or more like a comment. I think after listening to all your guys talk, I think the elephant in the room, in fact, is probably about costing and medical health system that you are in. I think it will be luxury like in America, when we look at all the data, have strong resources in each team, and especially bariatric surgery. After I've been doing it for so long, it's quite a multidisciplinary thing. Whereas hernia in Australia is still done in a way that is a bit haphazard. But if you're dealing with some of those more complex patients, and I think this approach needs to be adopted like the orthopedic surgery to make it more successful. At the end of the day, I think we've written a paper about the cost of obesity versus the cost of COVID and a pandemic. I think the only way to convince the payer or the insurance is that prevention of complication in all ways is good and is require resources and input at preventative level rather than actually at the treatment on the other end.
Thanks, Ken. We've got still a couple of minutes. Any final questions before we summarize? I think it's been a great session. There's been some
Chris, I popped the question in the chat earlier, but I'll ask of Vangan. So, I struggle a little bit with the data that you presented about smoking cessation. So I absolutely mandate smoking cessation, and I definitely do nicotine testing on people. But you've got this AHS-QC study that says it doesn't make a difference, right? And so, the question is, how do you justify the fact that a prospectively collected data does not suggest that smoking makes a difference, but yet you and I both make people stop smoking?
Yeah, well, I mean, it's the overwhelming body of evidence that shows that smoking cessation in a variety of operations is associated with better outcomes. The study that was done out of ACH-QC was a very heterogeneous group of patients and a very heterogeneous group of surgeons. When you look at the data, it's hard to sort of know exactly which patient population is sort of leading or pushing that data towards demonstrating no significant differences between the two cohorts. Further, I really look at our operations as like, we want to do it as well as we can the next time we operate. And so I try to really stress to the patients the importance of preparing as well as they can to maximize their outcome. And for myself, I just, again, and my team and my partners, we still want, if there's going to be more data to support active or operating as active smokers, sure, we'll consider it. But right now, we're really supporting patients and trying to optimize and make sure that they're not smoking. I don't know. Anyone else in the group think that?
Yeah, no, I agree. I think it's that thing about often we're a select group and we see the people at the tip of the iceberg that have had 4 or 5 goes before and have had bad outcomes. And so I think you just have to do absolutely everything to improve your chances. And even if the statistics don't suggest that smoking cessation makes a great deal of difference, it's just one extra thing that you've done that helps in the overall outcome, I reckon. So I also think it helps determine how much the patient wants to be involved in their own outcome too.
Well,
Can I comment on smokers?
Yeah, recently we had a debate on bariatric surgery.
As a smoker, Charlotte, you want to comment?
I operate on smokers all of the time. I think, obviously I trained with the people that put out that data, and was there while they started transitioning to smoking all the time. Certainly they did show that there was a difference between smokers and non-smokers, but it was that there was a higher incidence of seromas. And since most of the time there is nothing to be done about seromas, the question is, when you have these super large databases like NISQIP, and you're looking at hundreds of thousands of patients, you look at things that are statistically significant, but whether or not they're clinically significant makes a difference. And that data actually looked at people that were never ever smokers to people that were currently actively smoking. So a lot of times the data says people that were, quit in the 4 weeks before the operation. So in order to make the data as clean as possible, they chose never ever smokers, and then I'm actively smoking at the time of the operation. And they've actually come up with some new data that shows that if you have a seroma post-operatively, it does not affect your recurrence rate. And so the question is you're right, these patients are complex. Oftentimes we're the last people that want to be operating on them. And I think truly we don't know entirely yet. So I do know that there are some, they're going to be analyzing their patients after they have operated on a whole bunch of smokers to say, hey, did it really, did the ACHQC analysis that we looked at actually happen in real life? But I will say I operate on smokers routinely. I think obviously like a lap inguinal is much different than open complex abdominal reconstruction. I think that you can counsel the patient with say, hey, we have, data suggests that you're a high rate of a wound infection, but also, Hennifer just says the longer you wait in these obese patients, they get much bigger. And so, if someone's going to take a year to quit smoking and that you're probably just going to have to be dealing with a seroma, like when is the right time to go? Obviously there's people that are smoking 4 packs a day and there's people that are smoking like 2 cigarettes a day. And, all of nicotine is bad. And I do think quitting smoking is important for a patient just for their health. But I think, there is a lot of data about smoking and really trying to get some better data about smoking in the hernia field is important, but I don't think it's as bad as everyone says.
I support Dr. Horn's opinion in this because she's my partner. And if I have somebody quit smoking, I know where to send them. It's perfect for me.
So one of the things that's important is much of the data looks at what happens to smokers that we operate upon. What we need to really know, and what each individual surgeon and group needs to analyze, is how successful they are in their preoperative optimization strategies. There isn't a lot of data on that, knowing, okay, when a patient comes in smoking, what is your rate of converting someone to a non-smoker before you operate on them? Are we having huge disparities in care because we're not operating on smokers? And what happens to these patients if we don't operate on them? So that's going to be, I think, another opportunity for further QI in hernia, is understanding what happens to patients that we're trying to optimize, at least more granular data on the pre-op setting.
Thanks, guys. I think in the interest of time, we might pull the pin there because it's moving into the next session. I want to take this opportunity to thank all the speakers, particularly our North American friends who stayed up. Thank you again for a great session.
Thank you, everyone. Thanks a lot.
So I think we move to the next session now. We have a very exciting now. We saw how the risk can be mitigated, but now we have to see that how if the complication happen, how do we tackle them? So I have a co-chairperson with me, Philip Gann. So Philip Gann is from Australia, Victoria. He's a minimal access and bariatric and upper GI surgeon. And in fact, he has innovated some of his retractors, which I just saw it on a net. I have also Dr. Sharad Sharma, who is from India. He is our very dynamic person of AWRSC India. And both of them are going to co-chair it. So Philip, can you introduce Charlotte, our first speaker?
Yes. So our first speaker is Dr. Charlotte Horn, whom we've just heard from directly already. She'll be talking on bowel complications, obstruction and fistulae. So Dr. Horn's originally from Alberta, Canada, trained at Cleveland Clinic with a fellowship in complex abdominal wall reconstructions and minimally invasive surgery. So she treats complex hernias, chronic mesh complications, and chronic groin pain. So yes, she's the person to get to know to send all the difficult patients. Also on faculty at ERCAD as a web surge contributor. Thank you. Can we start that complication? Is that going live or pre-recorded?
So it's a pre-recorded.
Thanks.
Good afternoon. My name is Dr. Charlotte Horn, and I'm an assistant professor of surgery at Penn State Health. And I will be talking about bowel complications after abdominal reconstruction. I'd like to thank the organizers of this conference, as well as the ANZ and AWR surgical societies, for inviting me to speak today. The only disclosure that I have, which is not relevant to this talk, is that I'm a consultant for Medtronic. So the goals of my talk today are kind of briefly touch on some intraoperative bowel complications, and then the majority of my talk will be talking about how to manage and think through some postoperative bowel complications. So intraoperatively, you have an enterotomy, now what? And I think the biggest question is, do you complete the intended operation or do you bail out? And when you are facing this situation, there's a couple of questions that you need to ask yourself. Will you be able to get the defect closed if you just do a primary repair? Are there possible bailout surgical options, including a bridge repair or a different mesh? How does this change your mesh choice if it does? And then what other things can you do while you're in the OR to optimize your post-operative outcomes? Does that mean lavaging the posterior sheath if you're doing a retromuscular repair? How are you going to close the skin? And then intraoperative and postoperative antibiotics. And so there is some data to suggest how we should manage these situations and what the risks are of an inadvertent enterotomy. And Kripat et al. Looked at this. They looked at over 5,000 cases in the ACHQC. This was a retrospective analysis. They identified an inadvertent enterotomy rate of 1.9%, and this was equivalent in lap versus open cases. They actually saw that there was an increased risk of complications in patients that had bowel injuries, both increased length of stay, reoperations, readmissions, mortality, and there was an controlling for other patient factors. The highest risk of complication was actually a surgical site infection. And so what we do know in these situations is that you're at a much higher risk of a surgical site infection and complications overall, but care should be taken to optimize the patient in the OR as much as possible to mitigate against these risks. Interesting, what they did show is whether or not mesh was used, the complication profile kind of fit the same thing. So whether or not there was mesh, there really didn't change the complication profile postoperatively. And so I think the things that you need to consider when you've made an enterotomy in the OR is this something that's a small hole that can be fixed primarily? Do you need to do a bowel resection? Where are you in terms of your adhesive lysis? Right at the beginning, things are going to be far more complex. And so how complex is the bowel work? How complex is your abdominal reconstruction? Are you doing a redo TAR? Is there mesh that you need to take out? Are they missing components of their abdominal wall already? And then try to consider the complexity of this patient. Do they have diabetes? Are they a smoker? Do they have chronic kidney disease? And so all of those things are going to increase the technical complexity of the case, the time that the person's on the OR table, and the likelihood that they're going to have a complication afterwards. So I think if those things are complex, that when in doubt, bail out. But you also can consider your other operative options. All right, so we're going to switch gears after I touch base on this, that as other speakers will touch base on it or have already in this conference, to postoperative bowel complications. Obviously, after you've done a complex abdominal reconstruction, nothing is more humbling than a postoperative bowel complication. And so we really need to figure out how to take care of these and what's the best thing to do for these patients. And so I'm going to start with a case of my own. This was a 44-year-old female. She had a history of bladder cancer and had undergone a robotic radical cystectomy and had an ileal conduit. She'd also undergone a previous laparoscopic epigastric hernia repair. And she unfortunately developed a very large peristomal hernia and had obstructive hydronephrosis because of this peristomal hernia. And she actually had to have bilateral PERC neph tubes because her conduit wasn't working. She was not a well-optimized patient when I saw her. Her diabetes was poorly controlled. She actually came in with a blood sugar of 400 one day when we were trying to do her definitive repair. She had chronic pain, anxiety, and she had Crohn's disease. And so this is her preoperative scan. You can see that she has an intraperitoneal mesh with some tacks in place, a very large peristomal hernia. And so she actually did well. We did an open polyperistomal hernia repair with a medium weight retromuscular piece of mesh. She had a return bowel function on postoperative day 4, obviously some issues with pain and blood sugar control, but she actually went home on postoperative day 6 tolerating a diet. I get a call from the outside hospital 4 weeks afterwards and from the person there, and they said, you know what, your patient's here, she's nauseous, she's vomiting, and she's got a bowel obstruction. And so of course they say, like, don't worry about her, send her here, we'll take care of her. And so this is her postoperative scan that she has. So things to kind of consider, especially in this case when we did a conduit, is it something at the conduit that's the problem? You know, is there an intraparietal hernia, or does she just have a regular adhesive bowel obstruction, or, you know, any sort of recurrence? And so her CT scan showed that she had a transition point in her right lower quadrant down here. And so we brought her in and she did relatively okay. And she actually, we decompressed her for 48 hours. She had return of bowel function on hospital day 2. My rule is if you come in with a bowel obstruction, I want you to be tolerating our low residual diet for 24 hours before going home, which she did. She actually did pretty okay for 6 weeks or 4 weeks after her readmission. And then unfortunately I get another call. She's again in another outside hospital. She's nauseous, large volume emesis. Her conduit is functioning, but she hasn't had a bowel movement in a couple of days. And then again, we got a CT scan that showed her conduit looks okay over here. Again, there's no intraparietal hernia, no breakdown in the posterior sheath, but she does have this persistent right lower quadrant transition point. And so since my surgery was open, I said, well, you know, this is probably adhesion. Hopefully, you know, we got away with the first time managing it inoperatively. Let's try that again. And so she came in, was decompressed with an NG tube, and then was still sort of passing gas, questionable. So we got a small bowel follow through, and of course there was no contrast into the colon. So what do you do now? Obviously I'm 8 weeks out of her original operation. Her peristomal hernia repair looks okay, but she has this persistent right lower quadrant obstruction. And do you decompress? Do you reoperate? And I think this is where imaging is very helpful in making our decision. Number one, you can localize to a definitive transition point, then an attempt at laparoscopy is reasonable. I think you need to think about how soon you have had an obstruction after abdominal reconstruction. And so things to consider that are unique, especially if you're doing a retromuscular repair, is do you have intraparietal hernia, so breakdown of your posterior sheath, which can be the cause of an obstruction? Is the patient stable? Is this something that you can manage non-operatively? And then where is your mesh and what sort of repair that you did you do? Obviously, if you've had a retromuscular piece of mesh and it's pretty soon after and you have a posterior sheath breakdown, you might be stuck kind of redoing the whole operation, which is okay. Whereas, you know, we're 8 weeks now in this patient, so I kind of knew that I was going to have to either manage this with a laparoscopy or cut through my mesh because the peristomal part looked okay. And so I think when you're returning to the OR, you have to first figure out why you're returning to the OR. So if this is an intraparietal hernia, you got to take everything down. Hopefully those are found in the early post-operative situation. And so just sort of redoing your repair would probably be most appropriate. If you have an adhesive bowel obstruction, like we did in this case, then attempt at laparoscopy is reasonably, and you're really trying to mitigate cutting through your whole mesh because you know that that's at a higher rate of recurrence in those situations. However, if you're putting ports in or you need to do a laparotomy, close your mesh with permanent sutures. And one of the things that I do is I'll close that mesh in layers. So there is a layer of the mesh that's closed with the proline. Then I use a slowly absorbable monofilament suture for my anterior sheath and try to close this deep dermis and skin in layers as well. Because I do know as I've cut through this midline a few times, she's at a higher risk, or they're at a higher risk of surgical site incurrence or infection. So these are my take-home points for managing a postoperative bowel complication. Number one, if it's not a posterior sheath breakdown, hopefully postoperative bowel obstructions can be managed non-operatively. And I think this is sort of in the world of open surgery, especially if you're doing these robotic or minimally invasive things. You wouldn't presume that they would have a lot of adhesion. So there should be some concern for people that have bowel obstructions in those situations. If you failed non-operative management, attempt at laparoscopy is reasonable. Oftentimes you have momentum stuck to your posterior sheath, but in general, if you operate early, you should be able to kind of gently dissect that down and hopefully minimize the damage to your mesh. And then I think in general, if you have any concern about your patient and you have an early postoperative bowel obstruction, try to get to those patients within the first 2 weeks, because you're more likely to be successful in terms of laparoscopy, as well as, if you have to redo your repair, your mesh is not going to be incorporated well. So that is something that can be done, kind of in the 2 to 8 week range. Certainly there is dense scar tissue, which can cause more harm than good. And then after 8 weeks, your mesh is incorporated. And so, redoing the operation in that situation can be very, very challenging. So now we're going to switch gears to fistulas after abdominal reconstructions. Obviously, these are super devastating and nobody wants to see them, but we really need to take a step back and kind of work together with our patients when these happen in order to give them the best outcome. And it's always great when someone has sent you a fistula and you haven't done the abdominal reconstruction, because these are fairly rewarding. But I think they're very challenging for the surgeon as well as the patient for a couple of reasons. Number one, this is not great for the patient. They have leaking that's coming out. Oftentimes they're not eating because they're on TPN. And they can have a lot of skin breakdown because of the effluent that's coming out of their fistula. And in terms of a surgeon, you're kind of dealing with not a great situation. Oftentimes it's hard to optimize these patients. So I'm going to talk about some things that we can do preoperatively and intraoperatively, as well as what I do for postoperative care for these patients. So I think the first thing you need to do is kind of define how much the fistula is putting out and do everything that you can do to decrease the fistula output. Second thing that's very important is to protect the skin as much as possible. And then lastly, optimize the patient and yourself for the surgery. So that's nutrition, trying to change as many modifiable factors as possible. And then while you're doing that, localize the fistula and try to get as much information as you can about the patient. And so when it comes to decreasing the fistula output, obviously enteral nutrition is preferred if possible, but for some of these more proximal fistulas, that is just not an option, as these will increase the output and that can cause a lot of skin breakdown. So in general, TPN is often utilized in these patients. And I think one of the advantages for TPN is that it minimizes the electrolyte derangements of the patient, especially with these higher volume things that can kind of keep them from being hypovolemic. And most importantly, it allows them to not be in a catabolic state. So they have a positive nitrogen balance and they're able to at least maintain their nutrition status. In general, TPN should focus on getting enough protein at a rate of 1.5 to 2 kilograms per gram per day for an adult. So a lot of the patients are on either TPN, a combination of TPN and some amount of diet, in order to really kind of decrease the output and also maintain their nutritional status. Another thing that is an option in patients, especially with they have higher output fistulas, is the use of somatostatin analogs, including octreotide. And this was some data from the ASPEN clinical guidelines that look at the management of intracutaneous fistulas. And they actually looked at multiple randomized controlled trials, and they found that the use of a somatostatin analog, whether IV or intramuscular, actually decreased the fistula output and also in some situations decreased or improved the spontaneous fistula closure rate. And I think, the main reason I use it in my patients is that it decreases the fistula output. I obviously don't expect these fistulas to close because a lot of times the problem is that they have mesh involved. And so the likelihood of that closing is very low, but at least we can decrease the output to something that's manageable for the patient. I think one of the most important things is to protect the skin as much as possible. So anything that you can do to decrease and minimize and keep that effluent off the skin is important for a couple of reasons. Number one, it causes a terrible chemical burn to the patients and can be very, very uncomfortable. On top of that, you're going to have to deal with that skin in the OR, and you already know that you're going to be left with a large defect. And the last thing you want to be left with is a soft tissue defect, which would require a flap or other challenging things in order to get this closed in a situation that's already contaminated. And so options are wound managers, as you see on the right here. Other things that are great that everybody has are diapers, feminine pads. All of these things are very beneficial and great job at absorbing some of this output. In general, if wound care or home health care is available for those patients, those agencies should be involved because they can help change these things and try to educating the patients as much as possible on how to protect their skin and what they can do is really helpful prior to returning to the OR. And then I think the last thing that's important to do before you take these patients back to the OR is get as much information as yourself as possible, and then really try to finalize some of the things that you can do to optimize the patient. So I always get all the old imaging and op notes. This is a patient that I operated on for a fistula recently. He actually had a Hartman's and then a subsequent reversal. He had a previous onlay mesh that you can see here. He developed a big hernia at his previous ileostomy site. And he had a TAR done in that situation. And you can see he actually has continuity of his abdominal wall here. Unfortunately, he developed a fistula through that mesh. And so I know that I have a retromuscular piece of mesh. I have a onlay piece of mesh, and I do know that he's kind of got a fistula in the middle of the abdomen here. I think the other thing that you can do is corroborate your imaging with the old op notes, and all op notes should be hunted down so that you can figure out what mesh was there, where it's placed, and the sizes of the mesh. And then lastly, try to optimize the patient as much as possible. And this is really challenging because especially in those more obese patients, it's really hard to get people to lose weight on TPN. And if they are losing weight, it might not be healthy. Things that are easy to take care of are like telling them to quit smoking, and trying your best to decrease their HbA1c. But in general, these patients are going to get close, but they're probably never going to be perfect. So at some point, you do just have to bite the bullet and operate on these patients. And so how do you set yourself up for success in the OR? I think the first thing is start at normal anatomy. Whenever I see these patients preoperatively, I say, you're going to get a big incision. We're doing this for a fistula. This is not a cosmetic operation. And if I preface the operation with that, they're okay. You do know that there's going to be some devastation to the abdominal wall, and you might be the cause of it. But I think if you are going to, veer off midline in order to prevent your enterotomies, I think that that's a noble cause. And so in situations, I will start midline, get up nice and high, far away from the fistula, and then work down and kind of surround the fistula. And if that means, I'm not quite midline, that's okay. Because in general, I like to just have the fistula be the only enterotomy that happens. In these cases, obviously, you're dealing with bowel that's stuck to mesh or mesh eroding into bowel, and that can be very challenging to take down and can get out of hand pretty quickly. So everything I can do to make this operation easy for me is something that I will do. So you can see here, we've started at the midline. We now have the whole left side of the patient's abdomen open. We're working below the fistula. And this is our fistula. It's kind of just up. And my goal is to kind of get that up so I can look at it and come across it. And I have a nice horizon of just the fistula so I can see what's safe and what is truly attached to the mesh there. So that's what we have done here. We've kind of further started to surround by lysing adhesions both inferiorly and superiorly to our fistula. And now I'm completely behind it. The only loop of bowel that I have up is the fistula itself, and there's a piece of mesh eroding into the bowel that you can see there. So after you've gotten the fistula down, you can determine how you want to do your reconstruction. I routinely run all of the bowel. I want to make sure I know that there's no enterotomies or mis-serosal injuries because the lysis of adhesion can be challenging. I want to make sure I know how much bowel length they have. So if I have to resect the large chunk, I can make sure they're not going to have short gut. And then I want to make sure that all of their other previous anastomoses, if they have any, are not twisted or kinked, because I want to make sure everything lies flat. Because part of this is taking down the fistula, but the other part of this operation is kind of setting yourself up if they do have a hernia. And you want to make sure that you're happy with everything, because chances are you're going to be the person that's coming back. So the next thing to do in part of optimizing the abdominal wall for your return is to remove all of the mesh. And there are pretty much no situations where I would leave mesh in these situations, because you do know that it's been contaminated and the risk of you having a wound complication afterwards is already high. And so if you've had a prosthetic in there, then it's probably just going to be a persistent wound infection. So in these situations, all of the mesh comes out. Onlay, sublay, retromuscular, all of that mesh comes out. Tacks come out, Prolene sutures come out. I want nothing to be there except for the stuff there. This also gives me an opportunity to kind of analyze their abdominal wall. And I'll often put little breadcrumbs in my op notes so that I know what is left behind when I'm done. So when I go back and have to do the hernia repair down the future, I know what's there and what's going to be challenging. And then fascial closure. Obviously, when you've removed a piece of mesh and debrided your anterior fascia back to healthy things, you are left with a sizable defect. My preference of closure is a figure of 8. I think that I can get pretty big defects closed. Yes, they're on tension. No, do I think this stitch is perfect? No, but I do think that it mitigates the stress across multiple stitches versus 2 running ones. So in general, I'll do figure of 8s top to bottom and close them, and that works most of the time. If you're on amount of undue tension, and I think in these situations when you're thinking that their plateau pressures are increasing, then a inlay, phasix, or vicryl mesh, a slowly reabsorbable mesh is totally fine, probably better than a biologic in these situations. And the goal is to really minimize the defect that they have. And then I always like to do nylons for my skin. I know that my closure is not going to be perfect. And the goal that I'm trying to achieve with these operations is, number one, take down the fistula, restore intestinal continuity, mitigate any sort of serious complications. So with that respect, I mean like a dehiscence. And so both the figure of 8s as well as a long or permanent skin suture work really well, because heaven forbid one of those figure of 8s comes apart, at least I have the skin closed, so they're not going to eviscerate, but they will dehisce. And I leave those sutures for a month, and they come out in the office. And in general, it actually looks pretty good when things are all done. Obviously, if you have spaces in the sub-Q, drains are appropriate, incisional vacs are appropriate. And I don't think there's any real data to suggest one thing is better than the other, but just be aware that you're at a higher risk of a surgical site infection in these situations. So things that you can do to kind of mitigate those complications are appropriate. In general, patients always get an NG tube because I know the adhesive lysis is going to be complex. And on top of that, I'm unsure how their bowel function is going to resume because they've been on TPN. Patients will always get 24 hours of antibiotics, 48 to 4 days if there is any sort of gross contamination of mesh. I continue TPN on postoperative day 0. So after they're done, they go back on their home TPN just to allow their bowels time to wake up. And then I also like to image early if there are any derangements. And this is the same practice that I have for even my complex abdominal reconstructions without fistulas. And I think, you have to realize that these surgeries are very challenging. There's many ways that an operation can go wrong. And so whether it's an inadvertent enterotomy that's missed, there can be an obstruction of urine anastomosis, contamination that leads to an intra-abdominal abscess. And I think the goal that I have with early imaging is to find problems when they're small before they become big. And so actually one of the best ways to know whether or not your patient is doing well is to look at their heart rate. And this was a study by Haskins et al. That looked at patients undergoing complex abdominal reconstructions and whether or not postoperative tachycardia could predict serious events. And they actually were able to say that if patients that were tachycardic and had sustained tachycardia were at a higher rate of basically all types of complications. So infections, bleeding, VTE complications, leaks. And so whenever a patient isn't sort of doing what I'm doing, especially in these more complex multiple part operations, the moment there are fevers, tachycardia, anything like that, I scan early and I'll scan often just so I know that things are okay. And then I can manage them aggressively after that. So my take home points for this talk are, in terms of managing postoperative abdominal reconstruction fistulas, it's challenging for both you and the patient. And a lot of times it takes a lot of time to just get the patient ready to go. But that time is important to invest, and you should optimize the patients as much as possible. When you're in the OR, these surgeries can be very challenging and the adhesive lysis can be just terrible. So do your best to surround the fistula, stay in normal anatomy as much as possible, and try to really attack that fistula once you've got everything down. And then lastly, it's super important to remove all of the mesh and set yourself up for your subsequent operation. Thank you so much for inviting me to this conference. It was an absolute pleasure.
Thank you, Dr. Charlotte. I think that was an exciting talk, very detailed. I really appreciate the way you have described the way you would tackle a fistula. Maybe we can take the questions later and move on to our next speaker. It will be Dr. Naum Winter, and he's an anesthetist. He specializes in pain medicine, and he's a pain medicine physician at Melbourne. He has special interest in post-surgical pain syndromes, and he actually is a very prolific academician, and he has been a pain medicine scientific convener in one of the conferences at Melbourne. I welcome Dr. Naum Winter to please give his talk.
Good afternoon, everyone. My name is Dr. Noam Winter. I'm an anaesthetist and pain specialist based in full-time public practice in Melbourne. And today I'm going to be talking about chronic pain after hernia repair. I'd like to thank the organisers for giving me the opportunity to speak with a group of hernia aficionados about a topic that I feel quite passionately about. I've got no specific disclosures related to industry. Obviously, I'm not a surgeon, so I'm not going to talk about surgical factors. And I'm going to assume that surgical complications have already been excluded. So really, when we talk about any pain, we can generally put it into two main mechanisms. Pain can be considered either nociceptive, where the pain relates to inflammation or tissue damage, or it can be neuropathic, where the pain relates to a lesion or damage to either the peripheral nerves or the central nervous system. And obviously, you can have a combination of the two, where we call it mixed pain. When we're dealing with post-hernia chronic pain, it generally has to occur in the same area as where the surgery took place and or the nerve territory that supplied it. Now, there's a bit of discrepancy in the literature whether it takes place from 3 months or 6 months. I personally use 6 months in my definition, as I believe that there's a lot of mesh reorganisation in that first 6 months, and it should generally affect the patient's quality of life. It can't really be explained by anything else, such as an infection or recurrence, which could be contributing mechanisms. So how big is the problem? Now, you'll find a wide variation that's quoted in the literature, anywhere from 6 to 30%, and it really depends on how you ask the question. Is it based on questionnaires? Is it phone interviews? Is there actually a physical examination that takes place, which makes the diagnosis? Similarly, is it mild pain, where the pain score can be less than 3, or moderate to severe pain, where it's greater than 4? And similarly, how badly does it affect the patient's quality of life? Have they returned to work and any other meaningful outcomes that are important to them? And similarly, when you ask the question, it makes a big difference. So your incidence is going to be very different at 3 months than it is at 1 year and 2 years. Now, Mulgraf in 2017 found that 39% of published studies didn't actually define the criteria that they used when they made the diagnosis of post-hernia pain. Now, I know a lot of the discussion that's taken place today has surrounded ventral hernias. So I had a quick look through the literature to see if I could find some information in relation to chronic pain after ventral hernia repairs. Now, Grenier and Langbach both published some case series in relation to open ventral hernia repairs, and both found that at 2 years, 28% of patients reported a pain score of greater than 3 out of 10. If you looked at the numbers that had severe pain, so pain greater than 7, the incidence was a lot lower at 6%, but still those numbers are a lot higher than I had anticipated. If we look at Langbach and Liang, who published on laparoscopic ventral hernia repairs, the incidence again was about 17 to 24% in 2 years, but they didn't really define the severity at that point. Now, when we compare that to a case or prospective case series of 2,300 patients that was published in 2020 by Band, they found that in open inguinal hernia repairs, the incidence of chronic pain greater than 3 out of 10 was 14% at 4 months. And by the 2-year mark, that had reduced to 4%, which is significantly lower when in comparison to something like open ventral hernia repairs. And I'd be very interested to hear some of the surgeons' thoughts on this, hopefully later on in today's discussion. So what are some of the predisposing factors that may lead a patient to transition from acute to chronic pain? Well, what we know is that it's actually very similar to other post-surgical pain syndromes. So whether or not we're talking about post-mastectomy pain, post-thoracotomy pain, or pain after something like a knee replacement, the same risk factors are present throughout most of these syndromes. So it's really useful if you've got a little mental checklist when you've got a patient that's in front of you who has some of these, that it's important to realize they may be predisposed to chronic pain, and maybe that might be part of the consent process. So certainly if they've got severe preoperative pain, both locally at the site where the surgery is going to take place, or systemically, so something like low back pain, migraine, fibromyalgia, that's severe in nature, that increases their risk. Similarly, preoperative opioid use is again probably shows that they've got a pain system that's been sensitized and is at risk for acute to chronic transition. Obviously, if they've got larger, more complex hernias, or you're going in for revision surgery, you're going into an area that's going to be more inflamed, the nerves are going to be more sensitized, which increases that risk. And finally, with something like smoking or chronic cough, I think cough will increase your risk of recurrence, and smoking in itself can cause chronic cough, and it's also a pro-inflammatory state. So what can we do to actually prevent it or prepare for this? Well, most of the factors that we said before were not really that modifiable apart from stopping smoking. Certainly, if you've got someone with very severe pain or they're on high doses of opioids, it might be worthwhile having a chat to your anaesthetist or even organising a pain consult beforehand to help come up with a bit of a perioperative plan and maybe even to wean their opioid. There have been a lot of strategies that anaesthetists and pain specialists have tried to implement in order to reduce that transition between acute to chronic, but as of yet, they haven't been all that successful. So tap blocks have great evidence for reducing pain at 6, 12, 24 hours, and they'll reduce opioid consumption, but there's no evidence that they will actually reduce that acute to chronic transition. Similarly, with ketamine and lignocaine, we get a lot of those early benefits in reduction of pain scores at up to 72 hours, and certainly a reduction in opioid consumption, but we don't really know if there's any meaningful benefit in the reduction of chronic pain. Now, this is a source of a randomized control trial, which is being funded by the Australian and New Zealand College of Anaesthetists, called the ROCKET trial, and hopefully that answer should be forthcoming in the next couple of years. So what actually is the cause of post-hernia pain? Well, what we find out is that nociceptive pain is actually more common. If you look at neuropathic pain, where you've used a good a questionnaire like Pain Detect or the Neuropathic 4, and in combination with examination, something like dermatomal mapping, the incidence is quoted at about 40%. Now, if you just use questionnaires alone, if you just use history and you ask a patient, do you have burning, shooting, tingling pain, they'll often overestimate that, because obviously inflammatory pain, nociceptive pain can also have those descriptors. The benefit of the examination in this situation is that it's able to show elements of nerve dysfunction. So you can see what we call positive sensory signs, so allodynia, hyperalgesia, and what we'll often do is use something like a brush or cotton wool or a simple pinprick to make those diagnoses. And you might find negative sensory signs, so hypoesthesia or numbness, and they both show that you've got an element of nerve dysfunction. Dermatome mapping classification, I think, was Alvarez who first came up with this mechanism, and I think it's a great way of classifying post-hernia pains via its location, the type, and potentially the source of what's going on. And I think it's a really wonderful nomenclature so that we can all discuss pain on the same, with the same approach as to what we think the mechanism is and what we think is going on. Obviously, if I was accepting a referral to the pain clinic, I wouldn't need this to be done, but it's something that we will often use. So what do you do with the patient that presents to your room after a hernia repair who has pain? Well, it obviously depends on the timing. And it depends on when it is in their post-recovery period. I think it also depends on if you found, when you examine them, if they've got some of those positive or negative sensory signs to indicate nerve dysfunction. And obviously it depends on the patient that's in front of you and their degree of distress. The patient that says, "Doc, this is the worst pain ever, I can't sleep," is very different to the one who says, "Yep, when I get to walking about 2 kilometers, it sort of catches me a bit, but I'm able to continue on." So I think at the early phase, and I'm going to define early as anything less than 6 months, and there's no evidence of neuropathic features, so you've got no sort of positive, negative sensory signs. They've got mild to moderate pain, it's under 4, and psychologically they seem quite good. I think what's needed most of all is some positive reassurance. You can consider using an anti-inflammatory at that point. My approach is generally to use something like meloxicam or celecoxib for a couple of weeks, reassess and validate their concerns at that time. I think if they do get benefit from an anti-inflammatory and you want to use it in an ongoing way, I'd probably put them on a PPI at that point. Now, if again at that early phase and they do have neuropathic features, again, I'd start an anti-inflammatory initially and then maybe consider a first-line anti-neuropathic agent, which we'll talk about on the next slide. But I think early on, it's still going to be most likely an inflammatory, which is then irritating a nerve and causing that neuropathic pain. It's reasonable to consider a referral to a pain clinic or a pain specialist if they've got significant psychological disturbance, if they're on high-dose opioids, or if they've got severe pain over 7 out of 10 at the 1-month mark, because we know that's a significant risk factor for the development of chronicity. Now, this is a slide looking at some of the really common first-line anti-neuropathic agents that we use in Australia. I will generally use one of amitriptyline or duloxetine first, unless there's a contraindication. And certainly if there's concurrent sleep disturbance, I'll go with something like amitriptyline. If there's mood disturbance, I'll go duloxetine. With amitriptyline, I'll start at 10 milligrams at night time, increasing by about 10 milligrams on a weekly basis up to about 30 milligrams if needed, and reassess at about the 4-week mark. Now, main side effect is going to be sedation, but precautions that it can cause urinary retention and glaucoma, and it's relatively contraindicated in unstable cardiac disease. With something like duloxetine, I'll start at 30 milligrams at night time, and after 2 weeks, increase to 60 milligrams, and again, reassess that at 4 weeks. Relative contraindication again in unstable cardiac disease, main side effects would be nausea and a bit of mild sedation. Pregabalin is actually a streamlined authority in Australia for neuropathic pain once you've had a trial of other anti-neuropathic agent. I'll generally start off at 25 milligrams at night time, increasing every 3 to 7 days by 25 milligram increments, and then start it in a BD dosing manner, trying to get as high as possible before they get side effects. Main side effects in this situation would be dizziness, a bit of sedation, and in the long term, weight gain. Now, gabapentin is probably a bit better tolerated, but it does need to be taken in a TDS dosing manner. And as a result of that, you do have lower patient compliance. And in Australia, it's not available on the PBS, so it is a private script. So drugs to avoid. Well, I think unless you've had a complication, then I think opioids should be avoided after the first week. Certainly, if you're thinking of using an opioid for neuropathic pain, it's really after a trial of all other anti-neuropathic agents. And I'd probably suggest one of the atypical opioids such as tramadol or tapentadol rather than a more typical agent like oxycodone or morphine. What about the patient that presents with late pain? So over 6 months. Again, if they've got neuropathic features, a trial of an anti-neuropathic agent may be effective. And at this point, I'd consider doing some diagnostic blocks. Certainly, there are some surgeons that would consider doing something like a triple neurectomy in the case of post-inguinal hernia pain. But I'd suggest that with a lot of these patients, they're very complex, and it's reasonable to share the burden in that decision-making process with the pain clinic. Certainly, if there's no neuropathic features, it'd be appropriate to refer to the pain clinic. So what do we actually do when they come to the pain clinic? Well, we help make a diagnosis and provide that reassurance to the patient. We provide them with education. We might try some funky medications, but really it's about helping them modify the impact of their pain and recontextualizing their pain in their life through a combination of psychological and behavioral techniques. Some centers will do diagnostic injections and see if we can delineate the peripheral nerve that's involved in the source of their pain. And if they're positive, there may be a role for doing some therapeutic procedures. So we can pulse the nerves, we can ablate the nerves, we can go all the way back to the dorsal root ganglion and pulse there. And certainly there's growing evidence for implantable devices where we stimulate peripheral nerves, dorsal root ganglion, and spinal cord stimulators. So what are the take-home messages? Well, I think when it comes to post-hernia pain, it's may be more common than we think, and hopefully this can facilitate some discussion afterwards. Certainly with open ventral hernias repair, the studies quote up to 28% at periods of over 6 months. I think with any patient that comes to you with pain after a hernia repair, it's really important to validate their concerns. It's important to them, so it should be important to you. It's really essential that you reassure them that what's going on might be normal and that most patients will continue to improve with time. I think it's appropriate to refer to a pain clinic early on if they've got evidence of significant psychological distress, severe pain, or neuropathic pain that's not responsive to simple medications. And just remember that outside of the first week, there's really no role for opioid therapy. Thank you very much.
Thank you, Dr. Winters. Yeah. Dr. Punjani, would you want to come in?
Yeah, so I have to introduce Rod Jacob, who is from Australia, and he's one of the main organizers of this Anzawr, all 3 conferences that we have done so far. Rod Jacob is actually surgeon. He's a general surgeon, bariatric, as well as the abdominal wall reconstruction surgeon. He does open surgery, laparoscopic surgery, as well as robotic surgery. And we all know him by putting up a very complex cases in IHC, which are really mind-blowing work that he has been doing it. I had had a debate with him several times earlier. So my good friend Rod Jacobs, he is going to talk on this, the SSOs, SSIs, and mass infections. Rod, it's all yours.
Good afternoon. These are my disclosures. The relevant one is the 3M KCI. So wound complications after hernia repair run a big gamut through from simple seromas through to enterocutaneous fistulae, and it's the ones that require active intervention that concern us the most. Why are we concerned? Well, they're common, and particularly common after complex hernia repair. They're costly, both to the patient's well-being, and more importantly, they're a big user of resources, both as in hospital and after discharge. They also increase the risk of you developing a recurrent hernia, which of course predisposes to further recurriation. As well as being common and costly, they have long-term consequences. This is VA data that was presented at the European Hernia Society meeting showing ongoing risks after developing an SSI in a ventral hernia repair. And so, according to the World Union of Wound Healing Specialists, there are patient and procedure-related risk factors, and clearly we have high-risk patients. We've seen these, the diabetic, the obese, the smoker, and high-risk procedures, those that take a long time or have flaps, for example. And using the characteristics of the patient, the hernia, and the procedure undertaken, we can stratify the risk. This is work from Mike Liang, and they looked at the factors that were predisposed to SSOs and SSIs in about 800 patients over a 10-year period. And they were then able to stratify the risk and give a risk score based on those factors. But whichever way you consider it, really wound complications are simply a function of the complexity of the hernia and the surgery necessary to repair it. And however you look at it, the more complex the hernia, the higher the rate of wound problems and recurrence. So if we look at these individually, hematomas we should prevent with meticulous hemostasis. Drains are probably not going to stop you getting a hematoma necessarily, but they may indicate ongoing hemorrhage. And certainly in Australia, there are medico-legal prerogatives to put a drain in. If you do get ongoing hemorrhage, then usually that necessitates an open procedure to evacuate the clot and control the bleeding. And then mesh salvage is okay, providing you take appropriate steps to manage the wound. Seromas are ubiquitous. We only worry about the grades 3 and 4, that is those that are symptomatic or persistent or infected. Interestingly, drains do reduce your incidence of seromas, but not the incidence of those that require intervention. gratefully, they don't increase your risk of developing either a wound or mesh infection. So clearly, if you avoid a flap, or certainly if you have to have one, you excise any associated sac, as well as you're using talc and cording sutures to reduce the effects. If you get one, then percutaneous aspiration or drainage is the first line of therapy. There are case reports showing sclerotherapy and even endoscopic ablation to be effective, but mostly for chronic seromas, you require an open operation to resect the rind and deal with the resultant wound. Skin flap necrosis can vary from simple desquamation and minor dieback through to loss of the entire flap and the underlying infection then, and require long therapy to get closure of the defect. So clearly you need to know the anterior abdominal wall anatomy well and be able to preserve the perforators and perhaps avoid large flaps, and in particular consider doing posterior component rather than anterior component separation. Surgical site infections, I'm certain we're all aware of the CDC classification as well as the diagnostic criteria. And the risk factors are the usual patient comorbidities, but in terms of hernia repair, large defects repaired in an open operation, especially those that involve some breach of the GI tract. Clearly, superficial wound infection should be treated with appropriate antibiotics until clinical resolution. And I'll talk a bit more at length about pre-operative optimization. Deeper and organ space SSIs are clearly more problematic, and they do require drainage. Interestingly, whether it's done percutaneously or open seems to make not a great deal of difference to the overall result. I think it's important that you have infectious diseases input into their management. You need to clearly culture the fluid to guide your antibiotic choices. And antibiotics probably need to stay quite long term, and certainly well beyond normalization of inflammatory markers. What we're concerned about, of course, is mesh infection, diagnosed on the basis of clinical suspicion in the appropriate setting, local symptoms or a sinus, ongoing elevations of inflammatory markers. Radiologically, sometimes it can be difficult to differentiate from a seroma, but fluid adjacent to the mesh, and in particular fluid collections deep to the mesh, or those associated with the locules of gas, for example, are pathognomonic. And it's important to culture fluid that's aspirated from close to the mesh. There's a wide variation in the rates of mesh infection, as I'm certain you've heard earlier today. It depends upon the type of mesh used, where it's placed, and whether it's been an open or an MIS operation. But typically, they're the rates that we see. It's associated with the same sorts of risk factors for post-operative SSIs. Subsequent abdominal operations increase your risk of developing a mesh infection, obviously. And even though in this big series from Bueno Lado, their infection rate was relatively low, less than 2%, as you can see, 3/4 of those meshes needed to be explanted. It's a late onset clinical problem. As you can see, this is work from Vedra Augenstein that shows the median was about 2 years. And indeed, 1/3 of these infections don't become apparent until after 12 months. And this is almost certainly related to the development of biofilm. What happens? Well, you can get exposure to the mesh, you can get development of fistulae, and of course, recurrence of wound and hernia. There are a number of case series and small trials that have been published with varying rates of success, using conservative measures, sometimes simple wound dressing, through to complete extirpation of the mesh. And then you have a resultant hernia, and its management is really dependent upon a large number of factors. Negative pressure wound therapies are almost ubiquitous in managing these complications this day. They do result in more mesh salvage and high rates of healing, but overall salvage of mesh is quite low. Again, the work from Vedra Augenstein, they were unable to salvage any meshes in patients who smoked, had a fistula, and certain sorts of meshes. And indeed, this article by the group from South Carolina last year showed similarly poor results. The potential for salvage is dependent upon these factors. And so if you have macroporous polypropylene inserted in the retrorectus position, the patient's neither a smoker nor a diabetic, there's no underlying enterotomy, and you're aggressive with your wound therapy, you've got a reasonable chance of salvaging the mesh. Partial explantation of the mesh seems to leave with ongoing problems. There's a high chance of persisting infection, and the data from the AHS QC showed that the recurrence rates were high and there were more complications. Seeing therefore that you need to completely explant the prior implant, got to remove all the associated suture material. Leaving a well-incorporated mesh runs the risk of ongoing infection, but most people would probably advise that these days. And then one has to manage the bowel and soft tissue defects as well as the resultant hernia. The reconstruction, there's lots of published articles about how to reconstruct after extirpation of the mesh. Primer repair burns no bridges, but has high rates of morbidity. Definitive one-stage repair, we thought that biologic meshes were going to be an answer early on, but the results overall have been poor. Biosynthetics, I'll talk a bit more about, but they seem to be quite effective. And of course, in highly selected patients, you can use synthetic mesh. And it can be done, as I said, immediately or in the early or late post-operative stage. This is more data from that VA study that showed that if you didn't get a wound infection, you didn't have to have your mesh explanted. On the other hand, if you had a deep SSI, you had a 32% chance of requiring mesh explantation. And that risk continues out for 5 years after the index operation. Furthermore, after you've even had that infected mesh explanted, you have a high risk of developing a further wound complication, further mesh infection, and further mesh explantation at least once, and in 10% of cases, twice. So if we modify these risks, this was probably done early in the day, but we need to get the patient's control of their diabetes, stop smoking, and lose weight. What about what we can do as surgeons? Well, clearly avoiding a wound by using an MIS approach is appropriate, and it's been known for a long time that laparoscopic ventral hernia repairs have lower rates of wound infection. They also have lower rates of chronic mesh infection and reduced odds of mesh explantation. Preoperative skin management, high-risk skin wounds predisposed to wound infections. And so this sort of grade 4 wound, it's better to excise the wound, temporize, and come back another day to do the definitive repair. What about intraoperative antisepsis? Well, clearly antibiotic prophylaxis is appropriate. There's evidence to show that alcoholic chlorhexidine gives you the lowest rate of SSIs in all wounds. Clearly, changing your gloves and instruments between deconstructing and reconstructing is appropriate. Soaking meshes in chlorhexidine, I don't think there's any evidence, but I do it because I think it does reduce biofilm. There is, however, evidence to use pulse lavage. It's been used for a long time in orthopedic operations, and there's evidence in abdominal wounds as well. This is also a study out of South Carolina from Bill Kolb and Elfie Carbonell's group, showing that installation of a clindamycin gentamicin solution in the wound reduces your wound infection rate. Correct technique, clearly. So as well as handling the tissues appropriately, you need a tension-free defect closure that reduces your odds of a problem, putting the mesh in the rectorectus position as well. Avoiding an enterotomy is tantamount. It's bad news. You have a dramatically increased risk of developing a wound infection. Fistula rate's nearly 10%, and 1 in 5 meshes get infected. You can do that by obviously staying out of the abdomen or meticulous scalpel dissection. There's evidence to suggest that if you plan to excise and anastomose bowel, that's a better outcome than potential for an enterotomy. And then wound management. There is in vivo and ex vivo evidence to show that closed incision negative pressure therapies have lots of benefits. In ventral hernia repair, there are a number of published series that show that it reduces wound complications interventions, and that's been reaffirmed in a recent meta-analysis confirming all that. And then what about mesh? So generally we're going to use monofilament macroporous synthetic meshes. But it's been known for a long time that certain meshes, particularly EPTFE and the multifilament polyester, are more prone to developing infection. Indeed, the ventral hernia working group suggested that they shouldn't be used in high-risk wounds and suggested biologic. However, biologic meshes don't work. The complication and recurrence rates are high. There's no level 1 evidence to support their use. And indeed, there's a recent publication showing the randomized controlled trial that the outcomes are worse compared with synthetic meshes. Biosynthetic meshes, on the other hand, both in their early published work and more recently published work, have shown continuing low wound complication rates and low recurrence rates. And so these days, we'd perhaps consider using a biosynthetic mesh if you didn't want to use a synthetic as a repair option in the contaminated wound. There's currently no commercially available meshes that have antibacterial or antibiofilm adjuncts, but there's the potential for that. There's also potential wound therapies. We know cold plasma wash disrupts the cell membrane, and interestingly, non-steroidal anti-inflammatories potentiate the effects of antibiotics in vivo. And so we might see something like this. This is nanofiber technology impregnating bactericidal elements into meshes for abdominal hernia repair. So in terms of mitigating, we've got to get the patients to stop smoking, lose weight, control their diabetes, and look after their skin. As surgeons, we should perhaps try to avoid a wound if we can and put the mesh in the best place and be aggressive in our wound and mesh management afterwards if it's an open operation. The mesh infections are complex, they're a function of complexities, the risks can be modified, and the negative consequences of long-term outcomes can't be underestimated. Thank you.
Yeah, thank you, Rod. It was an excellent talk. We'll have a questions at the end. Now we have the last speaker, Doran Tonkin. He is a colorectal surgeon from Adelaide, Australia, and he has done work in AWR. He is head of the colorectal surgeon at Elizabeth Hospital. So, Doran, you can go on. He's going to have a very interesting talk of recurrence, redo surgery, same, only different. So let's see what he's talking about.
Thank you very much. Do you have my pre-recorded talk there, Barbara?
Yes, sir. Yes, sir.
Yeah,
We have.
very good.
Yes, sir.
Good afternoon. Well, it's afternoon here in Adelaide, in Australia. I'm Darren Tonkin, colorectal and robotic surgeon from Adelaide, and I'd like to thank the organisers for asking me to give this talk. Are we talking about redo ventral hernia repairs? And let's get on with it. Firstly, just some disclosures, which are self-explanatory. Recurrent incisional hernias, they're very common, quoted at 20%, but I'm sure it's more common than that. They're more common following open onlays, laparoscopic or open IPOMs, and those are fairly straightforward to repair as a redo, but it's becoming increasingly more complex with more people going towards retrorectus repairs, anterior component separations, transverse abdominis releases, and more complex techniques. So for all these recurrent hernias, really they do require careful workup and very individualized approach depending on the mode of recurrence, their previous surgery and other complications, and of course comorbidities as usual. So as part of the workup, I get a CT scan on everyone, and I actually do that for all patients with incisional hernias that I'm going to repair. I've got to review their previous operation notes, what mesh was used, what type, location, how was it fixed, etc., and plan it very carefully, looking very carefully at the CT scan yourself. I don't rely on reports. Obviously, you've got to medically optimize your patient and then make decisions about when you're going to do the surgery. Is it going to be open, minimally invasive? What are you going to do with the old mesh? Is that going to be removed or left behind? And where are you going to put your new mesh? As I said, for previous onlay repairs, it's usually fairly straightforward, and I actually think it's analogous to repairing a recurrent inguinal hernia after open repair. A laparoscopic preperitoneal approach will work very well. And so that's the way I'd approach a recurrence from a previous onlay. Whether it's open or minimally invasive, I do a retrorectus. perhaps a tar if necessary, depending on the defect characteristics, and mesh removal if necessary, but often not. I would generally prefer to use a robotic ETEP approach for these, unless, of course, the skin's compromised, in which case I do them open. Previous IPOMs, a bit more difficult. You can do them open or minimally invasively. I would generally resect the old mesh unless it is very well incorporated, and it would lead to loss of the posterior sheath if you try to remove it. But it's rare in my experience when there's been a recurrence that the mesh is well incorporated. I would perform a retrorectus repair and a possible tar, and that's my operation of choice for pretty much all incisional hernias. I prefer to do it robotically. I think I can perform a better and safer adhesiolysis robotically than I can open. I just get a better view and I've got better dexterity. Of course, reviewing the scans, often what happens is the mesh loses fixation on one side, or there's eventration. Sorry, typo there. Eventration of the mesh into the sac, and in those cases you can do an ETEP from the opposite side, and it works very nicely. Otherwise, I'd do a transabdominal approach, but you'd need to do a dual docking. This is just an example of a complex recurrence with a number of previous operations, including IPOMs and an onlay. And if you look carefully, you can actually see the mesh from an IPOM there. And so in planning for this, I can see he's got a decent sized rectus muscle, and I'd approach from that left side, and I did an ETEP. This is after getting into the peritoneal cavity, after taking down the sac and the left-sided posterior rectus sheath. And you can see this old mesh there. This was a coated one, not sure of exact brand, but it's basically completely lost attachment, and is slipped, but basically over on the right-hand side of the abdominal wall. It's just really very loosely attached. So this one I did remove, resected that mesh, and it's really just quite flimsily attached. Obviously there were dissolving tacks used in this case because there's no metal ones apparent, and that's been resected. His is a very complicated area here in the right sort of rectus edge. There's, as I said, there's been multiple repairs, and so he's got about 3 or 4 meshes in there. I don't remove them all in this case. I just remove this IPOM to enable better closure, and I really don't like having mesh in the peritoneal cavity. While this one was covered in omental adhesions, obviously the small bowel adhesions are the ones that you run into trouble with. And even if you do get dense small bowel adhesions, I would still prefer to do those on the robot than open. So that mesh is nearly out. The difficulty is then you've got to actually remove that piece of mesh. And I usually put it in a bag to extract it through the 12mm port, but often you need to actually cut it into little strips to enable it to come out. A little bit like peeling an apple to try and get the longest length you can, just so it's thin and long and it will pull out through the port. So once that mesh comes out, I'll just fast forward there a little bit. Then we can enter into that retrorectus space and do a standard reeve stopper repair from that point onwards. So those are the 2 most common ones that I see. Well, I have seen at least in the last 5 years. There are still plenty of people doing IPOMs and onlays in general surgery land in Australia, but it's starting to get more complex as people are hearing and listening and understanding that retrorectus mesh placement is probably the best way to go. And people are trying out more complicated things, and so we're getting more complicated recurrences and complications. So in terms of complex things, what sort of troubles can we run into? Of course, infected mesh, fistulas, skin erosions, all sorts of really awful things. And I think that's actually, the decision making is fairly straightforward. You've got to resect the infected mesh, all of it, basically don't leave any behind. Try and close the abdomen primarily, or bridge with a biosynthetic material, and plan for a staged repair later. You've basically just got to try and get the patient healed, get rid of the infection, and keep it simple. I would definitely counsel against doing any more complex procedures in terms of external oblique release or rectus dissection, retrorectus dissection, or TARS, because you really burn the bridges. And then when the hernia recurs, which I think they almost always do, then you've sort of lost options, or made it much more difficult anyway. So I plan it as a staged repair, get rid of the infection, get the patient healed, wait for them to, have a recurrent hernia. And this is obviously part of the consent process. They have to know that that's going to be likely to happen, and then they can have a definitive repair later on. This is just a video of a patient who had an infected mesh and a big recurrence. And I don't know if you can see, but there is some contrast that's been put in via a skin fistula, which is just up there and is running down. And there was a piece of mesh on this side, another piece on the other side. And basically just have to resect all that. I was able to close that primarily, and she'll end up with a recurrence and need something done later. But during the meantime, I've told her to lose some weight. When it gets more complex, then you have other issues like retrorectus recurrence after previous retrorectus repairs. I've seen these a few times, and it's usually occurred above or below a previously placed mesh. In my own experience that I've done open, and often in the epigastric region, if they've got a divarication and you don't take that repair right up to the xiphisternum. So you can do a redo retrorectus repair and just overlap the meshes. It's tricky where you have to dissect the mesh off in the retrorectus plane, but as long as you get about 5 centimeters there and then overlap, it works pretty well. Or you could do an IPOM. I've had a few early in my experience with mesh failure when I was using a lightweight mesh for these, and it basically just split down the middle. And on those, you could either do a redo, again, difficult, but not impossible, to do the retrorectus dissection, or an IPOM. I've had a few as well, and it'll probably happen more often now, where patients that I've done a lovely retrorectus repair have had some need to have another laparotomy elsewhere, and their abdomen's been closed with an absorbable suture, and they basically have had a recurrence straight through that that suture line. You could consider, well, for a couple of these, I've just reclosed the mesh with the non-absorbable suture, or you could do an IPOM if that happens. The lateral recurrences are the worst and most difficult, and I've seen, unfortunately, too many of these after attempted external oblique release or TARS, where the linea semilunaris has been breached, and they're a very difficult one to fix. But what I've done, and I'll show you a video, is just a redo TAR. So this is one of those most difficult ones, a lateral hernia. If you look at this carefully, there's the obliques over this side here on the right hand side. Then you've got the left rectus muscle there. This is the right rectus muscle. And obviously there's a huge defect there, which is about 12, 14, 15 centimeters. laterally. So, and this is the robotic view of that. This is the rectus muscle. It's denervated and atrophic, and so it's a bit difficult to really identify it was. But that's a arcuate line that I'm just dividing there, getting into the retrorectus space, and then extending that the section along in the retrorectus space. You can see here a little bit of muscle, that's rectus muscle, and really it's just important to try and identify landmarks and follow them to the point where everything starts to get more difficult. And so I've then gone up to the epigastrium, found the rectus muscle there, and started dissecting the retrorectus plane. She does have a few midline defects as well, but the main defect laterally is what we're concentrating on. Then that lateral sac, lateral to the rectus muscle, I've just been taking down, and here again taking down that sac. This is inferior epigastric vessels and the big sac next to it, keeping that sac as part of the posterior layer to close when we do the TAR. And this now, this is the inferior epigastric, this is the defect, this is the edge of the obliques, and this is me getting into the TAR plane there. This is some of the sac just coming down here. I'm not sure if you could see the transverse abdominis muscle fibers there, but there they are, and going in the right direction. So again, finding the planes where you can. Usually I'll go above and below the defect and then come back to join them together when you have these difficult ones. Here, continuing along in that TAR plane. This is the defect. And again, just coming up here to join with the section that I've done from above in a similar way. Yep, here's the TAR coming from above. And with these big hernias, I think you just got to go, you know, all the way to the pubic symphysis and up under the diaphragm to get a full dissection. Here going laterally with the TAR once we've defined the plane all the way around, and I like to try and take the transversalis fascia down with the posterior layer just to give it a bit more weight, so to speak. It's a little bit bloody there. And this is costal margin, and as I said, going right up onto the diaphragm to make sure you get really good coverage. So that's diaphragm there. This is now redocked from the other side, doing the retrorectus dissection on the patient's left. And you can see here that the muscle is much more normal looking because it hasn't been denervated on that side. That's xiphisternum there, and that's the completed TAR on the other side. If we come back here, this is the edge, this is midline, this is the lateral edge of the right rectus. So we're closing the posterior layer. I'll just fast forward that a little bit, close the posterior layer completely, and then this is from the opposite side. I place these stay sutures onto the anterior rectus sheath here, and then redock from the other side and start closing that lateral defect. And you can see that having those sutures there just gives that hand grip, I guess, that handhold to be able to make sure that you do actually get the rectus sheath when you're closing it, and then plicating all that scar and sac. It's not actually the sac, pseudo sac, I guess, and then approximating to the lateral border of the rectus sheath over there, and continuing that all the way along, just placing the sutures pulling them down gradually and cinching them tight as you go along. I usually reduce the intra-abdominal pressure down as low as possible, sometimes down to 8 or 5 millimeters of mercury, depending on how much space that allows you. And just take time and make sure we get a good closure. And that's it at the end. So when it started, I didn't think I was going to get it closed, and I thought I'd have to bridge, but it came together actually very nicely, and there was still plenty of space to lay the mesh. It turned out to be, I think, about a 30 by 45 or 50 centimeter piece of mesh, because it went from psoas to psoas basically, and roll that out. I like to roll it out on a scroll. I just find it makes it a bit easier to get it in the right position, and try and get it as flat as possible. Put a drain on top of the mesh, and then it's done. It did take about 5.5 hours, but I think it's worth it for the way the patients recover post-operatively, and that's the post-operative result. That's about 6 months later, and as you can see here, the obliques are now stretched out and probably joined somewhere around here to the rectus muscle there. She's got the mesh which runs basically all the way around, not quite to the psoas, but a long way, and a good result. These are just some other CTs which I thought I'd put at the end, just to show how you can actually be really careful and have a look and see where mesh is when you're doing redos. And I can show you this one. This is one that's been divided down the middle. There's a bit of mesh there and a bit of mesh there. We won't go through this video because we're running out of time. But thanks very much for the opportunity to present, and we'll take some questions later. Thank you.
That was wonderful, Dr. Tonkin. I think this was the last talk for the session. I would request any questions and discussions from the faculty here or anybody.
So Doran, it was such a marvelous, you said it is same, but we realized it was different.
Yes, very true.
It was definitely a different. Can somebody put on my video? Yeah, okay, start my video. All right, so it was an excellent, the speakers that we had on the very difficult subject of this. How do you go about treating this or managing this complication? So are there any questions? Philip, you have to ask any questions. I have a couple of them.
Yes, look, I'd just perhaps put it out to Darren Tonkin and Charlotte Horn. So working in an area of subspecialty interest with your hernias, but also sharing other specialty areas. So Darren, you're working in colorectal and you've got this hernia. Do you find that when your colleagues have a really complicated hernia case, you're starting to get that referral from your colleagues within your hospital organization?
Yeah, absolutely. I mean, and that's how I really got into doing abdominal wall reconstruction in the first place. I developed an interest in intracutaneous fistulas, for better or for mainly worse. And so now I do get most of the complex ones from other other surgeons, which is always good.
I think that's probably, yeah, I think that's where things are going to move to as hernia surgery becomes really more established as its own subspecialty. I think, speaking as a regional general surgeon, where I do everything from breast to, I do bariatrics, I do colorectal, I do hernia, varicose veins. But I think I'm probably going to be a dying breed in a sense, that I think everything is going to move towards more of a subspecialty. And certainly I've sent on some of the more complex cases to David Wardle, for example. So I think that's probably where things are going to move to. And for us generalists, it's trying to recognize at which point we stop in terms of the complexity of what we're taking on, and then saying, no, this is a really for someone a subspecialist.
I think you're right, and I think it has gotten to that stage where the techniques are getting more complex and the decision making is getting more difficult. Where hernia surgery has always been, I think, thought of as, oh yeah, it's just hernias, and fairly low level, decision making. But I think it's really changing a lot, and that's where I think it's really great that the ANZ and AWR, organisations are around to actually, promote education and also registries and MDT sessions and things like that to really progress the scientific side of things as well.
And before I'll just also mention we haven't actually acknowledged our sponsor for this session, which is BD. So on behalf of the panel and ANZAWR, I'd like to extend gratitude to BD for sponsoring this session. I was astounded to see that BD is in over 40 countries spanning every continent on this planet. So, their portfolio really covers a vast range of technologies, from diagnostics, laboratory, anesthesia, interventional procedures, and of course, surgery. So they're really that kind of company that forms the backbone of a lot of health institutions.
Charlotte.
Okay. Other questions?
Yeah. Can I ask a question? Yeah. So Charlotte, you said in EC fistula, you would do your AWR procedure at the same time, or you would stage it?
I always stage it.
Always stage it.
I think that, sometimes it's a little bit hard to tell if, or situations like chronic wounds where you think there might be a fistula, but you don't actually have any enterotomy, then it's definitely pushing it. I think sometimes you have these seromas that when you open them, it looks like it's pus, but when you actually culture them out, there's no white cells or even bacteria that are growing. And so, I think it's the safest thing to just stage it, because there's just so many things that are complex to those operations. Like, you obviously have your enterotomy, and as much as you can try to contain the contamination, you're already making it a clean contaminated or a contaminated case. And the other thing is, like, you burn no bridges for the patient if you don't repair the hernia. In general, they're there because they're leaking enteric contents onto their abdomen and they want their intestinal continuity restored. They don't care about the hernia. And so I tell all of my patients, like, the hernia is going to come back. We'll fix it if it bothers you. But at the end of the day, your goal isn't to do something definitive for the hernia. It's to take down the fistula and get them out of a complex abdominal wall situation.
How long will you wait for your second surgery to happen, the elective AWR?
So I wait until they have a problem. So if they, it's at least 6 months, if not a year after I've operated on them. But I always say, listen, if you have a bulge and it's not bothering you, then we don't need to fix it. Because also at the end of the day, you're dealing with patients that have had a devastating abdominal wall complication. And so oftentimes they don't want surgery again. So I always say, I follow them at 3 months, 6 months, and a year. And then we check in every year after that. And I say, when you think you have a bulge, we'll re-image and kind of go from there.
Yeah, I think what you said in a lecture that, either you do re-exploration after abdominal wall reconstruction for a obstruction or a enterotomy is, of course, enterotomy would immediately go, but for an obstruction, either before 2 weeks or after 8 weeks. I think that was a great message. Because, if you go in between, you would do a lot of harm to the patient.
Absolutely.
Rod, you were talking about the antibiotic impregnated meshes, which is going to be a future. Are there anything available at the moment?
Look, I can't get my video up, but not that I'm aware of. But there is, as you're aware, the technology companies are developing fantastic new things that we can only dream of. And I just came across that little article the other day about nanofiber technology that is going to impregnate fibers with anti-biofilm and antibacterial properties. So I know that people have tried in the past to develop antibiotic impregnated meshes that haven't worked very successfully in vivo, although they've worked in the lab. But there's nothing commercially available. But I suspect it will come.
If you explant your mesh, how much you will wait for your next surgery to happen?
Oh, look, I again, a bit like Charlotte, most of them are just happy to be out of a vac and to stop pus pouring out of their abdomen and bits of mesh spitting out every now and then. And I just excise them and close them primarily more often than not. And I say to them, if they get a hernia, we'll deal with it if you want it dealt with. So occasionally in younger people, I will say, well, you probably should have something done at some stage, but I will wait at least 3 to 6 months, if not longer. I think that the longer you wait, the less overall risk there is for them getting a further infective complication.
Would your
Charlotte, you agree with that?
Your time would change if it is MRSA?
No.
It will be still 3 to 6 months?
Well, in theory, I mean, it's interesting, the stuff that came out of the VA showed that even though they had clinical resolution and there were no infections, 23% of their patients got another SSI when they had their repair after their mesh explanted, and that they quite a percentage got a further mesh infection and then needed to be explanted. So I think the bugs do hang around. Most of the recurrent infections in their series were the same organism. So I think the longer you wait, the better, obviously. But I suspect that 3 to 6 months is sufficient time. I don't have any data to back that up.
Noem, you had an excellent lecture on a chronic pain or the pain. So, I mean, normally what do you advocate as an anesthetist as the pain management for an AWR, an epidural, or you just rely on a tap block or the narcotics?
So it sort of depends on the patient factors more than anything else. But in general, if they've got significant respiratory comorbidities, an epidural may be considered. But normally we try to avoid it, and we'll probably use just a combination of parenteral therapies and something like a tap block if the surgeons are happy. Often it's a discussion between the two, but epidurals, it sort of just depends on what's going on from a patient point of view. And certainly if they've got airways disease, an epidural would be something we'd do.
I think the epidural would probably not allow early mobilization of the patient. Is that the fear that all of us have?
Well, I think it just depends on the quality of your aftercare that you're able to provide in your service. Sometimes you can get people mobilizing really early on if you've got good perioperative nursing care afterwards, but it sort of just depends. If you're a good facility that does a lot of epidurals, then the care you get afterwards is fine. Early mobilization is not an issue.
Okay. Philip, you wanted to ask something?
Oh, no, I was just going to say, Noam, it's lovely to see you at this conference. And I very much enjoyed your talk. You had one slide where you were comparing the chronic pain incidence between ventral hernias and inguinal. And you were commenting that it seemed to be a lot less in inguinal and wondering why. But I would say it's apples and oranges because they're very different territories and really quite different operations. But even within ventral hernia, you're talking about apples and oranges because we've been listening all day about all the different techniques of doing abdominal wall hernia reconstruction, and certainly, for example, IPOMs with transfascial sutures, which was really quite the rage some years back, and we know that transfascial sutures cause a lot of abdominal wall pain and some of those very penetrating attackers as well. So, and that would be quite different, say, to doing a tap or a retrorectus without any mesh tackers. So that was just an answer to your slide.
Yeah, Doran, you all made us believe that I think robotic is the way to go. The kind of surgery that you did, I think, would not be easy with a straight stick, isn't it?
Oh, I mean, no, I wouldn't even try it with straight sticks. I mean, I think it's either open or robotic for these complex ones. And I mean, people say, oh, it took you 5 hours or something to do the operation. But I think the operation will still take 4 or 5 hours anyway, open for me. And if you have the technology and you have the availability of the robotic platform, apart from the benefits in reducing the wound complications and potential for mesh infection, I think it's much better for the surgeon. I mean, I can do a 5-hour operation and walk out with no troubles. If I was standing there doing that operation open, I'd be exhausted. So I think that's one thing that we sort of probably gloss over a little bit with the discussion about robotics, is the ergonomic side of things for the surgeon.
Right. So I think we have, time is getting over, and I think
we're out of time.
Session. Yeah, we move to the next session. Thank you.
All
Thank
right,
you so much.
Thank you, guys. Thank you very much.
Thank you.
Thank you. Good session. All righty. So welcome to session 4. And my co-host is Charlotte Horn, who I think is floating around somewhere. I can't see her. So this is going to be the most exciting session of the meeting. This is the complex cases, and this is really where the money is and what it's about. It's sponsored by Gore, and we thank the guys from Gore. They've been with us from the beginning, and in fact, we thank all of our sponsors. And please make an opportunity to go and have a chat to them. Ken Loy was going to say a few words about Gore, and Ken's had to go to some kind of hugely important meeting as always, so he's passed that on to me. But I think Ken wanted basically for me to say that he's used a lot of BioA mesh. He's done 20, oh, I've lost my screen. He's done 20 TARs with this. Oh, there we go. This is the form video. And I know Kelly Slater's a big fan of I think the research shows that Gore integration is really impressive. Sorry, I'll try my screen again. So this was the talk that Ken had, so I can't take any credit for this at all. But really, just the nature of the product, fully reabsorbable. They specify that 67% PGA, 33% TMC, really, and the data, if you ever get to see it, is amazing about the vascular ingrowth and definitely how the BioA facilitates collagen deposition. This is his posterior rectus sheath. I think these are his pictures, and I think Kelly's pictures are coming a little bit later. You can see he's reconstructed the peritoneum in the middle there, and the mesh sits nice and flat. And I don't think Ken actually secures his mesh. I think he relies on it to sit flat. You'll have to ask him on it. Maybe he does. He's got some anchoring sutures in there. He says he's had 1 recurrence out of 20 with his technique. This is Kelly Slater's data. And I apologize, Kelly couldn't be here at this meeting, but I'm sure we'll get on to one of the future ones. And definitely Gore seems to perform very well, and definitely performs very well in those contaminated fields, which are just a nightmare to deal with. This is the integration. You can see around the esophagus, and definitely when you go back a year later, if you have to go back, you can see it's all the BioA is gone and it's fully incorporated. So definitely a good product. So without much ado, Charlotte, is there anything you'd like to say? You're muted.
No, it's awesome to be a part of this conference and to moderate this session with you. And I'm very excited for this. I love some of the complex cases, and I'm very excited for the discussion that's going to ensue because of the stuff that you're going to show us tonight.
Lovely, absolutely. So let's get going. Can we, I think Alex has got a video lined up, so we can get Alex's video rolling, and things that make my heart stop when I was watching it before. So let's see how we go. Oh, we're just waiting for Alex's video.
We are going with the video, sir. We are just playing it. This is a case of a 56-year-old male who developed a symptomatic Swiss cheese incisional hernia after an anterior section. His significant comorbidities included obesity with a weight of 130 kilograms and a BMI of 42. He had no pre-optimization prior to surgery and had been on a public waiting list for 1 year. A robotic approach was not available, so the plan was for a hybrid approach with a lap ETEP to develop the retrorectus space, close any posterior layer defects laparoscopically, place a medium weight polypropylene mesh in the retrorectus space, and then through a mini incision to close the anterior layer. We were hoping that the hybrid approach will reduce the size of the wound and hence reduce the incidence of soft tissue complications secondary to his obesity. This shows the port positions that we used for this case. We begin the dissection of the left retrorectus space and cross over to the right side. Multiple Swiss cheese defects were reduced. We accidentally entered the peritoneum whilst reducing one of these Swiss cheese defects, and we placed the laparoscope intraperitoneal, which revealed only mental adhesions as far as we could see. We proceeded with a xiphoid to pubis retrorectus dissection, and apart from the multiple defects, there was also diastasis of the recti of about 6 centimeters.
I wish I could operate this quickly. I think, Alex, this is your normal speed, isn't it?
Once we completed dissection, we noticed an inadvertent enterotomy suprapubically. There was no contamination. In retrospect, this densely adhered loop of small intestine was present in the preoperative CT scan just above the pubis in an area of diastasis of the recti. There was no fat plane between this loop of small intestine and the abdominal wall, indicating possible dense adhesion. So the problem we now faced was the following. Firstly, we had an enterotomy without macroscopic contamination, which made this case from a CDC wound class 1 and converted it to a class 2. We also had a non-optimized patient having, hence the ventral hernia working group class is 2. Thirdly, the enterotomy occurred directly in the subrectus plane. Unlike an intraperitoneal approach where the small bowel injury is identified and repaired prior to developing the subrectus plane, and hence minimizing microscopic contamination of the landing zone, in an ETEP situation, there's microscopic contamination of the mesh landing zone. So the options were to repair the enterotomy and delay the hernia repair for a few days depending on the patient's postoperative clinical course, or repair the enterotomy and continue with the hernia repair. So what would you do in this clinical situation? We thought that the risks for mesh infection in this non-optimized patient in this situation were significant, and decided on repair of the enterotomy and delayed repair. If the patient was optimized and we had performed an intraperitoneal approach rather than an ETEP approach, we could repair their enterotomy, and if there is no obvious macroscopic contamination, would proceed to develop the subrectus plane and place a retrorectus mesh. Our preference would be for a biosynthetic mesh but a medium weight polypropylene is acceptable in these circumstances. So in our current situation, we closed the enterotomy and then placed omentum over the repair. We closed any small defects in the posterior layer and irrigated the subrectus plane copiously. The patient was placed on IV antibiotics and the clinical status was carefully monitored, as well as a CRP. After 3 days, the patient was well with no clinical evidence of infection and the CRP was falling, so it was decided to return the patient to theatre for repair of the hernia. So in the second procedure, we used a hybrid approach with both a laparoscopic and a minimal open approach. The retrorectus space was inspected and was found to be clean, and so we proceeded to place a 42 by 26 centimetre biosynthetic mesh in this retrorectus plane. The anterior layer was closed through a mini laparotomy. A subrectus drain was placed and it was continued with antibiotics for a week on the advice of the infectious disease consultant. The patient had an uncomplicated post-op course. The decision-making process with bowel injury during hernia repair may be difficult due to the heterogeneity of the clinical situation and the lack of big data from the literature, and to clearly define appropriate management strategies. In reality, what we are attempting to do is assess the risk of mesh infection in this unfortunate clinical situation. This depends on 4 main factors, including the amount of bacterial contamination, the patient's immune status, the type of mesh and its position, and the potential of wound-related problems. Firstly, with the amount of bacterial contamination at the landing site for the mesh, this is dependent on further factors, including the nature of the contamination, the degree and duration, and if the contamination occurred away or directly at the landing zone. Secondly, the patient's ability to combat the bacterial contamination is reduced by comorbidities such as obesity, diabetes, smoking, steroids, and immunosuppressive therapy. Also, this is influenced by the susceptibility of the bacterial organisms to antibiotics. Thirdly, the type of mesh may be important, and mesh-related factors include if it's biosynthetic or permanent. Large pore is probably better than small pore, and the position of the mesh in the retrorectus plane is probably better than intraperitoneal mesh. The more rapidly mesh tissue integration occurs, the less the risks of infection, and factors such as effective porosity and vascularity of host tissue are important. Fourthly, the potential of wound-related problems is important, and factors such as soft tissue, ischemia, seroma, hematomas, and fascial disruption may result in increased susceptibility of mesh infection. Wound-related problems are more common after open surgery than minimally invasive surgery, and a good soft tissue management is vital in this situation. A few points should be emphasized. If considering a one-stage procedure, change the contaminated setup to a clean one after repairing the enterotomy and before undertaking the hernia repair part of the procedure. If considering a 2-stage repair, 3 to 5 days should be adequate before returning to theatre, as long as the patient remains clinically stable. Involve a clinical microbiologist if possible, and lastly, it is advised to follow up the patient long term because of the possibility of biofilm-related effects. Thank you for your attention.
Wow. Rachel, Charlotte, sorry, what do you think? Oh, Charlotte might not be there. Oh.
No, I'm here. My video is not on. So I think you presented some super valid points when it comes to dealing with enterotomies, especially as you had mentioned this was in the retrorectus space, and that kind of changes your plan. And so I want to talk about what you do in the interim between when you obviously you put the mesh back in. How long do you wait? Are they on IV antibiotics while you're in there? When you irrigate your posterior sheath, is that with antibiotics or just saline? And is it really the CRP that you're following in terms of deciding when to go back to the OR? How do you make those decisions?
Yeah, good questions. Firstly, it's not only the CRP, but also the patient's clinical status. So passing wind, not vomiting, not pain decreasing, etc. Afebrile, so that's all important. The antibody, the irrigation that we used was just normal saline, but if I were to do it again, I would use the clindamycin, gentamicin solution. I think that's been shown to work, and we would add that to our regime now. And the first question was?
How do you do it? Like in terms of choosing mesh, when you go back in the situations, are you always putting a synthetic mesh, or do you prefer a bioreabsorbable in those situations?
Yeah, if I've got a choice, it would be biosynthetic. So our plan with that case was to use a medium weight polypropylene mesh, but then when we decided to stage it, we were able to get in some Phasix mesh, which wasn't readily available at our hospital. So we got that in and used that. So we used that time to get our choice of mesh for the procedure. I think the advantages of the Phasix mesh are just when it breaks down, it's the components have got some antimicrobial agents to it. So I think that's an advantage. Once you've had a contamination, it's never clear. No matter how many antibiotics you give it and so forth. So the long-term effects of biofilm are always going to be there. So anything that can diminish that is important. So I think, as Rod Jacobs was saying, it's, smoking and all that, it's all those 1% which add up to give you a good outcome. So, it doesn't really matter what the big studies show, but it's the little bits, the attention to detail that improves these outcomes. And I think that those little things are what differentiates the top hernia surgeons in the world, such as Todd Henneford and Eric Pauly and yourself versus others. And I think, we need to learn and to use those characteristics, and to improve our hernia outcomes.
Hopefully, I'm hoping that this is not something that none of us see on a regular basis. So what made you, have you done this before, or was this the first time, or just it's a slightly gutsy thing to do? Is that a fair thing to say?
Well, this is the first time we had a one in when we were doing ETEP, and that was always the concern when we started doing ETEP. So it's something that we've discussed, and that was, when we do an intraperitoneal operation, and we have a enterotomy without spillage, we close it, we wash it all out, and then, you know, in optimized patients, we continue the operation and get into the subrectus plane. And, you know, we're hoping that because it's now a virgin territory and it's not going to be as contaminated. But if you open directly into the subrectus plane, then theoretically that's got, you know, bit of contamination in it. So it's all about the load of bacteria on your landing zone. I mean, that's how the clinical microbiologists think. You know, it's all a balance between the bacterial load versus the ability of the patient to fight that bacterial load. And so, you know, the greater the load where the mesh is, the greater the issue. So I've always had a concern about it, and my plan was, if it did happen, then maybe to back off and just give it a few days, watch the patient, and then go back and put the mesh in.
Yeah, lovely.
I've
Thank you.
got no strong evidence about that. It's just on a theoretical basis and speaking to the microbiologists and others.
Yeah, okay. No, definitely something to think about. Lovely. All right, let's keep moving. So, like I said, it will be an exciting session. We have a surprise visitor. So Ramesh is going to present the next case. So if you're ready.
Yeah.
Over to you.
Yeah, is my thing visible?
No, sir.
Not yet.
Okay. There is some problem. Now it's flowing. Is it visible? Not yet.
No, sir.
It's showing open system preferences. What do I say? Hello.
Would you like to share the PPT with me? And should I share it?
To Swapnil?
Yes, sir.
Okay, then you can take one more case and meanwhile I'll send you.
Sure. Okay. All right. Brajesh, while we're sorting out some technical issues, can I get you to talk about groin pain is a pain up the butt, which
yeah,
I
good
may
afternoon.
not be doing surgery correctly. I don't know, but tell us tell us about it.
Yeah, good afternoon, sir. Good afternoon, everyone. Yeah, my talk is with the Vama team. I guess they'll just start in some time.
Sure, we'll start with that.
Fantastic. Right, are we moving or?
There's no sound coming.
Yes, sir. We'll just check. So, just a moment.
Greetings to all my respected seniors and my dear friends. Today I'm going to talk on chronic post-operative inguinal pain, why it happens, and what we can do to prevent it. Every once in a while, we get a patient who sits in front of like this during follow-up, and we wonder what went wrong and why. This is my case where a 60-year-old male, known diabetic, underwent left open inguinal hernia repair 7 years ago. He had some amount of pain and discomfort in the left groin since then. He sought help multiple times, but no benefit. Recently, there was increase in the severity of pain and his daily activities were affected. This is his DMT showing pain in the root of the scrotum. Rest of the areas were normal. A CT scan done here shows a mesh in the onlay position. There was a left recurrence. There is a primary hernia on the right side. Radiologist also reported some amount of inflammation at the inferior edge of the mesh. We had a discussion. We plan to go ahead with mesh explantation and left ileoinguinal ileohypogastric neurectomy. We went ahead with bilateral tap repair for his recurrence. During the tap repair, the left genitofemoral neurectomy was also done because during the explantation, we saw the vas was densely adherent to the mesh. Coming to the problem of chronic postoperative inguinal pain, the range of incidence varies from 0 to 63 in the worldwide data, which is due to variation into the definition, endpoints, and methodologies of the study. 10 to 12% of these patients have a moderate to severe chronic pain. 0.5 to 6% patients have been affected their daily life. How do we define a chronic postoperative pain? Chronic postoperative pain is a pain that persists at least 3 months after surgery, pain that was not present before surgery, or it has a different characteristics. There is an increased intensity from the preoperative pain. It is localized to the surgical site and to the referred area, and all other possible causes has been excluded. Few surgeons advocate 6 months time period to allow a postoperative mesh-related inflammation to subside. Coming to different types of postoperative pain, there is a somatic pain, also known as periostitis pubis. It is localized to pubic tubercle, and it happens due to damage of the periosteum of pubic tubercle from deep medial anchoring sutures or tags, as we can see in this MRI. Neuropathic pain is pain which happens due to injury to the nerves. This kind of pain is usually in sensory distribution of the affected nerves. Most commonly involved nerves in open repair is ileoinguinal, ileohypogastric, genital branch of genitofemoral nerves. In laparoscopic approach, nerves also involved are femoral branch of genitofemoral nerves and lateral femoral cutaneous nerves. Femoral nerve may also be injured during open and lap repair due to overzealous dissection and fixation, which leads to motor deficit. Nerve injuries can occur intraoperatively or manifest postoperatively. Mechanism of injury in such cases are either direct or indirect structural damage and entrapment injuries caused by suture or fixation device, folded mesh or meshoma, perineural inflammation and scarring. Here we see few examples where the ileohypogastric nerve is being entrapped in a suture. We can see a non-absorbable tag coming very close to femoral nerve. This ileoinguinal nerve is entrapped in the scar of the mesh. This is an excellent example of how a folded mesh or meshoma looks like. Another example where hernia plug has caused an inflammation in the surrounding area, which has involved ileohypogastric and ileoinguinal nerve. In a lap repair, mesh is directly placed over a bare genital nerve, giving rise to arcalgia and sexual dysfunction. Another type is nociceptive type of pain. This pain results from tissue injuries and the local inflammatory reaction, which is mediated by endogenous inflammatory mediators, which acts on these nociceptors. In this MRI, we can see an extensive fibrosis present in the space of Retzius and surrounding the mesh. Visceral pain happens when there is an intestinal, spermatic cord, or periurethral injury or involvement. In this case, similar to our case, we can see the explanted mesh is densely adhered to the vas, which was giving rise to the problem. Another example of missed bladder injury during a large direct hernia. Recurrence of hernia is one of the most major causes of post-operative inguinal pain and discomfort. There are various reasons for these recurrences, which we can discuss later on. A missed lipoma of cord or a retained lipoma of cord is another reason giving rise to increased pain or discomfort during postoperative period. Chronic postoperative inguinal pain is multifactorial, and it could be a combination of multiple causes which can give rise to this pain, like a meshoma with recurrence. Risk factors for chronic postoperative pain can be divided into preoperative, intraoperative, and postoperative risk factors. Female gender, young age, high intensity preoperative pain, recurrence hernia, open hernia technique, heavyweight mesh, less experienced surgeon, early post-operative pain are strong indicators that this patient may develop post-operative inguinal pain. Henry Hoffman et al. Has shown that smaller inguinal hernias are independent risk factors for developing chronic postoperative inguinal pain. So all important question is, how do we prevent such things from happening? Hernia Search Group has presented international guidelines on groin hernia management, which has laid down few specific recommendations. So preoperative strategies, patient selection and procedure selection is the most important thing as always. You have to tailor your approach depending on patient factor, hernia factor, and of course, the surgeon factor. Your expertise, skill sets, your infrastructure matters. Open, laparoscopic, and hybrid approach all gives an excellent result, provided you choose wisely. Evaluate each and every patient for risk factors as we have seen before. Preoperative counseling and informed consent plays an important role in patients with the borderline risk factors. Coming to intraoperative strategies, knowledge of anatomy is equally important along with neuroanatomy in both open and laparoscopic approach. Anatomical variations in the origin of the nerves and their course has been mentioned in details by landmark papers presented by Wolfgang Ranpold, P.K. Amit, David Chen, and others. David Lurie in his videos have shown various microfacial layers in preperitoneal region and transversalis fascia. Preserving these layers over iliopsoas muscle and nerve prevents direct contact between mesh and the nerves, reducing the incidence of chronic pain. Complete and adequate dissection to achieve critical view of myopectineal orifice should be done for adequate mesh overlap all around. This prevents recurrence as well as folding and crumpling of mesh, reducing the incidence of postoperative pain and discomfort. Importance of handling the vas gently in open as well as laparoscopic repair cannot be emphasized more. It reduces the incidence of orcalgia and sexual dysfunction. Prophylactic neurectomy is not advisable. A neurectomy during surgery is recommended only if there is an iatrogenic nerve injury or if the nerve interferes with mesh positioning. When it comes to choice between a lightweight or a heavyweight mesh, the data is not very useful, but some studies have shown some short-term benefits of lightweight mesh over a heavyweight mesh in open surgeries. For tip and tap repair, there is no relevant difference in the long term. But the recommendation is to use so-called lightweight mesh, although data is not very helpful. Data on the choice of fixation methods is very clear. No fixation is advisable on the pubic bone. Rest of the area, you can use a traumatic fixation like glue or very minimal fixation. In the post-operative stage, a robust follow-up and evaluation protocol is equally important. Standardizing the assessment tools like visual analog scale and dermatome mapping and using it as a common template for all CPIP data is helpful and in defining the problem and finding a way out universally. Lange et al. Has shown the experience of surgeons has a very positive influence on the outcome. So learn each and every step diligently, get a mentor, and as we all know, there is no shortcut to success. And then someday, I hope I get a patient like this. Thank you. Thank you very much.
Wonderful presentation. I'm going to ask just a couple other questions. Obviously, chronic groin pain is near and dear to my heart. So tell me, when you see these patients, you obviously had a patient that had a recurrence in a previous onlay repair. How do you decide how you're going to repair the recurrence and whether or not the mesh needs to come out? And then choosing your neurectomies, because I know that Dr. Chen is now into a little bit more of these isolated neurectomies if you can achieve appropriate pain resolution. So how do you kind of work through the process and what is the best operation? Because oftentimes these require like a combined lap and open approach like you showed.
So basically in this patient, if it was just plain recurrence, I would have gone tap and I would have touched, I wouldn't have touched the open previous mesh. But because this pain, as he said, since the last repair 7 years back, he had this discomfort since long and he had sought help multiple times. Plus, he was a diabetic. Radiologist reported there was some kind of inflammation in the inferior edge of the mesh where vas comes out and goes into the scrotum. So that was when I decided he might require neurectomies. I decided to send him to a pain clinic, but I think he was too much frustrated with all these multiple attempts. So he said, if you think explanting and neurectomy will help, please go ahead. I don't want to suffer more. So that is why then we had to go in. And because since we had opened, we had performed this ilioinguinal and iliohypogastric neurectomy at that time. And because his vas was very densely adhered at the area where radiologist has reported as such for his vas was attached to the mesh, that is where I decided, let us go ahead and do a genitofemoral neurectomy on that side also. And then we performed it is already 2.5 years now for follow-up with this patient, and he's very regular, comes almost every 6 months, and he's very happy and satisfied. So I guess it worked.
Oh, well done. It's so disabling, isn't it? That's the problem. So,
yeah.
All right. Well done, you. All right. So is Ramesh ready? Ramesh?
Sir, we'll go with the second presentation. I'm on call with sir.
All right. So is that Anmol Ahuja? So Anmol will run with yours. Fantastic.
Hello.
Hello.
Hi, Dr. Harsha. Good morning, Dr. Charlotte. I'm speaking from my institute, Sir Gangaram Hospital, New Delhi, India. I'm Dr. Anmol Ahuja, consultant laparoscopic surgeon. The topic of a presentation is IPOM mesh-related complications. We all know that mesh can lead to several complications. Ample literature is there which has described mesh-related complications in different planes, but literature on IPOM-related per se mesh complication is scattered, and that may be underreported too. But one thing is for sure, whenever these complications, intraperitoneal complications occur, it is usually involving multiple organs and usually requires multiple stage surgeries to bail you out. What can be the type of presentation? The presentation can be as mesh infection, mesh migration, meshoma, intracutaneous fistula, obstruction, or fixation device related lesions. So I'll be presenting few videos. Not presenting literature on this. I'll present some videos. The first one is on intestinal obstruction post IPOM due to mesh related band. The video was contributed to me by my friend Dr. Naveen Alexander. So it's of a patient who underwent IPOM plus surgery with a 20 by 30 composite mesh. It was a large hernia, and the patient later presented with obstruction to the emergency. In emergency, CT scan was done, and we were able to see some inflammation around the mesh lesion. We were able to see some tackers and dilated bowel loops. X-ray abdomen showed dilated bowel, small bowel loops, which was suggesting of intestinal obstruction. So once a diagnostic lab was done, there were several adhesions present with the mesh as well as with the tackers, which were taken down, and there was a band present between the bowel as well as the mesh. Here you can see the dilated bowel loop, which was getting transit into a collapsed bowel loop, and there was dense, thick adhesion present with the mesh. This dense band was additionalized with the help of scissors, and after removing the band, the bowel was freed and the obstruction was relieved. We were able to see peristalsis in the complete bowel loop, and this is how the patient responded well and was relieved of obstruction. So like intestinal obstruction, the other complication which may arise can be of intracutaneous fistula. This is a collection of few pictures by my colleague and friend Dr. Vikas Singhal. So this was a case of intracutaneous fistula with multiple openings with discharge around. And here you can see that the interface between the mesh and the small bowel is not very clear, and the bowel is completely adhered to the mesh. Diagnostic lab showed dense adhesions of the omentum as well as the small bowel. And we were not able to remove these adhesions very well, and an open approach was taken up. Here you can very well see that the small bowel is opened up, and this was the fistula tract, which was sending out some purulent material from the skin. Once this was explored, we were able to find a mesh, crumpled mesh, which was partially eroding into the small bowel here, and this small bowel loop ultimately had to be removed along with the mesh and the part of mesentery and the omentum. And the intestine was reanastomosed and patient was closed primarily. Similar cases, other cases are there where we can see a lot of enterocutaneous fistula. As it's a high volume center, Dr. Vikas, he commonly encounters these patients. And here again, the bowel is completely adhered and forming a fistula with the mesh. And the complete complex of mesh as well as the intestine was removed in total. So this is one spectrum of the complication, like obstruction was one spectrum. These type of surgeries can be devastating for the patients. And these intraperitoneal meshes, though they say are adhesion resistant, but they are not adhesion immune. So my next video is on a case of mysterious cyst. For this video, I'd like to thank Dr. Palanivelu and Dr. Pinakdas Gupta. In this video, this patient presented with a huge cyst in the abdomen. As you can see from the CT, we were able to see some tacks here or there, and it was a huge cyst somewhere near the abdominal region. This was the only complaint by the patient. So once the CT was reported, they reported it as maybe a mesenteric cyst, but it was quite unlikely as we were able to see some tackers here and there. So this was the reporting. They reported as a possibility of hydrated cyst or a mesenteric cyst. Once we did, we went in and did a diagnostic lab. All the small bowel and the omentum was divided and taken out, and ultimately a large cyst was seen hanging from the roof. So Dr. Palanivelu decided to put a trocar into the cyst and aspirated all the contents. It was purulent, around 2 liters of purulent material came out. And concomitant diagnostic lab was performed, and we can very well appreciate that the cyst got collapsed. And now the scope was introduced into the cyst, and we can very well appreciate a mesh which is not integrated at all, and a lot of tackers here and there. And this mesh which got infected and formed this infected cyst. So ultimately, the mesh as well as all the tackers were removed, and a drain was placed into the cyst, and the patient was discharged. So this was the complete mesh which was removed, and this is the amount of purulent fluid which was aspirated and sent for culture. The patient was discharged, and later the drain was removed on the 8th postoperative day. The culture showed E. coli and Klebsiella as well. So another 2 short videos which I would like to show are the additions to the fixation devices. So this is a dense addition to the tacker. You can see very well the bowel was completely adhered, and even while the sharp dissection, there was muscular tear on the small bowel. So things like this can lead to bowel injury later on, and sometimes formation of band and obstruction. A loose tacker in the peritoneal cavity has lead to banded obstruction. I have seen such kind of videos also. The other one is this video, and this is courtesy Professor Om Tatia. So this patient came with obstruction after IPOM, and there were a lot of additions to the mesh. So once we started dividing these additions, we were able to appreciate that the mesh is the bowel and the omentum is completely adhered on the abdominal side of the mesh, while the mesh is easily coming from the abdominal wall side. So it has not at all integrated into the abdominal wall, while all the additions on this side have formed very dense additions. So on further probing, we were able to appreciate that this was a PTFE mesh which was by mistakenly placed in the reverse direction, and the non-absorbable area went towards the abdominal wall, while the non-absorbable area went towards the bowel and the non-absorbable towards the abdominal wall. Hence, the mesh, we were able to excise the mesh completely without much problem. So these were few videos of complications which I was able to gather from my colleagues and friends, and I would like to thank them all. So to conclude, placement of mesh intraperitoneally is associated with its own sets of problems. So dual layer meshes are not immune to adhesion formation and related complications. An effort should be made to place these mesh extraperitoneally as far as possible. And as we all know, that is a better place to put a mesh. Thank you.
Wow, short and to the point. Nice. That that late infected seroma was nasty. All right. Okay, I think we have Ramesh ready. So Ramesh, can we?
Yeah. Are you seeing my screen now?
Absolutely. Well done.
Okay. Fine. So I thank the organizers to give me this opportunity. This is a very sad story of a patient who had some complication. So I bring greetings from Mumbai. Now this is a patient who is a 55-year-old female, BMI 29, non-smoker, non-diabetic. And she came with a bulge in the right abdomen with a discharging sinus since 9 months. So this is how there was a bulge over here. And you can see there was some dressing done. So there was a sinus over there. Now, in her past history, surgical history, she had an hysterectomy in 2010, that means almost 11 years ago, and had an incisional hernia since 2013. An E-TAP TAR was done in December 2019 for a 7 centimeter midline hernia. And she had a post-op collection 1 month after the surgery, which was aspirated, but then it grew acid-fast bacilla and she was put on AKT. However, she did not respond. She refilled and pigtailed in February 2020. So everything is happening in the month of about 2 months after surgery. The pigtail was removed because it did not drain much, and then she formed a sinus. So this is how she presented to us with after the dressing removed. This was a sinus. Now, after she came to me, we did a CT scan, and you can see here on a CT scan, and I would see what a disaster you will see.
Do you often see acid-fast bacilli? That's crazy.
So this patient now, see, it'll start showing up now. You can see here there is some recurrence. It's a huge recurrence now. And you can see some collection here with a mesh. And as you go down, you also see another hernia over here. So now she has got a 2 hernia and a mesh which is infected. Now this is a story within a year of surgery. And this is the longitudinal scan. Sorry. And again, it is showing a huge hernia on both sides. And there is a mesh, infected mesh over here. So she underwent, ultimately we operated her in December 2020. That means almost 9 months, 10 months after surgery. We probed the sinus, we could feel the mesh. And then we took a vertical midline incision. The pus was drained and sent for all cultures. So we basically, in our part of the world, we get atypical mycobacterial culture. So it was sent for typical atypical mycobacterial cultures. And the entire mesh was excised. So we could remove this entire mesh. Of course, there were a lot of difficulty. And while taking it out, in fact, we had plenty of posterior rectus sheath tears. So we just closed the abdomen primarily with just the sutures. Did not make any attempt to do the hernia. There was almost the full mesh that came out. And the sinus was scored out, midline wound was closed, and the sinus wound was picked, this thing. Now on a microbiological culture for Mycobacterium kansasi, they could grow. And that was sensitive to clarithromycin, amikacin, and linezolid. But it was resistant to quinolone. And she was put on amikacin 500 OD, clarithromycin 500 BD, and linezolid 600 milligram BD. This went on till the wound started drying. She started healing. And this after 3 months when we repeated the CT, the hernias are there persisting. In fact, it has increased in size now.
on both sides, but there is no collection. So this patient actually now is a infection free. So we stopped the, so this is how the picture was, and the sinus healed, and the patient then, the antibiotics was stopped. Now this is after 8 months. He came to me just about little time back, and again with a huge bulge. And this is a third CT. Right now she has got a lot of dragging pain, and practically she has got so much evisceration, even any abdominal belt doesn't fit her. And this is a longitudinal scan. And if you see here, so this is a semilunar blowout on both sides with a huge hernia. So my question to the audience over here is, when do we operate now, if at all we operate? This is almost now, how much, 8, 9, 10 months after surgery. What surgery will we do? When will we do? And could this whole episode be avoided? Now that's the question that has to be asked. Now I just actually probed to the surgeon who had done this ETAP-TAR, and I was really surprised to see that, you know, he had just seen few videos on YouTube and attempted it. So in fact, I mean, the message that I want to give is that the AWR procedures are not like Halstead's principle where you see one, do one, teach one. It has its own learning curve, and it requires its own sincerity in performing it. Thank you.
Oh, it's yeah, always ask someone to supervise you when you're first starting something new. I think that's the old see one do one is well in the past. So where do you think the bug came from?
So in here, you know, people do not autoclave the instruments. Many of them put it in Sidex, glutaraldehyde. And these atypical mycobacteria specifically, they do not die with the Sidex. So
Right.
This is the one shortcut which has been taken. Of course, we are now, as an AWR-SC, we are working very hard and taking and you know, telling people to use only autoclaved instrument. And second thing, of course, the training. You know, this man actually, for a 7 centimeter defect, now he has created one 14 centimeter, another 7 centimeter defect. And now probably, you know, it's very difficult to repair it by any surgery.
It makes it harder. Charlotte, have you had any experience with acid-fast bacilli in your wounds?
No, we definitely don't have any mycobacterium here. I mean, you have like the MRSA and stuff, but I certainly would be very nervous with some a mycobacterial mesh infection. How long do you leave them on antibiotics for?
How long?
Yeah.
How long what? Beg your pardon?
Do you put them on antibiotics for?
Yes, so we normally give it for, I had involved the infectious disease specialist, and they say that it has to be given minimum for 3 months or till your images do not reveal any collection. So we stopped it after 3 months, but then I was a little worried. So after 8 months, I repeated the scan and again it did not show. So probably now we have got rid of the infection, but left with the huge hernias. And
So the total treatment time was 3 months.
Yes, 3 months.
Wow.
3 months. You have to be amikacin for 3 days. So therefore, these are the patients who need a CBC and all their renal function tests periodically, because these are all very dangerous drugs to take it for a long time.
I must say, when we started planning this meeting, you know, we were planning it for Halloween, which seemed rather appropriate. So there we go.
The original title was going to mean Halloween horror stories, but
absolutely, and I think we're living up to that.
There quickly enough.
All right, let's keep going. So thank you, Ramesh. Dr. Kula, Samia Kula, are you ready to present on recurrences after IPOM?
I have more horror stories to continue with. So I think they have my presentation. Can we please start, Swapna?
Yes, ma'am. Yes, ma'am.
In India, and a very good evening to people in New Zealand. I'm Dr. Samia Kula from Bangalore, India, and I'm here to talk about recurrences after IPOM, what's contributory, and how to mitigate the risk. Laparoscopic ventral hernia mesh repair is first described by Leblanc in 1993. And ever since then, there has been controversies marring this kind of repair because of the intraperitoneal placement of the mesh. But IPOM is here to stay because it's easy, it's fast, it's easily adaptable, a lesser steep learning curve, does not require a big team to do it, and has fast recovery. Pain, though, is very significant post-IPOM, hence the question marks next to the fast recovery. The intra-abdominal complications have already been dealt with by Dr. Anmol, and I'm not going to delve into them. And recurrence rates are what has to be discussed now. The causes for recurrence in laparoscopic ventral hernia repair can be patient factors, technical, or post-operative factors, though the main which we will discuss today are technical. Now delving into the real life case scenarios directly. And this is a 12 centimeter intraperitoneal mesh, a standard IPOM, which is being placed for this defect. Now, as you can see, there's definitely a discrepancy between the defect and the mesh. The mesh is centered only centrally, and the transfacial sutures were not taken. As you can see, this mesh is definitely not adequate for this kind of defect. Going on to the next case. This was a post-IPOM. You can see that the mesh has completely crumpled and gone off to one side, and a large recurrent ventral hernia is there, along with lot of adhesions of omentum as well as bowel. Moving on to the next case, where a standard laparoscopic IPOM mesh repair is being done, and you can see multiple ill-placed stackers. In an attempt to improve that, the tackers are being placed even closer by. Finally, too many tackers, not the standard double crowning. In this case, a large ventral hernia, where a lot of adhesiolysis was done, and because of a small enterotomy and suturing, the surgeon actually chose to put in a Vipro mesh. Now let's see how this Vipro mesh is put. The defect, as you can see, is not closed. The Vipro mesh is being picked up with the transfacial cranially without bringing the falci down. And post that, once the tacking is being done towards the left side and the caudal side of the patient, you can see that the bowel happens to be very close to the tacked area. Now please note the tackers which are being placed cranially are quite ill-placed, with the direction of the tackers not being okay, falci, like I pointed out earlier, not being brought down, and a very minuscule amount of the edge of the mesh actually being tacked. Well, that's when the surgeon realizes that the mesh has been tacked very caudally as well as to the left of the patient, and there's hardly any overlap. So an additional mesh, like a patchwork, is put. This is a proline mesh being put, and this again was picked up and fixed. So it can lead to this kind of central mesh failure. So coming to summarizing it, technically, if you want to talk about it, not closing the defect is one of the biggest factors causing a recurrence. Improper centering of the mesh, wrong size of the mesh, generally a smaller one is chosen. Overlap or tailored mesh can have fracture in between, and the hernia can creep in from that area. Improper placement of the transfacial sutures are very, very important, because that can cause traction in either direction. Very tight transfacial sutures causing necrosis in between the sutures, and hence transfacial site recurrence, and improper application of tackers. Going on to the evidence, size of defect, as early as 2002, it has been told that definitely exponential raise in the recurrences in case of higher size. In IHS guidelines by Bittner et al., even in obese patients and high BMI, big defects have been told can be dealt with IPOM plus. That was quite surprising actually, because I do not think that this will be followed in 2021. Defects closure when we come to, then in 2018, Rosenberg has actually published that there is a reduced risk of reoperation for recurrence if a defect closure is performed. Also, in 2020, an RCT, again by Rosen, has shown that defect closure is extremely important, significantly reducing early seroma formation and recurrences. Tackers, how many are too many? Now, this is a very interesting paper from 2021 by Chan et al. They have told that a standard IPOM will have a mesh to fixation to tacker ratio of more than 4:1. But they have suggested an intensive IPOM plus with a mesh to tacker ratio of less than 4:1. So 150 centimeter square of the mesh being fixed by 50 tacks. Again, probably take it with a pinch of salt. So coming to the ideal IPOM according to me. An IPOM plus definitely. The defect has to be closed. Proper patient selection. Not a very obese patient, medium to small size hernias. Making sure that the glycemic control is good. And the patient, if smoker, has stopped smoking. Fixation method, nay, I would say the technique is more important, meaning that whether you're taking transfacial, you're doing intracorporeal suturing, you're putting tackers, make sure your technique is proper. Omental curtain, I definitely feel is very important. If present for the patient, please place it in between the mesh and the bowel. A transversus abdominis block definitely work wonders in reducing the patient pain post-operatively and hence the recovery. And definitely a good counseling about the post-op care is important. Thank you very much. Good morning, everyone.
All right, Loa, lovely summary. Thank you. So it is interesting when the mesh fails that all of a sudden the non-adhesive surfaces start to come into contact with bowel, which always makes trouble. All right. Charlotte, any comments?
No, I also love that you still indicate that there's indications for intraperitoneal mesh. I think a lot of times people say it's absolutely bad, but I think it's actually, as you had mentioned, if it's done correctly and your technique is proper, it's probably a fine and safe operation.
I think it is like a lap chole. Like when you do a lap chole, you generally think it's like a very routine operation and many people take it very lightly. And that's when you end up having biliary duct injuries. Similarly, if an IPOM is taken too lightly, it can cause more damage than good. So definitely there are few indications. If you have just a 3 centimeter or 2 centimeter size hernia, you don't want to do an ETA paras, the patient wants an MIS, you don't want to do an open repair. In such cases, definitely IPOM has a role, but if done, it has to be done correctly. And most of the Indian patients, I would say, are quite well endowed. So you do have that omental curtain to place in between. And even though I think I've not gone into the literature for that, but placing this omental curtain in between the mesh, which is touted to be intraperitoneal, and the bowel would definitely give us a better, layer of safety in between, I would say, for lack of better terms.
Can I make one other point, Samaya? Getting back to your well-endowed Indian patients, I always think that the landing site's very important. And so when I do IPOMs, it's not that frequently these days. I certainly always take off the peritoneum and the extraperitoneal fat because I want to fix it to the muscle underneath. Do you think is that what you tend to do?
Yeah, actually, sir, when we do falci coming down and even inferiorly, if you feel that the fat content on the abdominal wall is quite a lot with the peritoneum, it would be a good idea to bear it. I did not go into it for lack of time, but I did have few videos showing the bringing down of the falci properly. And that's why I emphasized the small part in the last video that I showed. But yes, bringing down that fat would be important so that the mesh gets incorporated well.
Absolutely. Lovely. Samaya, thank you very much. So moving along, posterior dehiscence after ETAP, RS. Dr. Jain, are you ready? Almost.
Yeah, so good afternoon, everyone. And my presentation, I would like to thank the organizers for such nice event. And in ETAPs, we keep seeing PRS descents sometimes. So we have been using barb suture for PRS closure for quite some time now. Recently, we had a barb suture from new company and we used it. And in 2 cases, we used it and we had PRS descents. So I think it happened because of that particular barb sutures. Anyways, when I went on to see the video recordings again, I also made out that I have not used peritoneal bridges to my advantage. So I would like to share this experience with everyone, and I'll present these two cases. My case one. So this was a 50-year-old female who had an paraumbilical hernia. This is the surgical video. So the momentum was reduced, and we can see that this is an insufflation pressure of almost 14. Even at 14 pressure, the PRS could be brought closer easily. And this is the new barb suture which we have been using. But here, if I see, I have not used that peritoneal bridge properly and tried to approximate both the posterior rectus sheath edges. And this was at the end of the closure, and it is coming closely easily. And then when polypropylene mesh was used, and on second post-operative day, patient complained of some abdominal discomfort, not passing plateaus. So I did an CCT abdomen for this lady, and on seeing the CT, we could see that some small bowel loops are dilated, and when we went down and saw the CT carefully, there was a dehiscence in the posterior rectus sheath. So here is the dehiscence, we can see very well, and then interparietal hernia has occurred at this level. When we went in for re-laparoscopy, essentially the entry was lateral to semilunar line, as we have not done any TAR, and from there we can enter into the abdomen. And the entry was through open technique. So when we entered into the abdomen, we can see that there is a large gap in the PRS. That's why I say wherever I have taken that bites through that barb suture, it is cut through at all the places. So small ball loops were adhered to the exposed mesh, and this is the barb suture bridge which is still there, and these are the small ball loops adhered to the mesh, and gradually we reduced the small bowel loops and then divided this barbed suture and bring them down. So we assessed the defect. It was a large PRS defect, but the mesh was already sticking well to the anti-abdominal wall. So what we did, we tagged this defect, then we planned to cover this defect with a dual mesh. And we used a 20 into 20 centimeter circular mesh to cover this defect. So this 20 to 20 centimeter mesh comes in, and what was important was that to center this mesh to the new PRS defect now. And while passing the suture passer, we have to support our mesh. And then like routine IPOM, this mesh was used and it was tagged again. So patient had two meshes, and for post-operatively, patient had uneven full outcome, no seroma formation. And in 2 days' time, she became all right and was started orally and was discharged. So this concludes the first case. And again, the next day itself, I did one more surgery and used this barb suture again. And there was a 60-year-old female. She had a 3 into 3 centimeter umbilical hernia. On third POD, actually I discharged this patient on second POD. Patient was fine. On third post-operative day, she complained of pain in abdomen. So I did an CCT abdomen. So when I did the CCT abdomen, I could see that again in this lady, we had the same problem. Like the initial defect was just 3 into 3 centimeter, but when we see the CT abdomen, we can see there is a large gap in PRS. So it will come into picture now. So now here we can see there is a large gap in the posterior rectus sheath, and a lot of small bowel has herniated through this. So again, we discussed with the family that we have to do re-laparoscopy. So this time the patient and attenders, they refused the consent for using one more mesh. We could see that these small bowel loops are herniating through, and that the interparietal hernia can be seen here. So first entry was lateral to semilunar 9, and then other ports were placed under vision. And here we can see that momentum is sticking to the mesh there, and there's a large gap in the PRS. Here's the small bowel which has herniated and got stuck to the mesh. So again, one small bowel loop adhered to the mesh, and this was again reduced carefully. Since we went in on third day itself, again we had more or less no difficulty in doing the adhesive lysis. And here the small bowel loops was brought into the peritoneal cavity complete. Then now we can see there's a large gap. It was not there at the first surgery. And then as discussed with the patient and attenders, we had very little options what to do. So we had to remove the mesh completely. And the mesh was brought out. And the posterior rectus sheath which was remaining there was tacked to the anti-abdominal wall. And basically this patient is now left with suture repair only. Two cases like what we learned that as we all have been doing, tension-free PRS closure is a must. We have been doing this and wherever needed we are using TAR for achieving this. What I have not done in first case was to use peritoneal bridge to my advantage. But nowadays I am very careful, especially when I am dissecting, especially in primary hernias, extraperitoneal dissection I do very carefully, and I save as much as peritoneum possible. And then one more point I would like to point out is that ideal suture material. So in my unit, I have completely stopped using any barbed suture for PRS closure. But yes, I've discussed it with many surgeons and they are regularly using a barbed suture. So for me, any PRS closure is with simple suture now, and no barbed suture is used. And any patient, if we do ETAPs, they are usually very comfortable, no complaints. But if a patient is having vague complaints, abdominal distension, not passing flutters, we should have high index of suspicion that something might have occurred. And at least a CT abdomen should be done wherever there is a doubt. And at least we can rule out there is no interparietal hernia. If we find something, early intervention is must. What are the various options? Like if we find an interparietal hernia, usually IPOM is a bailout technique for us. And sometimes we might have to remove mesh as happened with me in this case. So with this, I'll complete my talk and thanks once again. Thank you very much for your patient listening.
It was a really nice presentation. I think as we start to do a lot more robotic retromuscular repairs, certainly that's something that is going to be or can be increasingly common. And I think people are starting to see these posterior sheath breakdowns a little bit more frequently. So I applaud you for coming up with ways to mitigate posterior sheath breakdowns. And on top of that, like you had mentioned, just a really high index of suspicion when your patients aren't doing well and to image early.
Yeah, I agree. I think that posterior sheath closure is the Achilles heel of all the extraperitoneal repairs, whether it's an open or a laparoscopic repair. I'm just wondering, Dr. Jain, your normal technique is just a Lambert type suture, so through and through and through. You don't try to do a sort of horizontal mattress or a Connell type suture to give yourself a little bit of pledget every time in the peritoneum. I found that's very effective at giving you a more substantial closure.
So my closures are usually with simple suture and simple. I don't do any mattress or anything there. So
I can highly recommend just simply doing a horizontal type mattress or a Connell where you go in, out, in, out, in, out, in, out. It just gives you basically a pledget with every bite of your suture.
Okay, so I'll try this next time.
Yeah. Rod, how do you think we, I mean, David Waddle was speaking about closing the posterior rectus sheath to avoid bulging. And here we have closing the posterior layer and still getting dehiscence. I mean, David, does that worry you, that you're closing the posterior rectus sheath and putting it under tension? I mean, I've always had concern about the posterior layer, actually it's fairly routine that we take down the sac and use that to reconstruct the posterior layer to make sure there is absolutely minimal tension on it. And, you know, we use Amentum and other ways. And as a last resort, we'll do a TAR. So, but I just want to understand why you've moved on to suturing the posterior rectus sheath.
It's the paradox of VTEC, but I'm certainly not doing it all the time. But I think if you really care about plicating and flattening out as much as possible, you can add the posterior rectus sheath closure, which Igor has started doing to reduce the amount of bulging. But for incisional hernias in obese patients where they're not so bothered about, then I'll still just close the posterior layer the safest way. So I'm definitely not advocating to always bring it together. I think I don't know the right answer, but.
So how do you choose that you're going to do it versus those who, because this is an important topic. I mean, Igor and yourself are advocating closing the posterior rectus sheath for cosmetic effect, while there's potentially a serious downside with intraparietal hernias.
Yeah. So I've only just started tentatively. I really haven't done it a large number, and I don't know the right answer. But you do have to just watch the tension while you're closing. If starting from the bottom and working your way towards the head, and if it is under tension, you may not be able to get it all the way together.
But then if there's more to it, then it might just be a big cough as a patient's waking up or straining.
And so Igor talks about very small, closely spaced bites, and making to take up the tension. It is a balancing act between too much tension and and then ripping. But these cases that we presented, I think, were primary hernias. It's a bit unusual. I don't know. I haven't had any posterior layer failures yet, I guess. So that's another thing. I don't know if it's always just tension, if there's other factors like coughing or obesity or failure, tearing through of if the bites are not placed through the sheath, maybe.
So watch this space.
Yeah, I don't know the 100% definitive answer. I'm sorry.
Thank you.
Well, I think this advocates for a close follow-up of your patients because, we really don't know what's going on. And so, I'm always so curious with ETEPs since it's a pretty new procedure. And so I often image those people early, and often if anything's abnormal, and then I see all my patients back at 3 months. The ETEPs, I actually an open TAR, I'll see it 1 month, maybe 3 months in a year. But the ETEPs, because I think, there's some parts that we just don't know and don't have a lot of long-term data about. I actually see them at 1 month, 3 months. I give them the option of the 6 month, and at a year I get a scan because I want to know what's going on. And a lot of times, especially with the intraparietal hernias, and, oftentimes they're a little bit of well endowed, or I forget what you call them. It was a great term. Patients, you can't tell. You can't tell if they have an intraparietal hernia. And so I think, if their insurance lets me, I think scans at a year and follow them 1 year, 2 year, 5 years is probably the best for these patients until we have some good long-term data.
So what are you going to do if you identify an asymptomatic intraparietal hernia 1 year?
So this is a great question. I operated on a patient that had an issue with pain and had a previous TAR actually, and I retarred him because at the end of the day, that intraperitoneal uncoated mesh is just going to lead to more problems. And so I'd much rather, when I see it, if there's any sort of indication, operate early, because I don't want to be having to deal with a bowel obstruction or a fistula. And so if I can control the situation and say, hey, you have this needs to be fixed. I know it's going to be a problem. I just don't know when. And I can kind of control the situation and do the definitive surgery up front. That's what I would prefer to do.
Okay, so even if they're completely asymptomatic, you mentioned that that patient had pain, but if it was completely asymptomatic, you would still operate?
I would see them a couple of times, but I honestly would try to convince them to get surgery.
Thank you.
All righty. So moving along, Dr. Kalika, when TARs get messy, and yes, they can get messy.
Good afternoon, ladies and gentlemen. I'm Dr. Vishakha Karikar from Mumbai, and I will be taking you through pitfalls of transversus abdominis release. At the outset, I would like to thank the ANZ and the AWR community for giving me a chance to speak on this topic. I will be taking you through what can possibly go wrong in a transversus abdominis release in the next 7 minutes or so. While the published outcomes of TAR from an expert center are favorable, there can be potentially devastating complications if a transversus abdominis release is done in a suboptimal setting. Coming to the literature review of this, there is a paper published in 2019 that shows a surgical site occurrence of 15%, a surgical site infection rate of 7%, and a recurrence rate of 4%. Now, the infection rate may be comparable to an anterior component separation, but of course, the recurrence rate is much lesser when it comes to a transversus abdominis release. There are a lot of complications that go underreported, so there is not exactly a number to tell you how many or what is the percentage of what can go wrong in a transversus abdominis release. One of the most common things that you do once you open the abdomen for a transversus abdominis release is a hollow viscus or a bowel injury. Just last week, we did a patient on table. We had taken a patient for what was going to be a transversus abdominis release, opened the patient, dense adhesions, no problem during adhesiolysis. As soon as we reduced the content from the sac in the right iliac fossa, there was a gush of turbid fluid. There was a dense adhesion between the bowel loop and the sac. Once we released that, there was a sealed off perforation that had opened up, which caused us to do a resection anastomosis of that particular segment. And hence, we could not do the transversus abdominis repair for that particular patient. What we need to look at is we need to do a complete adhesiolysis, but we need to do a meticulous adhesiolysis. Any contamination of the abdomen, you cannot go ahead, or rather you should not go ahead with a transversus abdominis release. Now, this is another thing that can happen intraoperatively. Have you ever dealt with a frozen abdominal wall? Now, this is a lady around 60 years old who had undergone a nephrectomy laparoscopically for a RCC, following which she developed an umbilical hernia. She underwent an IPOM someplace else, had a perforative peritonitis following that, had a mesh explantation, had a wound infection. As you can see, the scar looks very ugly, which is healed by secondary intention. All this had created a lot of havoc in the abdominal wall. Now look at her scans on the left-hand side. Is there a possibility to do a TAR in this? Almost not. We took her intraoperatively on table. We could not dissect any layers. No posterior sheath was found. We could not do a transversus abdominis release. So what we did as our backup option was we did an onlay repair for the patient. And this is her abdomen after 1 year. We did her in last December 2020. And this is a recent photo. She just came last week for a follow-up. She's fine. She's lost 10 kilos of weight. She's walking well. Her back pain has reduced and her abdomen now looks bearable. Coming to vascular injury, loss of planes. Now, vascular injury, most common is the inferior epigastric. If you inadvertently nick it, take the two ends and tie it off. Loss of planes is the most common thing that can go wrong in a person who's not used to doing a TAR. You may very well injure the linea semilunaris. That can cause lateral bulges later, or an advertent Spigelian hernia. You may go into the plane between the internal oblique and the transversus abdominis. You may go in the plane between the internal oblique and the external oblique, and then you have destabilized the entire abdominal wall. You can also cause an inadvertent diaphragmatic injury, which can lead to a Morgagni hernia. So you've caused two hernias while doing this, either a Spigelian or an inadvertent Morgagni hernia. The other thing that can happen if you're in a hurry or you're not used to doing this is either you have tearing of the posterior rectus sheath or tearing of the peritoneum. Now, when you have one hole in the peritoneum and you do not take care of it, trust me, those tears can go on increasing because you're flustered and you don't know what is to be done. One hole can very well lead to multiple holes, and then you have a big peritoneal rent. You can, of course, put a composite mesh or a vicryl mesh, but talking about the treatment is beyond the scope of this talk. So these are some complications, to name a few, while you are doing the TAR. The other complication is anesthesia related, that is rise in the airway pressure. Now, most of us who have been doing a TAR know what the P peak is, what is the baseline pressure, and what happens when you do a complete TAR. There should not be a rise more than 5 mm. That means that either your TAR is not complete, or you may have an abdominal compartment setting in later, for which the patient needs to be ventilated post-surgery as well. Coming to the complications post-TAR, one of the most common and dreaded complication is a posterior sheath disruption. This is what we've had in one of our patients a couple of years back. Patient was fine on table, everything went well, seemed like we had done a good TAR, a good repair. Patient shifted out to the ward, settled 2-3 days, she was okay, but not completely settling. Some abdominal pain, some paralytic ileus, not looking as comfortable as how a TAR should be. We scanned her, that is the photo of the scan, and we found a posterior sheath disruption. Now, when there is a posterior sheath disruption, there is no option but to take the patient back again. On table, if you've done an open repair, you can go ahead with the same incision. If you have done a laparoscopic repair, you can go ahead, put a scope, look at the posterior sheath, try a repair, and then do an IPOM. So we did take the patient, and these are a couple of pictures from that, where you do see that the posterior rectus sheath has completely given way in the center. That is where it happens the most. So we took the patient, did the adhesive put the bowel back in, and put a composite mesh, and then closed the patient. She did fine. She is doing fine now post-op, maybe I think a year or so. Now, not all complications are created equally. Skin necrosis actually should not be a common complication of TAR, but it is very well seen. Now, the photo on my left shows a superficial skin necrosis around the umbilicus area, which is the most common region for a necrosis, but we could manage this without having to do any surgical intervention. The one on my right doesn't look so pleasing to the eye. There is extensive skin necrosis of this patient. We hadn't raised flaps anteriorly, we hadn't raised skin flaps, though still this is what we landed up with. Most commonly seen, if you have a T-shaped scar at the region of the intersection, this is what you'll find. We had to debride the patient, 2-3 sessions of debridement and 2-3 sessions of VAC, and then do a secondary suturing. Thankfully, everything was in the superficial planes, the mesh was unaffected, and the patient is doing well. Of course, we have paralytic ileus, bleeding, intestinal obstruction, missed enterotomies, or an abdominal compartment syndrome. Now, we've also had a patient who had a post-operative hematoma. Patient was well, shifted to ICU post-surgery, and then after a couple of hours, the ICU intensivist calls us and tells us that there is around 300-400 ml of blood in the drain. Patient is hemodynamically stable. Had a look at her, no tachycardia, no hypotension, but definitely there is blood in the drain that is placed above the mesh. So there are two things. One is that we have damaged some vessel, left it, not seen it intraoperatively. The inferior epigastric artery or the vessels have been damaged, and or there's a ooze from the raw surface area of the extensive dissection that has been carried out. This patient did not require any surgical intervention. We did get a CT angiography to see if there's any active extravasation from the blood vessels. None was found, managed conservatively, patient fine, discharged. She still does come on follow-up. It's been 2 years and there hasn't been a problem. Now coming to late infections, late complications of TAR, one of the things is a mesh infection. Now, TAR mesh infections can be really hard to deal with. We did this lady in December 2020, and in February 2021, she came to us, as the picture shows on the extreme left, with 2 discharging sinuses along her midline scar. We treated her with atypical mycobacterial cultures after we swabbed her. Not settling, developed multiple sinuses again, got an MRI done, showed a collection over the mesh, but the mesh wasn't floating. We took her on table maybe February end, March, and opened her, gave her a good pulse lavage, got a plastic surgeon into the picture, and then did a VAC. She had to undergo 2 or 3 settings of VAC, if I'm not mistaken. And finally, at the end of that, the picture on my extreme right shows a well-granulated mesh. We did her secondary suturing in the month of March end. Patient is fine. She did visit us last month. No more discharging sinuses as of now. She's well, eating well. So this is another problem that we need to take care of. Obviously, there are seromas. Not all seromas need to be aspirated, but there have been incidences where we've got referrals from people who have done TAR outside, and they have come with large seromas. We recently drained a seroma of almost 1 liter. Patient was fine, but she always complained of a bulge. The doctor had waited for 3 months. There was no absorption. So we have to take care of all of these. Now, lateral bulges also is quite common. Any injury to the neurovascular bundles will cause an atrophy of the rectus muscle, which can also give rise to bulges. And the last point is a recurrence after TAR. Now, why do we get a recurrence after TAR? Where have we gone wrong? This is what we need to think. Why is this happening to us? Have we gone wrong selecting our patient? Because we do know that all patients who have a hernia do not require a TAR. Are we overzealous in our approach for doing a TAR? Is this an overkill for a small umbilical hernia of 4 or 5 centimeters, where we can offer them other options? Are we not pre-optimizing the patients enough? Are we looking at their sugar levels? Are we giving them a tight glycemic control of HbO and AC of less than 7? Are we looking at their respiratory parameters, giving them to do good breathing exercises, spirometry before surgery? Are we looking at their nutritional status? And most importantly, are we looking at what their obesity and what their BMI is? Are we operating patients who have a BMI of 50? If the BMI goes above 40, the percentage of recurrence is more than 50%. Is this where we are going wrong? And finally, are we operating patients with an end-stage hernia? There's a recent paper in literature about a concept called as end-stage hernia disease, where it would be probably better to leave the patient and we have not touched the patient for a hernia, which may be more harmful for her than letting the patient live with the hernia. Are we operating on such patients? We do really need to think about it. The other thing we need to think about is who should learn a TAR and how should one learn it? We do 2 TARs, we go for a 2-day workshop or a conference, and then we think this is it. I know how to do a TAR. And a TAR by no means is a small or a minor surgery. We need to be trained. We need to go and look at many more surgeries, assist many surgeries regarding a TAR, and then call somebody to help us during our first few cases. But this might be slightly difficult for us to accept that not every doctor, not every surgeon who does fix hernias needs to do a TAR. If you're fixing simple hernias and you are good at it, stick to it. If you want to get into complex abdominal wall reconstruction, we need to train ourselves better. This is a wonderful paper on transversus abdominis release. What are its real indications and where is the limit? There is a line in the paper that says, if TAR was one option that was durable and fit for all, that should have been the end of the story, but unfortunately it is not. This is a very, very recent paper on no winning in the battle of the bulge. Is this where we want to be? Because once we are doing more and more TARs, and we are doing it without any experience, people are doing it in suboptimal clinical settings, there are going to be more recurrences. We are going to have more pitfalls regarding transversus abdominis release. And then what do we do? This paper shows a recurrence rate of 20 to 27%, which is a lot. And if we do not take care of it right now, it will be slowly going up, and then we will have nothing left to offer the patient. And then we will be in a bigger fix than what it was before the transversus abdominis release. So just a minute to take home a message for us to realize that even though there are pitfalls of TAR, we could avoid them by pre-optimizing the patient well, getting help where it is needed, having a low threshold to call somebody saying we are in a problem, we are stuck, we can't find the planes, come and help us, or get somebody to help us during our first few days or first few surgeries, so that we will definitely win the battle of the bulge. Thank you so much. That is all from my side. Thank you very much.
Vishaka, that was lovely. Thank you. Thank you. That slide, that
Thank
last
you.
slide was terrible. So lovely. Charlotte, Rod, any comments?
I love what you said about getting help and making sure that you have, had enough experience doing complex abdominal wall. So my question for you is, how many TARs do you think you need to do before you can say, yes, I can do these on my own?
I think easily a 50. I think last week we did our 85th TAR, and I did that alone without the surgeon who always is there to assist me. And that is when I realized that no number is enough. Each time there is a different plane, there's more adhesions, a different defect. So it's just a learning process continuously. But definitely attending a 2-day workshop or just looking at a couple of TARs or assisting a couple of TARs is not enough. They have to go maybe 10, 20, 30. That's the number that we're looking at.
Yeah, I think the more you do, the more you know you don't know how to do them.
Oh, absolutely.
Absolutely.
Absolutely. It can be quite humbling. All righty, let's keep going.
Look, I just think it comes back to, as Dr. Urena says, it's knowing the anatomy and getting very familiar with getting into those planes and knowing where you are. So, yeah, look, it's a vexed question. And it's one of those things I was told as a young surgeon that you can see an operation done wrong 100 times and it's still not right. And until you see it done right the first time, it doesn't twig. So I think it's important that we do promote collegiate atmosphere and people go and visit people and learn how to do things and have workshops and stuff. It's not easy at the moment with the way the world is and travel being restricted, but we do have online access, and I think that people shouldn't shy away from asking questions about difficult cases and help. But I think you never stop learning.
No, absolutely. All right, well, let's keep going. So our last speaker for today is Bushra Othman. So 3 mesh infections, and I'm told Bushra is running this live. So over to you.
Thanks very much, Harsha. I just thought I'd test out the technological system to see if it would work out okay. All right. Everyone can see those slides without too much trouble?
No slides yet.
The back room have to let Dr. Othman share her screen.
Ah. Ruturaj, can we help Bushra to share her screen? Oh, lovely. Okay, right.
Yes, sir.
Thank you.
Yes, sir.
Thank you.
All right. Thanks very much. Good afternoon, everyone. I want to thank ANZ for the opportunity to present at today's conference. We thought, I'm one of the fellows down in Geelong, we thought we'd present 3 of the cases that we've had in the last couple of years that would be of interest to this group. The first case that I'll discuss is a 78-year-old lady with a very low BMI compared to what we're used to seeing down here. She's a non-diabetic and a non-smoker, which is almost unheard of in the hernia population. But certainly she has a complex surgical history. She'd previously had a Roux-en-Y bypass. She'd had an epigastric hernia that had developed from one of the port sites that was repaired with an intraperitoneal mesh. She then developed an incisional hernia and had a laparotomy as a midline incision with a very large intraperitoneal mesh placed. Subsequent to that, she developed an acute episode of an internal hernia and required emergency laparotomy, ended up needing 2 small bowel resections. And there was a mention in the operation report that the mesh was incised during entry, but there wasn't any obvious enteric contamination that was noted. And a few years following on from that, she developed bad cholecystitis and choledocholithiasis, required a laparoscopic approach to divide some adhesions, had her gallbladder removed. There was mention of an abscess between the gallbladder and the abdominal wall, and ended up having a T-tube repair of her common bile duct after an exploration. So she presented to us with an acute history of a right abdominal painful swelling. Certainly there was a palpable mass that was there with some mild inflammatory rise in her white cell count and CRP. She went on to have a CT abdomen, and we can have a look at some axial and sagittal views there that showed an abscess cavity within the right abdominal wall with some gas locules in it. She initially had an attempt at a percutaneous drain, which they only aspirated a little bit of blood, and then developed worsening pain and cellulitis in that region. So went to theatre for an incision and drainage. So she had a defect that was through the anterior fascia down into a moderate sized cavity with lots of pus. And on palpation, the posterior wall of the abscess cavity was felt to be her intraperitoneal mesh. There was a Penrose drain that was left in situ to allow the area to drain as necessary. And part of the mesh that was removed and sent for culture grew gram-negative organisms in the form of Klebsiella and E. coli. She progressed well after that while in hospital. She had an involvement of the infectious diseases team, was initially on some intravenous antibiotics, but then placed onto orals. And during this inpatient admission, she was planned for subsequent definitive excision of the mesh down the track. So she went downstairs to radiology to have Botox into her abdominal wall. She had 150 units in total bilaterally to give a total of 300 units, and went home with a planned return to theatre approximately 4 weeks after her Botox. Intraoperatively, we did a midline laparotomy. She had a complete explantation of her intraperitoneal mesh. There was certainly very dense adhesions between her small and large bowel, her omentum and her abdominal wall from all of those previous surgeries and also from the mesh infection. We found that the mesh actually wasn't really incorporated into her abdominal wall, but it actually fistulated into her cecal pole. Once this was removed, we did staple off part of the cecal pole where the defect was, but we felt that this narrowed the region too much. So she ended up requiring a right hemicolectomy and had a hand-sewn end-to-end anastomosis. There was a couple of previous abscess cavities in her right abdominal wall, which we'd cored out and left open to drain. We were able to primarily close her fascia without any tension using a small bite closure with some OPDS. Here I've got a video intraoperatively of the mesh being pulled out of her cecal pole. Some of you who may be on the ANZ WhatsApp group may have already seen this. Our only regret is that she didn't have a preoperative colonoscopy. We felt the endoscopic findings were probably something that would have been very interesting.
That is insane, I must say. Oh my God.
All right. So you can see in the left-hand photo that that's her primary closure of her fascia, and we had planned to do a delayed closure of her skin. So she had a back dressing put on, came to theatre 5 days later, Her wound was clean and healthy, so it was acceptable to close. She had a 15 Blake strain put into the subcutaneous space. The skin was closed with monocrol, and then she had a Prevena dressing over the top of that for a week just to try and help limit any potential surgical site infection, which is this dressing that's shown here. She recovered really well in hospital, actually discharged home day 7. She was seen in the clinic for the following weeks. At about week 3, developed a very small distal surgical site infection that required some simple dressings and some oral antibiotics, but she's otherwise done well. The second case is that of a 78-year-old gentleman who's an ex-smoker, also non-diabetic, extensive past medical history, including having had a previous aortic valve repair, had a Hartmann's for perforated diverticulitis, and then a subsequent reversal of his colostomy a year later. Had a midline incisional abdominal hernia repair with some mesh, as well as a previous left inguinal hernia repair with a mesh plug. He, in the retrospect, you can see potentially where all the problems occurred from, but I think no one really wanted to deal with the underlying problems. So he presented in February 2018 with a right abdominal wall abscess that on a CT scan was seen to be within his transversus abdominis muscle. He had an ultrasound guided aspiration. There was 55 mils of pus, which grew E. coli. He settled down from that and was discharged home on some oral antibiotics, had follow-up with one of the surgeons, had complained of a recurrent swelling in his abdominal wall, had a repeat ultrasound guided drainage not too long after that with another 35 mils of pus that was aspirated, and then presented a year and a half after that, or almost 2 years, with another large recurrent abdominal wall abscess. By this point, it had actually already caused a sinus to the skin and had begun to self-discharge. He went to theatre, had that area washed out, and they felt that there was an abscess cavity with the mesh palpable at the inferior aspect. Lo and behold, the problem did not go away. In July of this year, he presented again with a recurrent abdominal wall abscess, as you can see here on the CT images, which is now multiloculated, involving extensive area of that right side of his abdomen. He had an ultrasound-guided percutaneous drain inserted, and with the understanding that he would need a definitive repair. So he initially was not seen by a surgeon who was particularly interested in undertaking his case. And when he'd re-presented with a recurrent collection and another drain placed, we began the process of preparing him for his repair. He was seen by the infectious diseases team while an inpatient. He also had a physician review given his comorbidities and was felt to be an appropriate candidate for a large operation. He also had ultrasound guided Botox to his abdominal wall. They did 100 units bilaterally for us. He came back in a month or so after the Botox for his definitive mesh explantation. He had a laparotomy and complete removal of what was thought to be intraperitoneal mesh from his original operation. It's seen there in the top left-hand corner. The mesh plug from his left inguinal hernia repair was not seen to be involved and seemed well incorporated, so was not attempted to be removed at the time of this surgery. He had 2 abscess cavities on either side of his abdomen, in the right and the left, and there was certainly some purulent fluid surrounding his mesh at the previous stoma site. All of that was excised. His fascia was also able to be closed tension-free, as seen in that superior diagram. And again, he had a delayed primary closure of his laparotomy wound. Post-operatively, he did exceptionally well. He was seen a month after his discharge with an abdomen that's pictured there. There was no obvious recurrence of his hernia at present, and he was certainly not on any antibiotics anymore. The last case is that of a 62-year-old lady who is a smoker. Again, extensive past medical history, including previous gastric stapling, an open cholecystectomy, and then an incisional hernia repair through the midline with what was thought to be a large polypropylene mesh, potentially in the sublate position. And this was fixed with the longitudinal midline incision that you can see here pictured in the abdomen. She presented with an acute history of some right upper quadrant pain. And if we look back through her records, she'd actually been complaining of a palpable lump in her right upper quadrant for many months before that. When she presented, there was certainly a palpable mass that was tender and it's circled here in the right upper quadrant. And there was an area of induration that was seen. She went on to have a CT abdomen that showed what was initially thought to be a right rectus sheath hematoma, but certainly there was a lot of inflammation and some gas locules within the site. that was suspicious for an underlying abscess. She had an inpatient colonoscopy just to exclude that there was no underlying bowel involvement, and that was all normal. She had an infectious diseases review. She grew an MSSA from her ultrasound-guided percutaneous drainage of that abscess. Again, she needed definitive repair, so had inpatient Botox injection for preparation for definitive surgery. She went to theatre 2 and a bit weeks after her Botox, had a laparotomy, extensive adhesiolysis, and complete mesh explantation. The mesh was felt to be preperitoneal, and certainly there was a hematoma in the right retrorectus space that was drained. She had dense adhesions to her mesh. And as seen here, there was some loss of the posterior sheath from the excision or the mesh explantation from her right-sided abdominal wall. Again, her fascia was able to be closed without tension. She had a vac to her superficial wound and a delayed primary closure. Post-operatively, she was seen in the clinic at 3 months and then was felt to complain of a right upper quadrant bulge, went on to have a CT scan that, as you can see here, is pictured to show a 12 centimetre large right-sided ventral hernia containing small and large bowel loops, which she'd become symptomatic from. This has actually progressively enlarged over the last 6 to 9 months. Her BMI is 33. She's stopped smoking, which is fantastic. She did have a Botox injection this year in preparation for a robotic TAR to repair the hernia, but due to the COVID restrictions, her case never eventuated and she's still on the wait list. So I've just noted a few reflections from some of these cases and the things that we've learned, and much is what lots of other people have expressed today. But we felt that the control of sepsis really in the initial stages is important, and that can be done through a few different methods, either percutaneous drainage or an open drainage, depending on how the patient presents. Really, anyone who's had any history of abdominal mesh, you have to think of that as the culprit for a potential underlying infection. And then there's extensive perioperative preparation that the patients require, whether that be weight loss to optimize their BMI, smoking cessation, prehabilitation, or tight glycemic control. I think it's important to adequately counsel these patients. There's no one-stop shop or fix, and these patients are sometimes in it for the long haul before they get their definitive repair, so they need to understand that and be able to appreciate the complexities of surgery. We found Botox to be particularly useful in trying to facilitate abdominal wall closure. Certainly staged procedures are required to obtain a definitive and a durable repair. And through the use of the VAC dressing to the superficial wounds and a delayed primary closure to the skin, we've been able to show that that's been helpful to reduce the surgical site infections. I think in some of these complex cases, they can be quite tiring and the adhesions can take numerous hours to dissect. It's certainly important both for the physical and mental status of the operating surgeon to have a second surgeon available or involved with the case. And a forum such as this or the International Hernia Collaboration is a great way to be able to discuss these complex cases and to obtain feedback from people about what they might do. Thank you.
I think I need a Bex and a lie down. All right. No, great. Crikey. Just, I'm still getting over this, the visions of that. The bowel, the mesh must have gotten to the colon and then start being peristalsed, peristalsed slowly down into it. That's just crazy. So, but definitely these are not for the faint-hearted by no means.
I'm not sure whether people are going to think that we're wanting to start a series down here in Geelong and they should just send all these cases down to us, but that's certainly not what I'm advocating.
Yeah, I am. I can go down the highway from there for a change.
Not the atypical microbacterial infections, though. We don't want to look after them, please.
I think there's a book, from the College of Surgeons Library, there's a book from the 1960s and it's aphorisms and quotes for surgeons. And there's one which I love, which is, there is a special place in hell for bariatric surgeons and the hernias they create. And that is so true. It is so true. As a bariatric surgeon, it is so true. So, all right, lovely. Charlotte, any comments for Bushra?
That was wonderful. I'm just curious about, I know we hear a lot about using Botox to close complex abdominal walls when we're doing a definitive reoperation, but your utilization of it just to get people closed when you're removing mesh, how did you kind of figure out that that was helpful, and what is your experience with that?
I can talk because Bush was muted. We've used it and we've been able to get them primary closed, and we don't know, if we hadn't used it, whether we would have been able to. So, I mean, we've got the Macquarie Group, which have led the way, in Australia with their Botox research. So they've got a bigger experience, and people like Rod have suggested it's a potential use for closing, open abdomens in, trauma, and so that was the thinking, to use it here for, being able to close a difficult abdomen without using a component separation.
How long do you think you should wait from Botox injection to having a crack at closing? How long do you think it takes to work? 3 days? 4 days?
2 weeks, minimum, maybe.
2 weeks?
I aim for 4 to 6, but I think it starts working immediately. Just sort of.
We've found with the open abdomens that you probably start getting some effect at 72 hours. It doesn't reach its maximal effect probably for 2 to 3 weeks. But I think that if you're doing it in this sort of staged procedure, I don't think that there's any real downside to it apart from the cost. And the cost is pretty minimal compared to keeping someone in hospital with a pussy infected wound or an open abdomen that you can't get closed, or you close them under tension and they have respiratory difficulties. So I think that there's lots of upside and very little downside apart from the getting someone to put it in and the cost.
Yeah, the more we use it, the more used the radiologists are to doing it. So we use it for lots.
Charlotte, I mean, it's probably label use in the US. Is it to stick it in someone's abdomen in this circumstance or not?
I think it is variable, depending on insurance providers and stuff like that. A lot of times insurance companies won't pay for it, and that's the problem. But I also love that you're using it. I think there's been a lot of concerns about using it in a potentially contaminated or infected field, but clearly you guys are doing it and it's working great. So
yeah, we've not had any issue. Well, I've not seen any issues with it, and use it routinely in people who have laparostomies that often come to me when they've been open for quite a while, and we just get them to put it in, and it helps facilitate the closure. I'm convinced it causes them to have less pain, and I suspect that it probably reduces their respiratory complications when you actually get their abdomen closed. So, and I think doing these staged closures is the right way to go. And you'll occasionally get a patient who doesn't get their hernia back and they're fixed, but most of them are going to require hernia repair. But at least you've got time to temporize and plan what you're going to do in the long term, and you don't burn any bridges with a bit of luck.
no, it's a really good experience.
Oh, sorry about that. No, fantastic. So that brings our meeting to a close. So I'd like to say thank you for everyone that's contributed and given talks or chaired a session. A huge thank you to our sponsors, BD, Gore, Medtronic, and Baxter for providing the funding so we can run these. This is the third one that we've run, and hopefully we'll get a fourth one up and running. I'm sure we will. We were just chatting online about it before, and maybe it might even be face-to-face, and we might be able to get some people down to visit us. We'll see what COVID has to offer us next year. But thank you very much, and thank you to Rod for putting the program together. Rod, is there anything you'd like to say?
Oh, no, I was just going to say thank you to all the people who've talked. Particular thanks to Charlotte. It's after midnight there in Portland now, so you could have spent your Friday night doing something much more fun than this, I suspect. But anyway, thank you. Much obliged. And to all the people who have contributed, thank you very much. It's been a good day, and by and large, it's turned out as I'd sort of anticipated in terms of working out what the complications are, how we can stratify those risks, how we can mitigate those risks, and then how we can deal with the complications when they occur, hopefully with less frequency in the future. That's it. Thank you very much. Thank you all for attending.
Thank you. Good night. Good morning. We'll catch you next time. Cheers.
Thanks, guys.
Take care.
Yeah, bye.
Bye.